Good morning. I hope all of you joining us today are safe and healthy. But if any of you are not, we truly wish you the best. My name is John Etchemendy, and I'm one of the co-directors of Stanford's Institute for Human-Centered AI, or HAI as we call it. I'm here with my co-director Fei-Fei Li, and we're pleased to welcome you virtually to Stanford University and to HAI's Spring Conference on COVID-19 and AI. The subject of our spring conference was originally going to be the intersection of neuroscience and AI. But with the onset of the pandemic, we were faced with a decision. We could either postpone the conference until fall, or see if we could convert it to an online format. In the end, we decided to delay the original conference, but to see if we could provide a more urgent public service. A conference focused on the many ways that AI can be used to better understand and address the multiple threats posed by COVID-19. Given we had only weeks to plan, it's a tribute to the public spirit of the research community that we could assemble the remarkable expertise represented on the agenda today. I'll let our other hosts describe the topics and format that we have planned for the day and the mechanics of the individual sessions. Ironically, the fact that we were forced to make this a virtual conference opened it up to many participants who would not otherwise have been able to join us. While our original conference was sold out at less than 800 attendees, over 10,000 signed up to join us today. And since the attendance is not limited, we expect many more to drop in. We're delighted to welcome you all. Fei-Fei, would you like to add anything?
Thank you, John. It goes without saying that I wish we were gathering under very different circumstances. In just a matter of weeks, the world around all of us has changed. Personally, when I wake up every morning now, my first thought goes to my elderly parents in their mid-70s, living in one of the hot zones of California with chronic health conditions. As the coronavirus rampages around the world, changing societies in unprecedented ways and claiming lives as we speak, I am sure all of you are in one way or the other concerned about your loved ones and your community. Many of us are sharing a sense of vulnerability physically, socially, or economically. Yet as a scientist, it is also reigniting the sense of urgency and meaning to the work we do. In these trying times, I am especially inspired by the eagerness and diligence of scientists, clinicians, mathematicians, engineers, and social scientists around the world who are coming together to combat this pandemic. A crisis like the COVID-19 outbreak presents challenges that touch many areas of life and span many fields of expertise. They don't lend themselves to easy solutions or quick fixes. But however challenging or daunting, the journey towards solutions must begin. So what role can AI play? AI, machine learning, and data science are a set of related technologies that is really good at finding patterns. In the last 2 months, much work around the world by researchers have been about finding patterns. In the virus biology and genome, in the infectivity and the spread of the virus, in discovering drugs to treat the virus, in the public and personal responses to the virus, and much more. So we wanted to bring together researchers in these areas to help illustrate the ways in which human-centered AI can help in complex, rapidly evolving situations. Almost exactly a year ago, Stanford HAI was founded on the idea that AI can serve humanity's best interests when it's guided by a diverse, inclusive range of expertise and perspectives. Today, we're putting that ideal to the test. It is part of our mission of ensuring that AI is always part of the solution, not part of the problem. With that, I'd like to introduce our moderators for the day, our good friends and associate directors of Stanford HAI, Professors Russ Altman and Rob Reich.
Thank you, Fei-Fei and John, for your welcoming remarks. I'm Russ Altman. You'll hear from Rob in a moment. HAI, as you just heard, is really pleased to bring this conference. I'll remind you of a few things. We decided to do this on March 3rd, so this is very much a best effort. Please bear with us as our technical and logistical challenges in moving to the online format become clear. The speakers we're very grateful for. In general, these are the most critical, most busy folks right now, and so we're so grateful that they joined us. Now, I'd like to say that although AR is our clear focus, we were not strict in applying this lens in all the work that we invited. Sometimes we just included really interesting talks that were adjacent to or related to AI. Now, human-centered AI mandated a broad look at how we can help in this pandemic. So you're going to see 4 sessions today. The first one is on framing and landscaping. What are the challenges that are really facing us with this pandemic? The second one is the social and cultural implications of this work and how AI can help. The social and cultural implications of the pandemic. The third session is the epidemiological and other methods for tracking the disease. We've all seen maps. Where do those maps come from? How can AI inform them? And finally, there's going to be a session on the treatments, vaccines, and healthcare challenges for COVID-19 patients. Our goal, of course, is to provide a balanced and multiple perspectives to best illuminate the challenges and the opportunities facing the scholarly community as we try to help in this battle against the pandemic. Now, I want to take a moment for thank yous. Very soon, now or a minute ago, you will see a slide or have seen a slide of our team who worked tirelessly for the last 3 weeks. I want to especially thank Professor Michelle Ilam right at the middle at the top there, who is our co-organizer with Rob and I. I want to thank the team who put this all together. I want to thank the Stanford Video folks who are helping deliver it. Of course, we want to thank the speakers in advance of their comments. And we want to thank you, the audience. We are pleased to see a global audience. And in our initial signups, we saw participants around the world, including large groups from Canada, India, China, the UK, and many others. So as you heard and as you've surmised, our format today is entirely virtual. Every speaker is in a different location, and this will pose some technical challenges. Please bear with us if there are technical glitches during our time together. I apologize if there are funny behaviors of Zoom backgrounds. We're doing our best there. You may hear funny sounds in the background. Sorry about that. You will hear voices with time checks. The only way we can tell our speakers that they have a minute left is to say 1 minute left. So you will hear that. And I want to apologize to our speakers because we may have to cut them off if they're going long. We understand their enthusiasm, but we have to keep to the schedule. If the signal goes down for this meeting, please go to hai.stanford.edu, where you came this morning, for alternative ways to view or hear the conference. Now, just 2 more things. We invite you to ask questions during the broadcast. Please go to the COVID-19 conference page, the HAI site, on the website, and you will see an Ask Questions link. We will try to get to as many of the questions as we can. Rob and I have a small army of colleagues passing the questions to us. And finally, we are pleased to offer continuing medical education for today's conference. If you know what CME is and you want some, please go to the COVID-19 conference page on our website and click the CME link. As I said, our day is divided into 4 sections, and our goal is breadth. We'll take brief breaks between the sessions and try our best to stay on schedule. You will hear some voices for timing. I'd like to transition now to our first section of the day on landscape and framing, and therefore pass it to my colleague and friend, Rob Reich, Professor of Political Science at Stanford. Take it away, Rob.
Thanks a lot, Russ. I'm going to serve as the co-host for this first session on framing and landscape. Let's get right into it in a minute, but I just wanted to add one additional note to the entire conference today. As Russ said, we're entirely virtual, each of us in a different location, stitching this together through the wizardry of modern technology. One thing that I think is interesting to note for the entire day is that we're members of Stanford University. It's a global conference. universities often work on very long time horizons. We measure the time in semesters or academic years. Research takes a long time to grow and then mature. And in the face of an emergency like the coronavirus, universities have mobilized to act quickly. As Russ said, we put this conference together in the space of less than 30 days. Universities were amongst the first places to act and to shut down the campus locations before states and cities did. And this conference is just one example of the many different things that universities across the world are doing in order to respond to the crisis. So our first session is about landscape and framing, setting the tone for the day. We've got a batch of fantastic speakers, and I'm especially excited to introduce our first speaker, Congressman Ami Bera, who will provide some of the opening context for us before we begin the agenda for the day. We will have some Q&A with Congressman Bera directly following his remarks, but because he's only available for a brief time, we won't be able to take audience questions just for this portion of the session. So let me now introduce Congressman Bera. With a 20-year medical career as a doctor and as the former chief medical officer of Sacramento County in California, Congressman Bera has long been a strong advocate of American leadership in global health. He is one of only 14 MDs, medical doctors, serving in the House of Representatives of the United States. He was the first member of Congress to hold hearings on the coronavirus issue and exercise oversight of the federal government's response to COVID-19. He was also among the first people to sound the alarm when the White House disbanded the office in charge of preparing for pandemics and sought to include funds to combat coronavirus over 2 months ago through other legislation. I'm really pleased to welcome Congressman Bera with us today. Congressman, you can now start your slides and start your screen.
Great, thank you. Thinking about how we ended up where we are today really helps us frame where we're going to go. If we look back over the last decade or two, many of us have understood that we were going to see a pandemic coming. We went through SARS, we went through H1N1, we saw MERS, and then the 2014 Ebola outbreak. And many of us actually thought we were fairly lucky not having something like what we're dealing with right now with COVID-19. That's why global health security and the global health security agenda was one of the first key areas that I got involved with when I got elected to Congress in 2013. It's difficult to sound the alarms because it's a small community of folks that are focused on pandemic preparedness. But post the 2014 Ebola outbreak, I think President Obama understood that there were some things that they got right, but there were also some things that they were slow at. So we did a deep dive in 2014 on lessons learned. And that's when you elevated this pandemic preparedness czar to the national security level. We thought that was clearly one of the most important things that we could do, to have someone who was working across the agencies, but also working with the international community and was just paying attention to small outbreaks as they popped up. And that did serve us well during the Zika outbreak. You had early warning signals. You had someone who was in charge of tracking how the outbreak was moving along. You had someone who could talk to the various agencies and make sure we were prepared, and also interact with the public health apparatus here domestically and internationally. You touched on the fact that that position was disbanded in May of 2018. We sounded the alarm at that juncture. We questioned Secretary Pompeo and really said this was going to make us less prepared. We've continued to try to fight to get funding for this. So fast forward to December of 2019, those of us in kind of the global health security space started to hear reports coming out of China that there was a novel coronavirus that was occurring. And then early January 2020, you saw the unprecedented shutdown of Wuhan and Hubei province. And that's when we knew something was going on. CDC, to their credit, had been trying to get to the hot zone prior to that, and we're not being allowed to get into China. They did have some personnel there, but the best way to get information is to get into the middle of the hot zone. That unfortunately didn't happen. Our first briefing was January 23rd, when the administration briefed both the Senate and the House. That was Tony Fauci, Bob Kadlec, Director Redfield, and others. And the focus at that time from the administration perspective was all on a containment strategy, which was really a travel ban out of China. We sounded the alarms at that juncture, and in the first hearing that we had in Congress in the first week of February, that a travel ban was fine. It was not going to contain this virus because the virus doesn't see borders, and it had already likely traveled outside of China and potentially, as we determined, had likely traveled to the United States already. It would buy us time, and that in that time we really needed to prepare our public health apparatus, make sure public health departments, hospitals had the supplies that they needed, and we were pushing testing. We lost time, unfortunately, as the CDC decided to devise their own test. I think there was a false sense of security when they announced that they were sending the test out to 50 states and to public health labs. We lost an opportunity there because we assumed that that test was going to be an accurate test that could be quickly ramped up and brought to scale for the massive contact tracing that we needed to do. Unfortunately, we can't get that time back. Fast forward to early March when we had the first community-acquired case of coronavirus in Solano County, ended up at my old hospital, UC Davis. And that's really when it came to light how little testing capability we really had. And that patient ultimately tested positive. Thankfully, that patient has recovered and is back home. But that's when the real alarm bells sounded. And we're only a month away from that point where we started to change the testing criteria and get the CDC to change the testing criteria to where we are today. If you look at the second week of March, people started to put in social distancing measures in Seattle and California. Fairly early on, Governor Newsom here in California, as the first state, went to voluntary stay-at-home orders to fairly quickly to mandatory stay-at-home orders. New York was a little bit after us. Washington State was around the same time as California. We will, as we see this virus kind of unfold across the globe, as well as here in the United States, you're seeing in real time how important those stay-at-home measures were. For my home community here in Sacramento County, what it did do is it really does look like it slowed the spread of the virus. Again, we still expect that we are going to see a peak in a wave perhaps in a week or two, but it did give our hospitals capacity to prepare, the ability to get protective equipment as they could, and hopefully bought us some time to ramp up our diagnostic testing capabilities. Unfortunately, you've seen other states like Florida and Texas that have still not issued mandatory stay-at-home orders statewide, and we've been pushing the administration at the federal level to issue that order as opposed to leaving it to 50 states. I hope Florida and Texas don't get hit as hard as New York, but we will see in real time almost this case control study that's playing out of early states versus late states. And if you watch the president's conference yesterday with Dr. Fauci and Dr. Birx, kind of showing that those graphs, you'll see that we are leveling out in California and Washington, are not going up as fast. And then if you look at New York and New Jersey, unfortunately, and Louisiana and other places, you're seeing this dramatic rise. Let's fast forward and how I think big data and artificial intelligence can help us with the next steps. The conversation in Congress is now moving to, we've got to mitigate this. We've got to control the crisis at hand. We've got to help our healthcare professionals and the public get through the immediate crisis. But we also have to start thinking about what those next steps are. And we are starting to have those conversations. We're also paying attention to Korea, to China, to Singapore, and other places that were a month or two ahead of us in this. So the first thing and first tool that we really need is serologic testing. From that perspective, I think Stanford has the serology and others. So we have the test available. We are now working with the commercial sector and making sure the funding is there to massively ramp up serologic testing. And why that's important, it's different than diagnostic testing. Serologic testing will tell us how many people in the community have already potentially been infected by COVID-19, recovered, and have some level of immunity. That will help us make scientifically based decisions on when can you open up parts of a certain community, when can you open up parts of the country. That massive serology, I think this is where having the ability to use big data to sort through a lot of that and get a sense of, what is the level of immunity, not just in one particular part of the country, but all across this country. So that's going to be very important in helping guide us. A second big issue is it really does seem like there's a temperature sensitivity to this virus. And if you go to the Johns Hopkins website, and they're doing a great job kind of collecting the data on number of cases, numbers of death, and where they're appearing. If you look at the northern hemisphere versus the southern hemisphere, it is quite shocking. The northern hemisphere is all red.
1 minute.
Southern hemisphere is not. So looking at that data, that's going to be extremely important as well. And then the last thing, we've talked about distributing thermometers to every American. As we start to reopen, training them to check their own temperatures. That's going to be a big data set as well. And that could be, as new clusters pop up, it could give us some information on how to move forward. And again, big data is going to be very important in teaching us about this brand new virus. So I will stop with that, and I'm happy to take some questions.
Thank you very much, Congressman Bera. We do have a couple questions for you. And I wanted to begin just by noting that just today in the news, the Secretary General of the UN called this the greatest threat to the globe since World War II. You're a member of the subcommittee chairman, in fact, of the House Foreign Affairs Committee. I wonder if you can speak to some of the global challenges, not just domestic challenges, and perhaps even the opportunities for US leadership to coordinate a global response, precisely for the reason, of course, that the coronavirus doesn't respect national boundaries. And to combat this globally requires global coordination.
Absolutely. The United States is uniquely suited with the resources to, and with the leadership, hopefully, to push the global community to work together here. This is where we've got to learn from each other. Part of the reason why we sounded the alarms early with China is because we actually wanted to learn from China. And I think this is a place where China can really be a world leader as well. We know that there's a high risk of a second surge potentially in the fall if this is a temperature sensitive virus. And how can we get through the current crisis, but also get prepared for hopefully not another surge? We also know if the southern hemisphere is going to be hit harder, places like Africa and elsewhere where they don't have the public health infrastructure could be hit pretty hard. How do we take what we're learning now to help prepare those that may get impacted later?
Russ, do you have a question as well?
Yeah, Congressman, thank you very much. I was wondering if in DC, anybody is yet thinking about how we're going to unroll shelter in place. I'm sure many people wonder about this, and especially if it's going to be coordinated or if it'll be a county by county basis as it was stood up.
I think in an ideal setting, you would have the federal government coordinating with the states and the local public health authorities. You'd also have the science guiding this. That isn't how this unrolled in preparing for this pandemic. Hopefully we've learned from that and we can do this in a coordinated manner. We do think specific geographies and communities will probably open up first, likely because they were hit first. We have to know what level of immunity exists in a community, and we can start then releasing those folks that have some level of immunity back into the community, either to care for folks that are still ill or to get the economy going again. You'll hear this debate about whether we use face masks on the general public to also reduce spread. We're in the process of getting the CDC to change their guidelines. We do think once we've taken care of our healthcare workers and first responders, then it probably does make sense to make sure the general public, for a limited time, does use that protective face mask. And then it's probably bifurcated. We know there's a very high risk population of those over 60, but really over 70 and 80 that you may have to treat slightly differently, particularly they're very vulnerable versus those under 50. And again, this is where working together as a planet, sharing data, looking at what best practices are, we can learn from each other.
Let me hop in there as well with a follow-up on that. I'm sure many of the people who are watching are looking for a game plan about how we get out of the shelter in place for the very many people who are currently abiding by those orders. Can you say something about what your expectation is with respect to testing, which has been such a difficult issue here in the United States? When can we expect to see much more widely available testing, and how is that connected to getting us out of the shelter-in-place orders?
You know, we've been told a lot by the administration that the testing's coming. I'd listen to Dr. Fauci when he does the press briefings. I do believe Abbott does have a point of service test that should be ready and distributed fairly soon. We're going to need that to make decisions about reopening. And we also know when we're starting to reopen, we will still see pockets of clusters emerging, and we have to have the ability to go quickly into those clusters and do contact tracing so we can contain those clusters if we have second events, et cetera. There's two different types of tests, and it's incredibly important for us to understand. The diagnostic test, which will tell you whether you have the disease or don't have the disease, and the serologic test will be a blood test. It likely will be a finger stick blood test that will tell you if you have immunity to the disease, if you were infected, maybe you never had any symptoms, and now actually have some levels of antibody. That will also be incredibly important in helping us make decisions about how safely to reopen.
1 minute.
Okay, let me ask a final question here. I'm curious if you can say something about how this whole crisis goes far beyond a medical or public health crisis. Some people are calling this the first modern infodemic. And as a public official in a position of responsibility for the health of the country, the well-being of all people, what can policymakers do at this point to ensure that people are getting accurate information? And not being subject to misinformation and disinformation that we see often online.
That's a challenge because early on you saw it coming from the highest levels of government, from the Oval Office briefings. Going forward, we're going to have to learn from this. We're all going to be changed by this because we're all going to be impacted personally in one way or another. What it also is doing is it's accelerating technology changes. The fact that we're doing this video conference, and we're all working from home, et cetera. So those societal changes are going to have an impact as well. So how do we learn from today, but also rethink where we want to be in the future? And I think that's going to be the big challenge for policymakers as well as industry and individual leaders.
Congressman Bera, thank you very much for your time this morning. We're grateful to you for showing up and participating in this virtual conference.
Thank you. Be safe and be kind to one another.
Thank you. All right, now let's move on to the remainder of our first session on landscape and framing. At this point, we will begin taking audience questions, and you'll be able to ask a question by going to the link on the website that says join the conversation at hai.stanford.edu. I'd next like to welcome our speaker, Nigam Shah. Nigam Shah is a professor of biomedical data science at Stanford University. Nigam, you can share your screen and slides now. Welcome.
Thank you. So this is a story that is spanning multiple departments. I'm just a messenger here. This is the work of over 60, 70 colleagues who got on the same page at this URL below. And it's Stanford internal, so if you're a Stanford person, you can access it. It is not a public document, but I'm going to walk you through the highlights. And this is sort of our take as an academic medical center to see what we can do to help respond to this pandemic. So if you can go to the next slide. So the overview is that in such a situation, there are multiple kinds of information needs. So the first bucket is operational planning. And there we might need to know things such as, how many patients do we expect in our region? How many floor beds are we going to need? How many ICU beds? How long will our PPE last? The second bucket is clinical care decisions. We just heard that testing had been limited. Who do we test? Can the presenting symptoms help us screen people better? And then the last bucket is these broader research questions that drive the science. What are the drugs that might alter clinical outcomes? What are the characteristics of the virus of the patients worldwide? And all of these are efforts that several of our faculty are already engaged in. And let's walk through the first couple of them. So if we go to the next slide, here there should be a blue box with the information sources that are available to us. These would be sources from the region, such as the County Public Health Department, the census breakdown, and then institutional sources from our testing facilities and so on, because we were amongst the few places that started testing very soon. These sources give us estimates of the growth rate and the disease burden in our neighborhood, and some internal signals about how often is a test coming positive, what is the rate at which we're admitting people. And then if we go ahead, that feeds into 3 different kinds of modeling efforts that help us plan hospital bed and resource use, that allow us to project county level information, and also estimate policy impacts. All of this then feeds into our resource planning, which is geared around planning our surge beds, modeling our protective equipment usage, and then also partnering with our county. And as one of our county officers put it beautifully, can we think of the county as one large hospital? And I think that's the right sentiment to plan with. And then lastly, that as we're doing all of this modeling, we also learn some clinical insights, such as, for example, the co-infection rates with other respiratory viruses is high. And as a result of that, it is not okay to test for, say, influenza, and based on that, rule out COVID. What I want to now focus on is that there's 2 kinds of models that are going around that most of you probably heard of by now. There are these things called SEER simulations or epidemic simulations that capture the dynamics of the epidemic. These tell us the impact of the policy interventions that help us answer when can we get out of these shelter-in-place situations. And we need 10, 12 diverse inputs for these, which are all practically guesses at this point. Then there are these simple calculators that tell us about the next few days. These take very few inputs, cases, hospitalizations, bed capacities, and then help us plan for the next 5 days, so to speak. So here's a screenshot of an epidemic simulator. This is from the OpenAI group. And the point here is there's many such things out there that give you this beautiful epidemic curve, but what we need is accurate inputs. And I love this quote from 538 that says, think of making these models like making a pie. But then if your recipe says, add 3 to 15 chopped apples, steaks, or Brussels sprouts, depending on what you have, well, that's going to result in a differently tasting pie. And it's a good way to think about these complex models, that despite everybody's best efforts, we don't yet have accurate inputs. And so what we started doing is to say, can we focus on getting the accurate inputs? So here's a plot from the Santa Clara County of the number of cases and hospitalizations. And typically what happens is you would start with this blue dot, a case estimate, in this case as of March 16. You would then guess how many infected people are there in the county. Based on that guess, you would project how many will need a hospital bed, and then that gets you your number. But because there's uncertainty in these estimates, these numbers could vary between 1,500 to about 380. And I'm just going to do a back and forth. Now that's about a 5-fold difference. And that's highly uncertain. You can't plan a hospital with that level of uncertainty. So we said, well, we're also tracking hospitalizations. Can we not just use that same series to project where the next dot is going to be? That's where this question mark is flashing back and forth. And so that's what we started doing. And the URL below will walk you through our planning around that. But our suggestion is use hospitalization data from your local region for the health system. You'll be much better off in your capacity planning. And then remember this 12 to 14 day lag between interventions like staying at home and then peak demand for hospitalizations. And day-to-day variation can be misleading, and we got to be watchful about that one number trends down doesn't mean that we're out of the woods yet. But California has been amongst the most forward-looking and amazingly efficient in responding to this situation. So in order to help other people use this kind of hospitalization data, as well as share our planning about our own hospital and so on, and to use it for others, we release these calculators. The URL is on screen right now. There's one that helps you do hospital bed and resource use projection. And then the second one allows you to do your county level or regional hospitalization predictions. The red box shows you that you can use confirmed cases or hospitalizations as inputs. The person highlighted here, David Shankar, is sort of the person who led this large team to get all of this done on a very short notice. So kudos to that team. And then I'll just like to give you a flavor for the kinds of things we're monitoring as an institution. This is sort of our situational awareness. We're looking at the neighboring counties. We're looking at case rates, hospitalization. How are the ratio of new cases changing over time? How is the number of new cases changing over time? And all of this feeds into our modeling efforts that then informs our hospital and our neighboring counties and our peer hospitals that how should we think about this situation and be prepared. And then lastly, I'll zoom out a bit. So all of the things that I talked to you up till now were how are we responding to make sure that we're prepared. But at the same time, we do need to understand what's going on in the population. And another group of faculty, Eleni Linos and Julia Simard, are running the Stanford coronavirus study. And then Dr. Rusty Hoffman and Steve Goodman are running this daily health check, which is actually going to be launched very soon, I think today or tomorrow, so that we can monitor what is going on with people. How are they feeling symptom-wise? Are they getting testing? And then inform that larger geography information in our planning and response. So that's sort of the gist of the effort. And I'll end with this URL that if you have questions that you believe the Stanford data science team may be able to answer, please submit them here. This is a public URL. There's no guarantee that we can get to every question that you submit, but we will try our best. And I'll stop here.
Thanks so much, Professor Shah. For everyone listening, you get a good sense here of the ways in which an interdisciplinary approach, bringing all of the resources to bear of people who work within a university, can help inform this coronavirus response. So it's not just a matter of providing bedside healthcare with issues of masks and PPE and tests, but how data scientists can produce important models that will predict the path of the outbreak and how to provide a better response from within hospitals as well. At this point, we're going to move to our next speaker. So I'd like to introduce Dr. Seema Yasmin. Dr. Yasmin is the director of the Stanford Health Communication Initiative, and she's going to talk to us today a bit about the issues in responsible reporting about coronavirus. Dr. Yasmin, please share your slides and your screen.
Good morning, everyone. Thank you so much for having me. I am going to start, sadly, on a personal note. I know for many of us entrenched in the numbers of this pandemic and studying it from a very academic perspective, it's also a very personal crisis. And yesterday we learned that a dear friend and mentor and phenomenal HIV researcher, Professor Geeta Ramji, died of COVID-19. And she was South Africa's chief scientist for HIV, director of the Medical Research Council's HIV research unit, and she had dedicated decades of her life to HIV prevention research. So as much as we are studying this pandemic, we are also, I think it's fair to say, really heartbroken and stunned by the loss of our colleagues. So I am a public health physician and a journalist, And I came to combine these careers, which may not sound like they should be combined, because I came to the States to serve as an officer in the Epidemic Intelligence Service. So I would be helicoptered into different hot zones and tasked with having to investigate contagion, to stop disease spreading, and to keep people safe as much as possible. And what I noticed very early on, and time after time with many epidemics, was that disease was not the only thing that was spreading. And yet my sole focus was containing a pathogen. What I would see, though, was that rumors, pseudoscience, health hoaxes, all of those things were spreading in tandem with the disease. And those were often helping fuel the spread of infection and leaving communities vulnerable to the disease and also to the spreading misinformation and disinformation. So I decided, after training as an epidemiologist and public health physician, that journalism is part of the public health ecosystem. And in order to be an effective public health physician, I needed to train as a journalist and learn how to share this information effectively. So I did that. I became a television reporter and a newspaper reporter, covered many epidemics, including Ebola and Zika, and then came to Stanford in 2017 as a Knight Fellow to really study how can journalists better cover epidemics and pandemics? How can we make sure we stay safe while doing our job? And how can we ensure that we do the best possible job at countering so many of these false narratives and making sure that people receive the information they need to be empowered, to make informed choices, and to stay healthy? Being a journalist covering epidemics and pandemics is really tough. You are thrust into a dynamic situation with numbers changing every day, and you have to make difficult decisions. Here's just one example from this pandemic. On March 7th, an Italian newspaper receives a leaked memo from an official with plans for a potential quarantine in northern Italy that would effectively restrict the movement of 16 million people. Now, if you were an editor at that newspaper, would you or would you not share that information with your readers about what might be headed their way? I don't know how you might make that decision, but this is the area that we're looking at. So what happened was the story was published. I believe those editors and reporters felt like it was in the public interest to share information about how this pandemic was evolving and how officials felt like they should be responding. So what happened? There was chaos. The leaked plans about the coronavirus quarantine sent thousands fleeing to train stations and bus stations to try and get the heck out of this area that they believed was about to go under imminent lockdown. And the next day, Italy reported its highest day-on-day cases from COVID-19 to that point. Of course, we saw things get much, much worse there. So I share this example to illustrate this point that you have to make tough calls, not just as public health officials about should you or should you not institute restrictions on movement, but also as journalists covering a public health crisis. How do you balance the ethics of keeping your audiences really informed about what's happening and also holding officials to account? And journalism has impact. And that's why many of us go into journalism, because we believe that information can empower people. As I mentioned, during a public health crisis, you can see a disease spread widely, but you see information spread widely as well. There's misinformation that spreads, that's false news that spread without the intent to cause malice. And there's also disinformation, which is false news that spread with the deliberate intent to cause harm. I won't go too much more into this idea of misinfodemics, which is what I study and I'm very interested in, because you're going to hear later from folks like Renee DiResta, who are experts in this field as well. There are many studies that show that false news can actually spread farther and faster than accurate information. So that's what we're up against during crises like this, not just a virus spreading at speed, but also harmful false news. This has happened many times before, not just with this pandemic. Here are just some of the rumors that we saw circulating during the Ebola epidemic. These can have very real consequences on the ability of people to trust healthcare providers, to seek treatment, and to be honest about how sick they might be feeling. We saw disinformation campaigns during the Ebola crisis. Yahoo News's Twitter account was hacked with this news, this false news, that there was an Ebola outbreak in Atlanta. There were more sophisticated breaks too, with a CNN website being duplicated and false news put on the homepage, alerting the public to this false outbreak of Ebola in Atlanta. A lot of this was done by the Internet Research Agency in Russia with the idea of causing chaos and diverting emergency resources away from where they were really needed. I want to make sure that we're really hitting home the point that yes, we are in a pandemic situation now. This is a crisis.
1 minute.
But in terms of these misinfodemics, we are up against this all the time in terms of growing anti-science movements and anti-vaccination movements. So this is not by no means a new phenomenon, but I hope that we start taking this much more seriously as a public health community and making sure that when we deploy epidemic investigators like I used to be, that we're making sure that we're tackling not just the spread of disease, but also the spread of information that can hurt people. Just some more examples. We've seen Twitter bots and trolls stoking debate around vaccine safety where there is no debate. You may have heard of free press being described as the immune system of a democracy. And that's completely true. I think that you can use journalists effectively to counter false narratives, to hold the powerful to account. But unfortunately, my research has found that journalists are not well supported to cover public health crises. I've said time and time again, we need to make sure our reporters are safe and well trained in how to cover health and science. When I did my research, I talked to top editors at news organizations around the world, and many said they had no plan for covering a pandemic. And many of us in public health will say over and over, but these kinds of things are imminent. We've heard of folks saying they're winging it, and this is exactly how we wind up with reporters sick with the same infections they're trying to keep us informed about. Working on some solutions, don't have much time to get into them, but you can please reach me afterwards if you'd like more information about inoculation theory or the toolkit I'm producing for reporters. And in summary, we just really have to take seriously the concurrent spread of not just disease, but also misinformation and disinformation about disease. Thank you so much.
Thank you very much, Dr. Yasmin. We're going to hear next, our final speaker is Dr. Michelle Barry, who's professor of medicine at Stanford University and directs the Global Health Initiative there. Dr. Barry, if you're with us, can you share your screen and start your slides now?
Yes, I can start my, and can you hear me?
Yes, very good, thank you.
Great, thank you very much and good morning. So I've been asked to talk a little bit about the global response to COVID-19. And I think I'll start with this snapshot of various countries with different curves. And I'd like to address the 3 of these countries in a territory that have been able to flatten their curve and talk about why that may be so. I'd like to concentrate on South Korea. Let's go back to that curve. I guess I can't go back. I'd like to talk about South Korea, China, Hong Kong, and Singapore. And the reason I'd like to talk about this is these were very vulnerable countries and a territory that were proximate to the initial outbreak in Wuhan. And I thought it was very interesting. I asked my research associate to look at how many people traveled from Wuhan before those 2 weeks when the first case and before Wuhan closed. And you can see that 5 million people traveled. So you can understand why this virus globalized. Next slide. It's not moving. Okay. Singapore's strategy was one of strict containment. And they took a very strong travel restriction with strict international travel. All returning citizens had to stay at home for 14 days. They had aggressive temperature screening at the borders, all buildings, all airports, and they had rapid test development. And I think what was really key is not only did they gear up their testing, they had pretty much lax requirements. You did not have to be short of breath. You actually could be tested with just a clinical suspicion by your doctor. There was free testing, and at one time, at their peak, there were over 2,000 tests done a day. So this was the first country to have a confirmed and the highest confirmed cases out of China but they were very quick to do strict quarantine measure. They did not have to lock down. They did not shelter in place. What they did was temperature testing in just about all public spaces, stay-at-home notice. And if you go to the right-hand side of your screen, this is a stay-at-home notice where everybody, you can see that we're coming from a country that might have been contaminated, got to stay at home. They got text messages sent to their cell phone. The government followed their cell phone with GPS so that they knew they were staying in the quarantine area. They might, and this is a little card that was given out, they could get random calls from house visits, from authorities, and they would have to take a picture showing that they were in the quarantine area. So it was quite strict quarantine. The other thing that they did, which I think was really important, was that when somebody was identified as COVID positive, they gave them mandatory hospital or isolation stay. They did not put them back in the house. As we know from the China epidemic, in the first 82,000 cases, most of that transmission, 85%, was within a family setting. So positive people were put in hospitals or isolation facilities. They gave aggressive daily economic assistance for everyone quarantined. They told physicians that even if someone was not COVID positive, all upper respiratory infections were quarantined for 5 days, even if COVID-19 negative. Because we know that our swab testing now at best has about 75% sensitivity. They did strict social distancing, but they did not lock down. What they also did was a unified government response and very transparent communication. You can see that they had daily reports on your WhatsApp messaging. They talked about how many cases were in Singapore, how many were discharged. They gave daily messaging about the situation in the country. They also ran very interesting, apropos of SEMA's communication, comic book chronicles of COVID-19, where they talked about not only what you should be doing, which we get the 5 all the time, but they talked about the sense of social responsibility. Don't come into work for if you're sick. They developed a very interesting app called Trace Together, where actually these are cell phones with this app that communicated with Bluetooth networks and enabled contact tracing for 21 days. And actually, these apps could calculate the distance between people. So you knew if you were coming close to a COVID-19 person. It allowed for early notification, and it was installed by more than 600,000 people in Singapore, and it's now freely available. The benefit of this was that not only were people better informed, the Minister of Health was better informed about who needed quarantine. The con, and we can talk about that, is privacy. Next slide. Let's see if I can do it. Next one is about, next country I'd like to talk about is South Korea. And what they did was interesting because they did do a lockdown, but what they did was very vigorous testing. And they also prevented people from coming in. They mobilized companies for rapid test development of 100,000 kits a day. They had 600 testing centers around the country. The government asked many of their manufacturers to doing it. And they conducted over 300,000 tests at peak. And I'll show you some of the comparison testing that we can see. So you can see here that we are way below the amount of tests per million people. And that was a very strong reason for why South Korea was very strategic. They had advanced contact tracing using big data with security cameras, smartphone apps, and credit cards. Their data became very transparent. They had regular text message and aggressive thermal imaging at all restaurants, hotel, and large buildings. And they rapidly had new laws to prioritize community security over individual privacy during the outbreak. But again, they were able to do containment with a lack of strict lockdown movement restriction. China's strategy, we all know pretty much about, but I just want to highlight some of the interesting approaches they took. We all know that had a very bold, aggressive approach that strictly controlled movement via quarantine and social distancing. They expanded their hospital infrastructures very quickly with 3 new hospitals and 16 temporary hospitals in Wuhan. They did swift testing development. But what they did, I think that was quite extraordinary, is they had rapid deployment of 40,000 healthcare workers to Wuhan, and they sent 15,000 epidemiologists to do aggressive contact tracing. And it's about contact tracing and isolation and quarantine that I think helped China's ability to stop this epidemic. As again, unprecedented surveillance. They even had drones that sensed temperatures and determined who in the crowd had a fever. The benefit was that with these drones, the police were able to enforce strict social distancing and monitoring fever. Hong Kong took a similar strict social distancing. They implemented this very early in the crisis. They prevented, at the beginning, when they had international travelers coming in, they quarantined everyone and even gave tracing bracelets to those coming back so that they could keep tabs on where they were being quarantined. And interestingly enough, they had daily public releases of COVID positive cases. And this information, you could go online. It had the date of positivity, symptoms, street location. So you knew in your building who was positive, date of discharge from the hospital as well. It was de-identified. There were no names, but obviously there was quite a bit of information that was released. So why did I think about these 4 responses? Because I think they all had something in common. For one thing, Singapore, Hong Kong, China, and South Korea all had extensive, a first preparation, a first run with the 2003 SARS-CoV-1 epidemic, which had about a 30% mortality. So they were set up to do aggressive fever and fever clinics. They had swift and decisive physical distancing. They had aggressive, transparent testing, and they had frequent coordinated public announcements on a daily basis. I did want to spend a few seconds talking about a very interesting public health experiment in Vo, Italy, which shows that containment is possible if you test early. And this is, as you know, Italy is a hot center, but this is a town of 3,300. When they had the first Italy death, they closed the town's border. They implemented mass testing of all residents in February with no new cases. Mass testing, even if you were asymptomatic. And what they found that 3% of residents were positive. They quarantined them, they isolated them, and they did second testing several weeks later and found that had dropped and actually contained it. And since March 23rd, they have not had a single case. Iran is an interesting clash of religion and public health. It was very interesting to see the Iran curve dramatically go up at the beginning, and one asked why. And this was an interesting class of religion and public health. This had to do with the fact that in Qom, Iran, they had 700 Chinese Muslims coming from Wuhan that actually went to a very sacred shrine where they actually licked and kissed the shrine. This obviously caused massive viral dissemination, and still to this day, it's been very hard to interfere with this shrine in Iran. They have now done aggressive, punitive violation quarantining. So we've had a diverse global response to COVID-19. We see how United States has surpassed China, but we've done this not by so much a unified public health messaging. We have state-by-state health policies. CDC cannot go into a state without being invited. We've had lack of testing, which Congressman Bera talked about. We've seen in India massive lockdowns, forcing massive migration, and obviously congregation that is not good for migrant workers. And I think you're going to hear from Jason Wang, a real success story, which I didn't touch upon, which is Taiwan with big data analytics. I want to end with the sense that we need to have this concept of interdependence, sovereignty, and shared global governance. Congressman Bera talked about this. This is not only for air pollution, climate change, but also pandemic infectious diseases. And I think the way that we need to go forward in the future is this concept of we need to have a healthy planet to have healthy humans. We need to look at the impact of our land use and deforestation, which moves these bats, which carry coronaviruses. We need to look at climate change upon emerging infectious diseases. We need to do surveillance to detect emerging zoonotic diseases in animals and humans. And if you want, we can talk later about what this concept of IHR and One Health is, which is basically looking at animal health as well as international regulations and global health security. And lastly, we need to have evidence-based interventions with AI helping us to build community resilience, to prevent, adapt, and respond to pandemics. Thank you.
Wonderful. Thank you very much, Dr. Barry. And now I'd like to invite all of the speakers from this morning, Dr. Yasmin as well as Dr. Shah, to rejoin us. And Russ, if you're back with us too, why don't you start off with a question for any of the panelists?
Yes. Thank you very much, Rob, and thanks to the speakers. Thanks especially to Nigam for dealing with our technical issues and forging new territory. So we're very grateful that you took one for the team. So I think this question is really relevant to everybody, which is the quality of data. We all know within AI, data science, and all the fields that you're in, journalism, global health, and within a hospital, that when you're building models or responding to challenges, your actions are only as good as the data you have. So I'm wondering for each of you, how do you ensure that you have the best quality data, and where are your main worries about data quality in all those very diverse application areas we've just been hearing about? And let's do it in speaker order. So Nigam, then Seema, then Michelle.
All right, thank you, Russ. No, absolutely. Like, without data, without good quality data, all of these models will go exponentially bad outputs because they all have exponential coefficients. Getting the right data has been a challenge, and I will say publicly that US law does not help. Our local counties have been extremely gracious and kind, and our lawyers pushing through data use agreements on a fast pace so that we regionally can share data, but it has still been a challenge. And I would say, I think we should all learn from this opportunity, from this crisis, and make sure that at least at the regional level, as you and I have talked in the past a couple of days ago, we should put in place networks that are already pre-authorized to share data at very short notice so that not all of us have to be flying blind. I mean, that is absolutely critical and a lesson that needs to be learned from this situation.
Seema?
As someone who was a CDC employee, I will say that I know that that agency has the capacity to produce the kind of data that can inform solid models. And what we're seeing here is really perplexing in terms of the agency kind of sitting on the guidelines and in fact data disappearing from the CDC website regarding the number of people who were tested, the number who tested positive. So that's really a hindrance. And for journalists, I urge you all to really dig into what's happening there with the agency and why the US's public health institution isn't being empowered to do its work. I reported a lot on models because models make great headlines. So when you see those alarming models that talk about millions of deaths, often those are the ones that get many newspaper inches because they are quite sensationalist. And I worry about how the public is fed that information without the context of how models are built and just the number of assumptions that we put into them. I wrote during the Ebola crisis about that quite famous model that from the CDC, in fact, that said 1.4 million people would become infected with Ebola. Of course, that epidemic was startling and awful, but nowhere near that many people became infected. When I interviewed those modelers, they said, well, we did that because we wanted to get people's attention. So I think from a communication aspect, there's a lot to dissect with models, and we have to be really careful in offering that context around what the data really means and how it will pan out in real life.
Thank you. Michelle?
So I basically will deal with the global data, because I know there's been a lot of questions. Should we believe the Chinese data? Should we believe the global data? But in actuality, the data that we received from China early on was incredibly crucial as to the first symptomatology, how this virus was presenting. They quickly shared, as opposed to SARS-1 outbreak, this outbreak, they quickly shared the genome. I give them a lot of credit for that, because that helped many people work on COVID-19. There is now a website, because we're all worried about mutation of this virus, called nextstrain.org, where many countries are working together to actually put up the new genomes and the small mutations that we're seeing.
Just to make sure I get that, this is nextstrain.org, as in a strain of virus.
Yeah. I believe that's you can check me, but I'm pretty sure that that's the website. And the other thing is the extraordinary collaboration now with journals, where journals that usually take months to have turnover of publications, we're seeing rapid turnover. We're seeing open access. They're waiving their fees, and there's really rapid peer review. And interestingly enough, there's also non-peer-reviewed articles that are being printed, which we need to take with a grain of salt. But I think the most important thing is to get this information out.
Thanks a lot.
I'm actually impressed with the global cooperation.
I want to move now to some audience questions. We've had a number of different questions come in that try to get at the heart of something that cuts across all of the presentations you've made, which have to do with some of the trade-offs that we have to strike in the face of an emergency like a pandemic. So Nigam, you asked about access to data in order to make much more accurate modeling. That often comes at the cost of surveillance and abuses perhaps of privacy. Seema, you talked about the challenges of a free press and protections for the independence of journalists to do the work that they do, but sometimes that can also pave the way for misinformation and disinformation. And Michelle, some of the various countries that you pointed us toward are not always strong models of democratic governance, and perhaps the more centralized rule there is what permits some of the more stringent measures. So I wonder if any of you wish to speak to the trade-offs that get made in the face of a pandemic, and whether or not, let's take surveillance and privacy or misinformation and disinformation in a free press as a start, whether or not there's a possibility of overreacting in the moment, or whether the emergency just takes precedence and changes the way that societies have to weight these different values.
Right, so that's a really tough call. And when I'm training journalists about how to cover global health crises like these one, I remind them that this is a breaking news situation, and one that's a situation that's familiar to them. And you are making trade-offs all the time there about vetting data as quickly as you can. But we have this adage in journalism that you want to be right, not necessarily first. And that's a tough call. You want to keep your audience as informed as possible. But if you're too quick, you could be sharing information that hasn't been vetted properly. And I will say that as much as we're now seeing flaws in the public health infrastructure, we're also seeing how devastating it is to us that we have had a lack of resources funneled into local news. So in the US, we have these maps of areas that we have defined as health deserts, places where there are vulnerable populations that lack the proper access to care. They often overlap with news deserts, places where local news organizations have been shuttered because of a lack of funding. And that combination is devastating to those communities.
I'm going to jump in here with a suggestion on the technology side. I mean, just like we have legal infrastructure for the governor to invoke emergency powers, for example, and take over, say, a hotel for the purpose of turning it into a field hospital, I think on the technology side, we can have pre-thought emergency powers assignments that enable the administration that any pandemic situation, when the legislature agrees, they can take over certain infrastructure, such as those that tech companies have at their disposal. Like if the governor is allowed to legally command Sheraton to share its hotel beds as hospitals, I believe the governor should be allowed to command a tech company to share their tracking infrastructure for public health for a limited period of time. We have things like the Amber Alert system. Why is it one way? Why have we not thought through about making it a two-way system in an emergency situation so that the administration can get reliable information near real time? All of it is not a technology problem. We have to think through as a society what we want to build in terms of legal infrastructure around it.
Michelle, do you want to address that in terms of the interdependent sovereignty that you ended on?
Well, I definitely think we need interdependence, global governance. But I want to answer the question that the person asked. I think for many years we've had public health laws that take precedence over individual privacy for the greater public good, ever since Typhoid Mary. So that's been longstanding in the U.S. I think what we're all worried about in some of the more authoritarian countries that you may, and there was a great New York Times article about this, is that sometimes it's often hard to unroll laws, strict laws that are made in the time of public health emergencies. It's very easy to roll them out, but we're all looking with bated breath about what's going to happen in the future.
Right. Okay. The standing challenge of any emergency situation in which rollbacks of civil liberties and individual protections in the name of some greater good are often then things that linger far past the emergency time. Let's go to one more audience question. And this one is in particular about journalism. So I'm going to direct it to you, Seema. I'm wondering if you can say something about the way that the contemporary news cycle, in which it's a constant update from Twitter, 24-hour news fractured across many different channels. Is there any special opportunity or challenge in that type of environment as opposed to the kinds of centralized communication that happened in very fewer channels in the past?
I think one of the challenges is offering people context. We see numbers churned out constantly. Those numbers can be useful, but you have to offer people the context as to what those numbers mean, how to interpret them for their day-to-day life. And one of the things that we see regularly during epidemics is shifting case definitions. That's just the nature of how you investigate epidemics. As you gather more information, case definitions change, but that can drastically change the number of cases you're seeing, or at least that you're reporting to the public. We saw this early on with the numbers from China. There was a few days where it looked like the numbers were dropping, and they weren't truly dropping, but we had a very different case definition. So I do worry that there's this 24-hour news cycle, this urge to just be updating information constantly, but then it lacks that nuance that really helps people interpret what the data means.
Mm-hmm. Can I just follow up to that, Seema? You made a really interesting mention of the spreading of disinformation, and usually it's not going to be through the traditional media markets and the media that you work for. Can you tell me what is the sense within let's call it the mainstream media about their duty to snub out any or all or some of that disinformation that spreads through other media like social media and whatnot? It's a complicated, I don't know what the answer is, but that's why I'm asking it.
And just to clarify, sometimes we have seen, so during Ebola, we did see there were newspapers that were churning out conspiracy theories. So it's not, the disinformation isn't always coming from where you expect. There certainly are bad actors. I mentioned that Internet Research Agency in Russia. One of the issues there, though, is that I think we're doing a better job now at debunking some of the false narratives. There's some research that argues that debunking a myth offers it more oxygen and gives it a platform. There's just as much research, though, that says it can be useful. This is a long game. That's why even during a pandemic, I brought up those slides about the anti-vaxxers, because it's a chipping away at belief in science and trust in science. often based on histories that have been unethical in terms of how communities of color and marginalized people have been engaged by the sciences. So it's really complicated and it's rooted in history. We need to be unpacking that all the time, I think, and building health literacy and news literacy so that when it comes to a time like this, we have better relationships with audiences and we're able to say, here's a thing you might be hearing, here's why this is not true, and here's how believing it could be harmful for you. And there's a role for all types of media organizations to do that work.
Nigam, please.
So I would advocate strongly for the need for data literacy. And I mean, this is not something we can do in a pandemic situation, but as an ongoing thing, we teach all of our students to learn how to read, write, and add numbers. I think we also need to teach how to interpret data, and particularly numbers that don't have a reference point or a context, and not be scared by these models that say millions will die and this many beds will be needed. Like as of Monday, California needed 50,000 beds, and as of today, it needs 10,000. That's a 5x difference in 24 hours.
I just want to remind the audience that if they want to ask questions of the panel now or later today, they can go to our website and click on the button to submit a question. Michelle, I think you wanted to get in on the conversation too.
Yeah, I just want to add something to what Seema said. It really has a lot to do also with trust in government. I mean, you can use good media if you have good trust in government. In just watching how Singapore use their apps to tell daily dashboards of what's happening was very important for people to know and prevent themselves from having contact with COVID-19 patients. But you need to have trust in government.
I want to go to one more audience question here, and this was for anyone who feels able to answer this. Many questions have been submitted on a very particular question that individuals can actually act upon. What is the best information we have about the use of masks, either now or in the future, once the curve has flattened?
I'll take that because unless Nigam wants, the CDC is about to, I think, put out an edict for masks. I think the big problem, and it's been a really big problem, is that the instructions for masks have been very different for us than the rest of the world. And it has been more for expediency because we don't have enough masks. So CDC took the line that this is primarily a droplet, meaning drops coming within 6 feet or less than 6 feet. And that cloth masks, not cloth, I'm sorry, cloth doesn't work well. Paper masks or droplet masks work. I think you're going to be hearing very soon that that's going to be changing. But I don't want to preempt. This is grapevine information. But did I answer the question, Rob?
Yes, I think so. But the basic idea is that if individuals who are watching right now think that they could construct their own mask as a way of doing something rather than nothing, they wouldn't be ill-advised to do so.
That's right. But if you look at cloth masks, I know a lot of people are knitting. It's really not effectual, like 20 to 30% effectual. You really need to get the droplet masks or the N95s. And I think it's really a shame that we are not as prepared as some of our Asian colleagues with giving our healthcare workers who are on the front line the best protection. All of our healthcare workers working with COVID-19 patients should be having N95 and face shields and goggles. That's what was done in Taiwan and Singapore, in all those countries that, in fact, in China, they showed that there was infection transmitted to healthcare workers that dramatically dropped when they enhanced their personal protection equipment. Unfortunately, we don't have that ability.
All right, well, we got about 5 minutes.
Hopefully in the future we will.
Hopefully in the future we will, indeed. Yeah. We have about 5 minutes left before we're going to close this session off. I want to ask one more question that introduces an element that I'm sure we'll get into in the next session as well, which has to do with some of the ethical considerations in the delivery of care. We read stories about how other places that are hotspots are having to limit the use of ventilators because of the lack of the numbers, and whether or not the coronavirus happens to afflict older people disproportionately. really hard choices having to be made in hospitals about who should get access to life-saving treatments. Just as we might think we have a different approach in an emergency, do the ethics of delivering necessary healthcare treatments also change in an emergency like this? And how would any of you react to the news that comes out of places with the hotspots that people are simply unable to get the necessary treatment, and doctors and nurses on the spot have to choose on the basis of what? Something other than guidelines or their intuitions? What's emergency practice here, and how do we think about the ethics?
Well, I think Stanford has done a great deal of thinking about this, and my hearts go out to my Italian colleagues, whom I'm in daily contact with, because they've had to do this on the fly. Fortunately, we've had a little bit of a lull before the surge, so our ethical committees, our palliative care folks, are all meeting now and trying to come up with standards as to who gets ventilators, how we assess who we put on ventilators. There is going to be a tiered approach, and they're working very hard on that right now so that people won't have to do this on the fly. And that takes the pressure off the healthcare worker because they're already stressed out taking care of patients. And it's so hard to make those decisions without an algorithm to make them feel a little bit better.
I would second that. I don't think you want the person delivering the care being forced to make that decision. There has to be a separation between the deliverer of the care and a group that may or may not use both data, algorithms, and individual input to make the call. But the decisions of who to ventilate and not, and the act of doing so have to be separated in order for it to stay on a solid footing.
All right, well, let's end, if you're willing, with a reaction to what the President of the United States said yesterday to the country. President Trump said that the United States should be prepared for a very, very difficult next 2 weeks, possibly month. The messaging from the Oval Office has hopscotched all over the place, and I'm wondering if any of you can, give information to anyone who happens to be in the live stream about what you anticipate in the next 2 weeks or a month, and what kind of messaging you'd like to see from the Oval Office or other central bodies of government. Seema, is it all right if we start with you?
Of course, and I'm just thinking about the direct consequences of that information and misinformation. We saw a man die in Arizona and his wife wind up in the ICU because they said they took medical advice from the president. He said a medicine was approved to treat COVID-19. They had it in their house. They took it. The husband died and the wife is very, very sick. So I worry massively, even about the airtime that's given to these press conferences where officials, politicians say one thing and then infectious disease experts walk to the same podium and have to backtrack. My advice is to be really careful, skeptical about the information you're seeing. Go to trusted sources like the World Health Organization and CDC's website, and be careful about what information you absorb and what you share. And we're seeing just the misinfodemics, right? People with good intention sharing stuff that is not accurate. And I'm just really concerned again about those communities that are already vulnerable because they have access to care issues, then being more susceptible to disease because they're receiving so much misinformation from even the highest levels.
So on the data front, if anything is rising at a 15% growth rate, and we put in place a perfect intervention as of today, after 14 days, things will still be 5 to 6 times worse off than today because of the lag between getting infected and getting symptoms and getting serious. So there's no question that in the short term, things will appear to get worse. That's just the way the math works out here. And in terms of listening to statements coming out from the White House, I mean, the only thing I can say is, monitor for consistency. If a factoid stays the same over 72 hours or longer, it is probably real. if it keeps changing every 24 hours, too much entropy to trust it.
And there's clearly going to be a surge in this country, and the surge is going to be very different in different parts of the country. Just as if I look at the global response, it has a lot to do with density. I think that's why we're seeing New York take off. It's a lot to do with the heterogeneity of our population. We see a lot of deaths in Europe. It's an older population. Older people have a higher mortality in this disease, but we're still seeing young deaths. So remember, it's not just going to be the older people that have the high mortality. And I'd like to end on the sense that it's not just about the US, I'm sorry. We're all in this together as a planet. And we can't forget that. And I am incredibly impressed that the Chinese are flying us over masks and helping us with scientific backup and reagents, which we're running out of quickly. I think once we have a country that has zero antibody positivity, maybe we can even ask them for help for frontline healthcare workers. I mean, we're all in this together. And I wish our administration would take a larger view of this. And ultimately, when this is all over, I think we need to take a larger view of how we do better global surveillance of zoonotic diseases, because all of these pandemics in the last 50 years have come from animals and bats, particularly. And we need to do better surveillance as a world. And for goodness sakes, give our WHO more money than one hospital in the United States. Their budget is basically for the entire world, similar to a large teaching hospital in the United States. So I'll end on a global plea.
Well, I want to thank each of you for giving us your time in this virtual conference today, Dr. Shah, Dr. Yasmin, and Dr. Barry. And to anyone listening, we're going to take a short break of about 10 to 12 minutes, and we'll return with our second session on the social impacts of COVID-19 in just a short amount of time. So thank you once again to our panelists, and we'll see the audience again in just a few minutes.
Thanks.
Welcome back, everybody. We're going to begin our second session now of the HAI conference on COVID-19 and artificial intelligence. My name is Rob Reich, and along with Russ Altman, we're co-hosts for the conference today. Our first session was a basic landscape and framing to set up a wide-ranging discussion throughout the rest of the day. And this second session is going to focus on the social impacts of COVID-19, as well as broader issues of biosecurity. One of the things that marks the approach of the Institute for Human-Centered Artificial Intelligence is that it's not just an effort of AI scientists to push the frontier of AI forward, but a fully interdisciplinary approach so that the ethical and social and economic and psychological impacts and orientation to thinking about artificial intelligence are always and everywhere present. And that's very much the approach we're going to take in this second session. So we will focus, of course, on COVID-19, but we'll be having a discussion with a great panel of experts about some of the social impacts of the coronavirus and the pandemic that we now confront, as well as broader issues of biosecurity and the challenge that the globe faces in making a more secure future, secure from the kind of ravages we see right now from the pandemic. So I'd like to welcome our first speaker. Our first speaker is Kate Starbird. She's a professor at the University of Washington, and she's going to talk to us about the idea of a COVID-19 infodemic as well as an epidemic or pandemic. Kate, you're welcome to share your screen now with us and start.
All right, I am actually not going to use slides this time around. My talk today is a reflection on COVID-19 from the perspective of a researcher of crisis informatics. For over a decade, my colleagues and I have been studying how people converge online during crisis events. Our field is informed by much older research in fields of sociology of disaster and the psychology of rumor, and many of our lessons are relevant to COVID-19. I'm going to start with what we know about human responses to crises generally. So crisis events as they unfold are often characterized by high uncertainty, about what's happening and what we should do about it, both individually and collectively. In these cases, the facts of the situation are often dynamic and there are often unknowns or things that need to be resolved. This uncertainty feeds anxiety about the personal and collective impacts of the event, as well about what actions we should take. What should we do? Where should we go? When should we evacuate, or in this case, quarantine? Under these conditions, people come together to seek, process, and share information to try to resolve that uncertainty and anxiety. It's a part of the human response to disaster events. Researchers call this process collective sense making, and it's been theorized to serve both psychological as well as informational needs. Though a natural response to crisis events, sense making can produce rumors, including ones that turn out to be true and ones that turn out to be false. And as we know, false rumors or misinformation are dangerous because they can cause people to take actions that endanger themselves or others. Historically, the biggest challenge for people experiencing a crisis event was an absence of official or good information. And in that void, people would share information with their families, friends, and neighbors to try to make the best decisions. In the connected era, the problem isn't necessarily a lack of information, but the overabundance of information and the challenge of differentiating between information we should trust and information that we shouldn't trust. And unfortunately, our current information space is characterized by the pervasive spread of mis and disinformation and the active politicization of just about everything. The conditions of crisis make us particularly vulnerable to these types of messages. So with COVID-19, we have a perfect storm of sorts. The event itself is highly uncertain, with the best knowledge and the underlying science changing from day to day as we learn more. And the uncertainty is very slow to resolve as the event continues to affect people all over the world. As a result, we're all experiencing this extended period of anxiety where we're trying to resolve it by searching and searching and searching for more information. And we're doing that in an era where our information systems are already inundated with rumor, misinformation, and disinformation. And so within this sort of perfect storm, what kinds of actions should we take? What should we do? And I mean we in a lot of different ways. So when I think about we as information participants, I would recommend that we tune in to how our anxiety fuels the sort of information seeking and sharing practices that may make us susceptible to spreading misinformation. Perhaps this is the hand washing for the infodemic part of the pandemic and the action that we could take to maybe help that and make it better. For crisis communicators, an acute issue is that the challenge of finding information we can trust as information participants becomes compounded when we lose trust in official sources or the government agencies charged with managing the response. For those agencies right now, I really recommend that they be truthful, building their policies and recommendations using the best science available at the time, communicating the scientific uncertainty in ways that their audiences can understand, and being honest about their rationale for specific recommendations. And I know that this is going to be acute when we talk about masks coming up in the next few weeks. Otherwise, these agencies risk losing trust at a time when it's most critical for people to be able to find and act on trusted information. For political leaders and communicators, I recommend that they reflect on how their statements contribute to the spread of misinformation and may have detrimental effects on individual and collective responses. When elected leaders and political appointees share dubious information and contradict their own agencies and scientists, this foments distrust and diminishes our ability to find the information we need, increasing the anxiety and uncertainty, and even causing people to take actions that endanger themselves and others. On the technology side, I'm supportive of many of the actions taken by social media platforms for preventing the spread of misinformation. But I want us to consider how these changes we may need to revisit these as the event kind of calms down, because we're making some pretty extreme changes. In particular, I commend the platforms for applying new policies, not just to everyday people, but to influencers, including high-profile media pundits and even elected leaders. We've seen them take actions that for the first time against political leaders in terms of removing their content. I think that's a good thing. However, I caution against the sort of fine-grained policing of content that might inadvertently silence the collective sense-making process that is so vital for people coping with the impacts of the pandemic. So I really encourage the platforms to continue to sort of focus on influence and how the dynamics of their platforms help misinformation and disinformation go viral, rather than focusing on the sense makers or the people that are just trying to cope with this event and may sometimes get it wrong, but that's actually an important part of our response to the to this kind of disaster events. And so I'm actually, I spoke too fast, so I think I'm going to end early, but hopefully we'll have some time for questions later. Thank you.
Great. Thank you very much, Kate. We're going to move next to my colleague, Renee DiResta, who ordinarily occupies an office just down the hall from me on the university's campus, but not today. Today, Renee is going to talk to us from somewhere else, where hopefully her connection is going to be stable. She is a researcher at the Stanford Internet Observatory, and she's going to talk to us about misinformation and disinformation with respect to COVID-19. Renee, you can join with your screen and slides now if you can.
Title slide, Propaganda and Pandemics, How Chinese State Media Shapes Narratives on Coronavirus. So I'm actually not talking about social media misinformation and disinformation in the user-generated mimetic context in this case. One of the projects that we've been working on, my colleague Vanessa Molter has done a bunch of excellent research over the last month. We've been observing Chinese white propaganda for quite some time. We began actually in a project related to the Taiwan election, and we started following along with what the official channels were saying, what the English language channels specifically were saying, to understand how state-sponsored narratives were shaping the conversation worldwide. So as just a really quick background, the propaganda spectrum, when we talk about this is not a new concept. States work to control information for reasons of everything from public diplomacy to malign influence. When we talk about the propaganda spectrum, we start on the white propaganda spectrum, which means it's overtly attributable. You know exactly what state is producing the content. In these cases, China is most often in the name. Other examples would be Russia Today. Then there's the kind of gray propaganda spectrum. That's where you get into the provenance, the claims, the funding sources are obscured a bit. And then black propaganda is the deliberate misattribution, the sort of internet research agency or troll farm activity that we actually talk about quite a bit. But for this particular chat, what I want to go into is actually the white propaganda ecosystem and how narratives are moving their way from Chinese social media through to Chinese narrative propaganda and then being pushed out both on Facebook and through strategic communications on Twitter and elsewhere by high-profile attributable diplomats. So everything we're talking about here, there's no plausible deniability involved. This is a state-sponsored communication. So the interesting thing about China's white propaganda ecosystem is that it exists on Facebook, even though Facebook is banned in China. So what they've done is they've created a range of properties, and most of their properties are regionalized. So the ones that you're looking at on my screen right now are the ones that are in English specifically, but there are also Spanish language and Arabic language and a number of other regionalizations for most of these properties. But you can also see year-over-year growth. So this is 1 year's worth of data. And so you can see that these pages over in the page likes column are upwards of, many of them, most of them, upwards of 50 million likes. Just to put that in perspective, CNN has about 33 million likes. Fox News has, I think, around 14 or 15 million likes. So China is investing heavily in this English language broadcast ecosystem on Facebook. They're prioritizing the development of it, and they do have massive audiences, even though we believe the interaction rate, the engagement rate is not as high as you would see on other state media. So one of the ways that they've done the work of amassing this audience is they do run Facebook ads. And so we've observed over time, while most of the ads generally focus on positive news stories about China, beginning in January of this year, about a third to half of them began to focus almost exclusively on coronavirus. So China was paying to boost its state-sponsored propaganda stories on coronavirus in particular. So we started looking at why that was and what that was. And one of the things we believe is that perception of the pandemic has been a significant PR challenge. And this is because, of course, there is a sense that, the virus originated in China. And so that the Chinese response has been, was a bit slow, that the Chinese response initially was to conceal that the data emerging was not necessarily reliable. There was a news story that broke today claiming that the death numbers have been vastly underreported. And so there was a lot of need to manage perceptions, need to manage the way that the world saw their response to the outbreak. And also, as they got a handle on their regional outbreak, as it gradually became a pandemic, ways in which that narrative was then ported into broader narratives around how the Chinese government system was superior to Western democracies because it had allowed them to tamp down in extremely effective ways. So Chinese media began covering the coronavirus and very early, of course, in January 2020. This is where we began to see state-sponsored media, including coronavirus content in their posts. You can see there's a rather significant offset. The US is about a month behind as we look at what, it was not a thing that most US media was paying attention to quite the same extent. So a lot of the conversation that we're looking at began much earlier in China as the significance became much clearer in China first. We observed three primary narratives. There's content related to the origin, there's content related to the spread and treatment, and then there's content related to the government response. A fourth narrative has begun to emerge that's related to conspiratorial state communications, which I'll touch on very, very briefly because I've only got 7 minutes. But narrative one, the media spin was really focused on rapid recovery. So you see here two kind of conflicting stories about a baby diagnosed with coronavirus. So the CNN emphasis is on the diagnosis. The China Daily story is actually on the fact that here was this other baby that was born with no infection. So China is putting out very positive news stories in its official channels about cures, about rapid recovery, about the number of people who have been successfully treated, while US focuses much more on numbers of infections. The Li Wenling case, this was, of course, the doctor who was the whistleblower. There is no mention in the official communications or reports that are put out in the English language media ecosystem of the early warnings, the fact that he was arrested, the silencing attempts. What we see instead is we're mourning a national hero. So a lot of the content on that focus, the warning piece of it is largely left out of the narrative. Instead, we have the narrative of a hero doctor who was one of the first to uncover the virus and the early activity that the Chinese state government, the kind of persecution is possibly a bit strong, but the arrest and the silencing attempts were largely eliminated from the narrative. We see again, what are the words? We're examining words that they use.
1 minute.
And we're beginning to see again the narratives really focusing very much on him and his personal story, not China's reaction to it. China then begins to frame the response narrative as China has bought the world time. Their effective containment, their effective treatment has given the world time to prepare because the pandemic was not universal earlier, versus the US, which of course is focusing on the way in which China has in fact botched their response. These platforms are really being used as a tool in shaping the global narrative. There's quite a PR battle happening. This is where you begin to see the conspiratorial communications emerging. Conspiratorial communications began in their media ecosystem in early January, but really made national news in March. So it was about a 2-month kind of percolation through channels to get conspiratorial narratives saying that the outbreak didn't originate in China out there earlier. I'll just say that io.stanford.edu is where our blog posts and research are posted, and you can see much more in detail and methodology around the work that we've been doing on this.
Great, thanks very much, Renee. I'm going to repeat that web address for everyone. That's io for Internet Observatory.stanford.edu, where you can get more information about Renee DiResta's research as well as other scholars too. Before moving to our third presentation, I just want to remind the audience watching that you're welcome to pose questions for any of the panelists by going to the live stream website, hai.stanford.edu, and click the Submit the Question button. And I'd now like to introduce our third speaker, who is Megan Palmer. Megan Palmer has a brand new job, I'm told, just as of today, the Executive Director of Initiatives in Bio Leadership at Stanford University. and she's going to talk to us about COVID-19 and broader issues in biosecurity. Megan.
Wonderful. Thanks for having me today. For the last 4.5 years, I've been a senior research scholar at the Center for International Security and Cooperation at Stanford University. I lead an interdisciplinary group that studies how individuals and organizations contend with the responsible development of biotechnology, with a focus on how security is conceived of and managed. And as Rob mentioned, today is actually my first day in a new role at Stanford as Executive Director of Initiatives on Bioleadership, an effort spearheaded by bioengineering, but designed to connect with efforts across and beyond the university to both explore how biological science and engineering are shaping our societies and to guide innovation to serve public interests. This effort is driven by recognition of the increasingly important role that biotechnology plays in our societies, including safeguarding against biological threats. Less than a month ago, I was testifying in the US Senate about the need for strategies to prevent and prepare for future biological threats, as otherwise COVID-19 will not be the last and likely not the worst pandemic. Biosecurity is a very broad area, but today I wanted to touch on two topics where COVID-19 is shedding light on long-term strategic issues. The first is how we prioritize and manage biological threats in an evolving international security landscape. And related to this, how do we deal with technologies that can both mitigate and cause security threats? That is, they are dual use, including technologies at the intersection of biotechnology and AI. So first, the evolving security landscape. Experts have long warned about the seriousness of biological threats, and in spite of this, these threats often receive low and inconsistent attention relative to other security areas such as nuclear risks. The US and other nations have biodefense strategies, but we're seeing the ways in which these strategies can fail in both design and implementation, especially coordinating across nations. One issue I want to highlight today is the underlying challenge of estimating the scale of these threats. There are several different origins for biological threats. First, there are naturally emerging infectious diseases for which we have the most experience and data. This pandemic is in many ways the least surprising set of events, and yet even experts calling to take these issues seriously often underestimated the consequences. Secondly, there's the possibility of accidents from labs that are studying pandemic pathogens. And third, there is intentional misuse, including the possibility of weapons development by state or non-state groups. For these last two categories, our threat estimates are highly uncertain, and experts disagree both on the scale of the risk and the likely effectiveness of risk mitigation strategies. The events of this year will undoubtedly change risk perceptions and how we prioritize these different types of threats as a result. And there is a question on how that risk calculus should change. These events will also change how we think about consequences, including knock-on effects and intersections with other security domains, like information security, that create compounding vulnerabilities, as my fellow panelists are highlighting today. Some of the work my group has done involves looking at different estimates and conceptions of risk and how they do and might inform our threat prioritization, especially in the midst of great uncertainty. We also have developed scenarios of different security threats to study how we might avoid over-indexing on any particular type of threat, blinding us to future possibilities. There can be future pandemics, natural, accidental, or intentional in origin, that may dwarf or look very different than the current outbreak. Which brings me to my second related topic. How do we manage technologies that can be used for good or for ill, that is, they are dual use? For good, we are now relying upon innovations in biological science and engineering to deliver the diagnostics, therapies, and vaccines we need to respond to pandemics. As we'll hear later today, AI and information sciences more broadly are a critical part of that tool set. For bad, we see the devastating impacts that infectious disease can have on our society. How do we safeguard against accidentally releasing or intentionally creating organisms that could cause just as, or potentially even more devastating consequences? And this dual use nature applies not only to biotech. How do we ensure that the surveillance tools we develop to help prevent the spread of disease don't create longer term vulnerabilities that suppress civil liberties after this pandemic is over? I think it might be helpful to share one example of a conundrum in dual use management that has been a focus for my group. Advances in biotechnology are enabling research groups around the world to synthesize novel viruses in the lab without relying on the physical delivery of samples from patients. For example, in February, Swiss scientists created a synthetic genomics platform for reconstruction of the SARS-CoV-2 virus and publish their methods in an open preprint server bioRxiv. Broad access to these methods can enable the rapid development of diagnostics, therapies, and vaccines that we need to respond to emergent threats. However, as methods and tools spread across the world, we also must wonder at what stage they can generate new types of risks and how those should be managed. This is not a purely hypothetical concern. In past outbreaks, such as the SARS response in the early 2000s, we saw cases also of laboratory-acquired infections. And moreover, we know that the same types of processes that can enable reconstruction of viruses for groups working to end this crisis could very well be used by others attempting to manufacture this or other viruses for ill purposes. So one of the things my group looks at is how we decide when and how research contributes to security rather than undermines it, as a function of both the conditions in our research settings and changes in the global threat landscape. It's worth noting that in the US, labs doing certain research on novel coronaviruses experienced a temporary federal funding freeze in 2014 as a result of oversight bodies being concerned about the risk this might generate. And the resulting policies that were enacted around the care and oversight of potential pandemic pathogens designed to manage research-related risks are actually undergoing assessment and revisions. And this assessment will certainly be influenced by the latest events.
1 minute.
I won't have time to go into it today, but our group combines different methods and fields, including risk analysis, social psychology, and policy assessment to examine the underlying assumptions in these policy and oversight designs, and also examine the organizational and governance strategies that might be used to adapt those policies in response to new information. So just to conclude, COVID-19 will certainly change how we think about biological threats and how they should be managed, including how we manage the innovations in science and technology that can both mitigate and cause wide societal harms. The stakes are high, and we need more work to understand how we respond and manage risks in the midst of great uncertainty in ways that are closely coupled to those on the ground, making real-time decisions and informed by a variety of different disciplines. Thanks very much for having me join you today.
Thank you very much, Megan. So for our final panelist, we're going to now move to Iram Alam, who is a professor at Harvard University, where she teaches in the history of medicine. So we've gone from information and misinformation and infodemic to broader issues in biosecurity, and now someone whose chief scholarly focus is on the history of medicine for a look at how COVID-19 is interacting with longstanding issues of xenophobia.
Thank you so much to organizers for all of their efforts in putting this together so quickly and for inviting me to contribute a few thoughts and preliminary observations on this present pandemic. So my talk is called Foreign Bodies, COVID and Xenophobia, and I'm interested in exploring how the virus as a vector of disease that is foreign to the body gets collapsed and equated with bodies that are considered foreign to an imagination of the nation. So here I'm really thinking about the terms that I'm sure we've heard, Chinese virus, Kung flu, Wuhan virus, foreign virus. So this rhetorical slippage that happens has significant consequences, I argue. And the most obvious is in the increase in hate crimes and racist incidents against the East Asian American community over the course of the last few months. So as a historian, I am going to provide a slightly different perspective on this question. And what I am attentive to are the logics and the discursive frames that are really marshaled in these acts of naming and of violence and of excavating the residues from the past that help to explain this present phenomena. So in the very brief time that I have, I'd like to highlight two historical threads that I think have really come together to activate and embolden xenophobia in relation to COVID-19. So I teach a course on the history of medicine and health in America. And on the first day of class, which was January 27, 2020, I showed my students the following set of political cartoons. So the first is from May 1882 and depicts San Francisco, close to where many of you are at the moment. And emanating from the boats in this image and from a congested residential space are three spectral figures with the words malaria, smallpox, and leprosy written on their garments. And the figure on the far right is sending some kind of vaporous discharge or maintaining some sort of miasmatic link with the region labeled Chinatown. So just a few weeks prior to the publication of this image, the US Congress passed the Chinese Exclusion Act. This bill was the first piece of immigration legislation that prohibited the entry of Chinese laborers into the United States and also prevented Chinese people who were already in the United States from becoming US citizens. So the passage of this piece of legislation was heavily motivated by the fear of a contaminated Chinese body shedding contagion everywhere, coupled with this economic anxiety about Chinese laborers stealing US jobs. And through this act, I think an antagonistic relation to something, some figuration of what something of Chinese was codified into US law. So the second image that we studied was this one from January 23rd, 2020. And in this illustration, there are shipping boxes labeled with the Corona Wuhan virus and a Reaper figure on the left saying or thinking, quote, a Chinese export with a tariff you don't want to pay. So in this depiction, the spread of viral contagion is refracted through Trump's trade war with China, once again emphasizing the entanglement between biological and economic logics. So taken together, these two representations, spaced 138 years apart, do reinforce the idea that an adversarial and paranoid relation to the Chinese body is required to prevent US biological and economic death. And in this project of preserving US life versus Chinese death, every US citizen is always already conscripted, which is my second point. So many scholars have provided an in-depth analysis of this state of permanent war and total war that was inaugurated after World War II and reconfigured and expanded during the War on Terror. So in this new regime, war is no longer an event that occurs on a battlefield between two sides, friend, enemy, bounded by time and space. Instead, it's a permanent state of militarization that enrolls a civilian population in the continual project of risk assessment and mitigation, exemplified in the statement, if you see something, say something, that I'm sure we're all familiar with after the War on Terror. So in this injunction, identifying and naming an enemy, which is often conjured using some combination of history, fantasy, and anxiety, is followed by this rapid commandment to act, justified by the moral imperative of security. So what total war does is it condenses this reaction time, and delay is a disaster. And in return for this participation and vigilance, there's this promise of total security and total control, and a closed and impervious body politic. So our present moment is a little bit tricky in relation to this concept. So when the metaphor of war is explicitly activated against a disease, hospitals become battlefields, care workers are on the front lines, and every patient is a possible warrior, the civilian come patient is called to stand at attention and urgently search for an enemy. But a viral threat poses a peculiar kind of challenge for this total war apparatus. So each body has the potential to host a virus, but also to be held hostage by this foreign vector. So the vigilant citizen who's enrolled to surveil the threat can morph into the asymptomatic weapon of mass destruction through a simple doorknob. They can become the very terror that they're enlisted to police, turning into the most intimate kind of enemy and carrying the foreigner within. So this risk becomes omnipresent and uncontainable. And so what we're seeing is an externalization of this unknowability and anxiety into familiar racialized tropes in ways similar to what happened after 9/11, With COVID, though, it's the resurrection of the script, which has framed Chinese bodies as diseased and a plague on American life for over a century. And I've been thinking about the language of security and vigilance, which is tied to social distance at this time. And I wonder how conceptions of the social are actually being defined and redefined in this moment, and urge us to think about who gets included in this idea of the social. Thank you.
Thank you very much, Professor Allen. So I'd like to ask all of our panelists now to rejoin us. You can unmute yourselves and rejoin us on audio. And my co-host Russ as well. I'm going to toss it over to you for the first question for the panel.
Great, and I see everybody. Thank you very much for your really stimulating comments. So as you know, this conference in part is about AI and its impact on this pandemic, either anticipated or unanticipated. And I'm wondering, for whoever would like to answer this, in each of your areas of scholarly work, is there interest in the field or action in using AI technologies? So for example, Kate, for tracking the infodemic or tracking what the collective sense-making is. For Renee, for tracking this white to gray to darker government data sources. For Megan, the biosecurity risk tracking, and for Iram, the historical analysis community. I'm sure you're all trying to manage tons of data. Is AI there yet, or is it mostly still a promise? And who would like to go? We can go in the order of our speakers, so maybe Kate first.
Sure. So I guess let's think about it in two different ways. As a researcher, is AI there? There are machine learning tools that we would call artificial intelligence that we use as part of our research. It's one tool among many others. We use visualization. We use a lot of human-powered things as well. But we definitely have natural language processing type things in our research repertoire. In terms of real-time addressing misinformation and the infodemic or whatever we might want to call it, I mean, when we think about what the platforms are doing, certainly they are at least talking about using AI, and AI is a part of what they use to find misinformation and figure out what they need to address, although it's imperfect and still needs humans in the loop to have it work well.
Renee?
Yeah, I would echo everything Kate said. We use similar technologies for our research, particularly into social media, social networks. I would say on the propaganda front, the issue is really much more of a policy one at this point. It's not that we don't know it's there. It's not that we can't see where it's coming from. It's really more a matter of how do we think about how far it spreads, how much automatic lift it gets, and what the appropriate response is. Recognizing it is disclosed, so it really becomes much more of a question of national values informing the public. Excuse me, it's just much more of a social issue at this point.
Thanks. Megan?
I'd say machine learning and AI is increasingly an important part of the tool set being used in biological sciences and the discoveries that we need to sort through vast amounts of genomic and other types of data. So that's certainly part of it. And then we also see its use in areas like attribution that are an important facet of biosecurity in an uncertain landscape. And so certainly already there, and we're seeing it increasingly part of an integrated tool set.
Thanks. And Iram?
Yeah, within the digital humanities, I think this really provides a great platform for amassing huge amounts of data to be able to look at change over time in ways that are unprecedented. Access to digital records and archives, I think, provide openings that just were not possible for one person to be able to access and to use previously. So it's enriched the kind of work that we do and the scope that we can do, certainly.
Thank you.
Good. Let me now direct a question, I guess, chiefly to Renee and Kate, and then I'll have a second one for Megan and Iram in just a second. But you both, Renee and Kate, have been studying the platforms as well as the way that information circulates on platforms for a long time. Both of you, if I caught the words correctly in your presentations, said that many of the platforms have, in certain respects, risen to the challenge of the pandemic and begun to either foreground authoritative information in a way that they never had before, or to really make vigorous efforts in a way they hadn't before to downrank or eliminate false information, conspiracy theories, etc. I wondered, can you first, is that an accurate assessment in your view that the platforms have performed better in the face of this particular controversy than in the past? And then second, what do you think that augurs for the future? Do you predict better judgment, better performance of the platforms in the face of standing misinformation and disinformation? I'll go with Kate first.
Oh, that's okay. It's a hard question. I would say they've taken stronger actions than they've been willing to take around misinformation in the political context, for instance. And I think there's something about crisis events where we as a public may be more willing to accept heavier-handed policies around misinformation than we would be in the political context. And so their policies are more content-based than behavior-based than we're used to. They've added content-based things. And so there are things there that I think are going to be more effective against misinformation, but also will begin, if they get extended past this context. And even in this context, there are some worries that that they might be stifling some kinds of contestations that, especially when they privilege authoritative voices. In some contexts, that sounds great. In other contexts, well, that doesn't sound so great. And so I've been critical of similar policies in the China context, and now here we're seeing them in the U.S. and we're in some cases celebrating. So as a researcher, it's a tense moment. I really think we need to have a period of reckoning about the changes that they've made and see if there are things that we want them to extend, or if they demand sort of new criticism as the crisis resolves.
Yeah, Renee.
So I'll say two things. One, a lot of the policies stem actually from policies undertaken in response to the measles outbreaks of last year. And I had some conversations about those as the policies were being formed, because at that point, one of the interesting things is that the science was really quite settled with measles. There was not a debate about this. Was not a new disease that no one had ever seen before. There were extremely high death tolls in misinformation dense environments like Samoa. Over 70 children died. So there was a clear demonstrable impact that the anti-vaccine movement was having on these outbreaks. And so we did begin to think about how do we surface and downrank, so surface authoritative, downrank the grifters, the conspiracy theorists, and the anti-vaccine groups. And there was a balance that was struck. We allow them to exist. They continue to exist on the platform, but they're de-emphasized. The platform removed them from their recommendation engine and de-emphasized their conspiratorial content. And in return, what it did, the other side of that was that it did amplify the CDC and the WHO as authoritative sources for information about that outbreak. Now, this has become a bit of a controversy now, because as we discussed in the last, as your speakers in the last session raised, the CDC and the WHO are operating with incomplete information at the moment. This is a new disease. This is something nobody's seen before. As Kate raised in her presentation also, what that's translated to is poor communication from the institutional authorities. And so the question now is, how do we think about that balance between the recognition that occasionally established authorities or institutional authorities will get things wrong? And how do you ensure that your marker for authoritativeness is not institutional credentialism, but that there is an opportunity for authoritative voices who are still medical experts, who are still scientific experts, or who are still, talented emerging researchers? So how do you continue to minimize the grift and the conspiracy while at the same time recognizing that you don't want to over-index on institutional authority?
Yeah, great. Thanks a lot. That's really interesting, because I think all of us here in the United States and elsewhere have been wondering about the performance of the large platforms when it comes to election issues. And now we see a different kind of response, and all the questions of authoritative voices ever present. So thanks for those reflections. Megan and Iram, I want to direct the next question at you primarily, picking up a thread also from the earlier session we had today, in which various of the speakers indicated that for the data to be good, either to build models on which to predict the path of the pandemic, or to install various ways of monitoring at scale, that we need surveillance technologies in order to secure ourselves from these biopandemics. Megan, that was one of the things you mentioned in your presentation. And then when I hear that and I pair that with an historical account of the actual response through surveillance, that's not just general across the entire population, but disproportionate and targeted perhaps in certain ways, and not always just for the purpose of biosecurity. Megan, I wonder if you can reflect upon how you would respond to the historian who says surveillance doesn't always work out just for biosecurity's benefit. And Iram, I wonder if you could reflect upon Megan's challenge, which is for better security against the very ravages of the pandemic, surveillance technologies might be necessary or are indeed necessary. So Megan, can I start with you?
Yeah, I'll admit, I think this is a really difficult challenge, and one that spans all the way from policies to the details of implementation, and asking questions of what we're willing to trade off for the public good in moments of crisis, and how we keep an eye on the long-term effects this has. It's very difficult to do that, and so we need to make sure that we're building the infrastructure early that can carefully manage the trade-offs between information sharing, protection of privacy, and whatnot. I'd say that we're certainly not asking the right set of questions all the time when we're in a moment of crisis. And so I see many of my colleagues also struggling with how we build the types of platforms in real time to do effective collection and sharing of data. And the ones that have been often the most effective are the ones that were built in advance. So we mentioned, even NextStrain as an example of a platform built in advance that could be leveraged. In other cases, we're seeing data cropping up in multiple different platforms, and you run into the same questions of what to trust.
Yeah. Thanks, Megan. Iram, would you like to get in the conversation too?
Sure. Yeah, I guess my thought is just that I think we always have to remember that surveillance or any kind of technology is a social technology, that it's not divorced from the ways that it's implemented, and that the use of it is always going to have a relation to actual material consequences. And so I guess just keeping an eye to that, as not giving it the status of just a scientific universal good, but kind of inserting a question into what that is I think the challenge. And the limit of how much and when and where, I think that is a very difficult question. It's a question of saying whose life, when, how many, which is once again a very, very difficult question. But I also think we need to recognize that a lot of the infrastructure that we built around this question of the pandemic has some kind of vision of a nationalistic border. And that is a difficult thing to actually think about in this age of globalization and the permeability of all of us to everything. So, to really keep that, I think, in mind as we do build these kinds of models, that there are many, many downstream impacts in other countries that are related to the actions that are taken by the US and the UK.
Yeah, thank you for that. Now, a question from the audience that's come in that I think gives Kate, Renee, and Megan perhaps a chance for an exchange. Of course, Aram, get into the conversation too if you wish. Several people from the audience have written in to ask what to make of conspiracy theories that allege that COVID-19 was birthed in a bioweapons laboratory or a research lab and then deliberately unleashed upon the world. What does that mean for your world, Megan, of biosecurity, that such conspiracy theories are out and about? And Renee and Kate, what do you make of conspiracy theories as such in these particular moments?
So I think this speaks to both how difficult it is to combat conspiracy theories, and the reason I'm grateful for a fellow panelist today, and the difficulty of forming an evidence base in the midst of uncertainty, right? We have high-profile publications that essentially argue that we have no evidence base to assume that this came from a bioweapons lab or is engineered. But at the same time, we will continue to persist in any type of outbreak or pandemic with uncertainty over the exact origins, right? Where patient zero is. And so that's the challenge of how we communicate uncertainty and the continued collection of data to get and refine our understanding of the origins, while also combating these conspiracy theories that are politically motivated, right? And have different political ends. And so, what we can do as a research community is, I think, continue to point to the lines of evidence that combat against these conspiracy theories, and but at the same time refine our communications, that we need to get better at building the evidence base in the midst of crisis, on exactly where risks originate now, and where they might originate in the future.
Renee?
We did a trace of the conspiracy narrative, the Chinese version of the bioweapon narrative, which says that during the world, I believe it's the World Military Games is perhaps the name of it. U.S. representatives were in China, in Wuhan. There was a cyclist. He was stationed at a fort. The fort did bio research. Ergo, of course, he brought the brought the virus over. That's the rough sketch, and you can follow through the timeline of how that made it from the kind of underbelly. A lot of the conspiracies are often bottom up. The bioweapons one is absolutely, it pops up every time there's an outbreak. Russia used it as a narrative during the AIDS crisis, actually, as KGB propaganda. The idea that the CIA had created AIDS, that AIDS was a bioweapon that had gotten loose. They changed the variants according to what would make the most sense in the region. You see Iran talking about the virus as a bioweapon in this particular case, saying that it is actually tailored to the genome of the Iranian people. You see RT amplifying the Iranian state conspiracy, because there's a difference between the kind of bottom-up conspiratorial communities versus when you see conspiracy as as statecraft. I call it tinfoil diplomacy, but it's just the idea that they are that actually the conspiracy becomes part of the public diplomacy communication. And one of the reasons they do it is to create a distraction. It also it removes responsibility from the leader if it's something that's been done to them by the outside, and so it creates an attitude to distance official responsibility, official failings, if this was something that was done to the state by someone else.
Mm-hmm. Kate, anything to add?
Yeah, there's not much more to add. Just as a researcher, misinformation, disinformation, and conspiracy theories, it just didn't surprise me at all. I mean, it's just like, of course that's going to happen. Oh, and everybody's going to point fingers at someone else for exactly the reasons Renee is spelling out there. It's not surprising. It's part of the, information space, and seems to be a tactic that must be working at some level, because it keeps showing up in event after event after event.
If I could do an add-on to that, Rob,
yeah,
and maybe specifically to Kate. Kate, in your comments, you mentioned that the social platforms have, in a somewhat impressive way, intervened and are trying to do filtering. Do you know the degree to which they are in concert with one another and trying to share best practices, or is this each social media platform kind of doing their own thing and hoping that the net effect is positive? I can see arguments in both directions. I'm wondering what the facts are, if you know them.
So we might have to ask Renee here. I would say I don't know them right now. Over the last couple of years, we have seen them try to figure out ways they can collaborate on misinformation, disinformation, without sort of violating privacy kinds of things and commitments that they have to their different users. And so they are still working on what that means. I can see the policies building off of each other, but I don't know exactly what's going on behind the scenes right now for the tech companies.
Iram, there's a question from the audience for you, which has to do with whether or not you have a view about the very different reaction in the United States, in particular, to the fact that suspicions of Asian Americans who might have brought the coronavirus with them from Asia to the United States are quite different than Europeans who might have traveled to the United States and also brought the coronavirus with them. Do you see evidence of xenophobia in the very different reactions there? One of the questioners wants to know.
Yeah, and I hope that my talk and in showing kind of the imagery from the 1870s was to show that there is continuity in the construction of the diseased Chinese body, and this is something that has been activated and reactivated over and over again. The Chinese person in relation to their diet, and this kind of foreignness is also a very, very common trope that was used in the times that 1870s, 1880s, 1890s, and continues to be used today. So there are figures that we see through history, especially in the United States, that are kind of given this forever foreign status, and irrespective of the time in this country or generationally, there's always this distance that will remain with that group. And I guess that's just they're not able to assimilate within this fold in a way that the European body is able to do that. And so the foreignness of the virus gets overwritten by the foreignness of the body, and these two things feed off of each other in this kind of loop to condense, and collapse a viral body into a foreign body.
One of the things which I'm curious to ask anyone on the panel about has to do with the various ways in which any of the things you've presented might be discussed either with parents to their children, perhaps with teachers to their elementary, middle school, high school age children. There's a bunch of questions that ask something in the neighborhood of the following: in an age in which there's rising distrust of authorities in general, and even in this moment, conspiracy theories and Zoom bombing, all kind of terrible behavior in the face of a global emergency. What kind of advice would you give to a parent trying to help steer their children through the information universe that's before them, or a teacher and to their students? And I mean, for an ordinary parent with a teenager, it's of course Instagram or TikTok that is a chief source of information at the moment. And I wonder if, in the light of history or in the light of any of the research that you've done in the contemporary moment, you have advice to give to parents or teachers as they confront talking to children about how to think about what's going on. Kate?
It's a hard question for me because I've spent a lot of time the opposite type situation is explaining to teenagers and young people for them to teach their parents to do the right thing, because this is not a problem that just affects young people in terms of figuring out what to trust and how to make sense of information. And in fact, we talk about it as a K through 99 problem, is that we're all sort of struggling with these information spaces in different ways. And I don't know much about the sort of psychological needs of children in crisis events. That's not my area of expertise. And certainly there are a lot of impacts that are happening there that are just, I guess, beyond my expertise to talk about. In terms of the online engagement, again, it's like, less of it right now is probably better. And to focus on watching your local news once a day and maybe doing a little national news, but not to sit there on social media all day. And yet it's so hard to say that to a young person who that's the only way they have to connect with the world right now. And so I would just say to have those conversations and have them to be two-way conversations as well, because I think the young people have a lot to teach their parents.
Yeah. Ira, Megan, or Renee, any last words before we wrap up this session?
I might just so part of the work that my group does is actually understand the psychology of risk, how we conceive of risks over time, and work a lot with biological scientists and engineers and others on to what effect they take risks seriously. And so what we're seeing is that there wasn't a lot of overlap between the groups that studied biology and the folks that studied international security in the past. And I think we're going to see more and more those coming together as we realize both the scale of the threats, but also, frankly, an inspirational note about seeing the scientific community really rally together to try to confront these types of risks. And so I think it's a question of contending with the scale of the risks that we need to manage, but also a hopeful, inspiring image of what we can do when we work together. That's not just a technology problem, but certainly a social problem.
Mm-hmm.
On that, being a social problem, I think also paying attention to the cyclical nature of these kinds of problems and really thinking through the kinds of social dynamics that produce and reproduce these, I think is also an important thing to keep in mind.
Renee, any final words? Or
no, I think it's I think one of the key challenges we have right now is how do we appropriately communicate to people where institutions got things wrong, but also contextualize that? That's really, I think, one of the areas that's I've been the rest of the conference looking to others for guidance on how we do that. It's one thing to point to overt conspiracies. It becomes really challenging when institutions are getting things wrong or slow to react and are not transparently communicating. We're seeing a lot of failure at a lot of levels at this point. So it's a significant challenge going forward.
Good. Well, I want to thank all of you for your time today. And as a way of drawing this entire session to a close, I think from my point of view, my training as a philosopher doesn't give me any of the social scientific expertise, the biomedical expertise, or the historical expertise you've seen. But philosophers are so often deeply rooted in the past and see the evolution of ideas over the time of centuries. And one of the things that's notable, thinking even philosophically about the coronavirus, is how societies have been changed profoundly in the wake of global pandemics, as well as global wars. And we're just at the beginning stages of understanding what both the possibilities of positive change might be in order to allow ourselves a more global interdependence as a way of confronting the challenge, or perhaps all kinds of destabilization and a reconfiguration of geopolitical power. And that's part of why we want to bring this multidisciplinary approach to thinking about the challenge of coronavirus to you today. So Kate, Renee, Megan, and Aram, thank you very much for your time. We're going to take another break before we move to our third session of the afternoon. And we'll be back with you in just a short amount of time and look forward to your questions then. Thanks very much for joining us, everyone. See you soon.
Welcome to the third session of our conference, AI and COVID-19. This third session is entitled Tracking the Epidemic. We're going to talk about technologies that are being used or developed or imagined for tracking this epidemic. We have an exciting lineup of speakers, and we're going to go right into it. The first speaker is Dr. Jason Wang. Jason is from Stanford University, and the title of his talk is Taiwan's Use of Data Analytics to Control COVID-19. Jason, now is a good time to share your slides and your thoughts.
So just wanted to give a little context here. So Taiwan is a democratic country about 81 miles off the coast of China. In January this year, it had its presidential election, and where 75% of the people voted. So this talk is about Taiwan's response to COVID-19 based on a JAMA paper. And you can look at for details. There are 124 action items that's described in the paper. So after SARS in 2003, Taiwan has been thinking about how to prepare for the next epidemic. And so it had passed a series of amendments to its Communicable Disease Control Act. That includes trying to keep track of all the protective equipment stockpiles, setting up a National Health Command Center for coordinating government agencies, putting together a set of regulations for gathering, entry, and exit of people and traffic. Also amend the law so that there's penalties for violating home quarantine and isolation. And then, for the purpose of this talk, a set of laws to track and manage people under infectious risk, and also allows geographic location and total number of patients to be made public in an aggregate manner. And then finally allows the public property, including military camps and so forth, to be used and facilities to be made for essential equipment. So here is the Taiwan's National Health Command Center. So as you could see, it has room for different data analysts to get the data from different local and state national governments and internationally. It has a media room to report to the public what they're doing, and you could also sleep there because it is a lounge. So it's a 24/7 operation that could host 100 people. So this is what it looks like, and this is what's happening right now. From the data, they have a National Health Insurance Stockpile System, the National Health Insurance Infectious Disease Statistics System, and the Media Surveillance System, all in the command center. So the first thing that Taiwan did this time was to recognize the crisis. And so immediately after December 31st, when there was a report of a suspicious coronavirus coming from Wuhan, Taiwan immediately sent people onto the airplanes that were coming from Wuhan to check for their symptoms. And on January 20th, they activated the command center and had a national security meeting convened where all the ministries are supposed to act really quickly. So this is how they do it. They boarded the flights to make sure that people won't bring in and having fever and coming into the country without being checked, because there was suspicion of human-to-human transmission. So when people landed, what they did was they scanned a QR code. The QR code would lead to an online declaration form. And an online declaration form, you fill out your travel history, where you have been in the last 14 days. And if you've been to a hotspot area or not, no. And also you fill out your symptoms, cough, respiratory symptoms, or signs of fever. Then you fill out your cell phone number and the place that you're staying in Taiwan. So if you didn't travel to a level 3 alert country, like if you didn't come from Wuhan or in later on South Korea, you will get a SMS sent to your phone that says you passed, so you could go quickly through customs. Now, if you went through high alert countries, level 3 countries, you need to do a 14-day quarantine. So during the 14-day quarantine, they will bring you food. They will track you to make sure you didn't go outside and to make sure that you didn't get on the metro and infect other people. And then later on, they start paying people under quarantine with the daily wages equivalent to GDP per capita. What they also did was they linked the National Health Insurance database with the Customs and Immigration database, so that when the doctor sees a patient in clinic, the doctor will be alerted, or the nurse will be alerted, that this person has traveled to Wuhan. So then they will be putting on protective gear. Basically, they will triage them separately, and then they will index suspicion for COVID-19, and then order a test if it's necessary, if they believe that there's enough evidence that this patient might have that. So this way, they allow them to quickly get at the people through their system. So this is a picture of the alert at the point of care when a doctor sees a patient coming from level 3 alert countries. What they also did with the data is that they immediately got a quick count of the nation's stockpile. So on January 20th, they told people there are 44 million surgical masks, 1.9 million N95, and 1,100 negative pressure rooms. So what that tells people is, people did a quick math, said, 44 million surgical masks. Taiwan has 23 million people. Well, that's less than 2 masks per person. So then the next day they said, well, we are going to ban mask exports to outside, and we have to make more. So then what they did was they got all the best engineers together to hack out 60 different supply lines, and they immediately got the raw materials necessary to make masks. So they increased the mass production from 2.44 million units per day to now 11 million per day. And as of today, they are going to be donating masks to the United States. So this is what they did with the Diamond Princess cruise ship. So this ship actually went to Taiwan on January 31st, before it went to Japan. When it got to Japan, they would discover that there were numerous cases. So people in Taiwan started to panic. So what the government said was that, okay, we'll give you the 50 places where the visitors from the Diamond Princess had been, and then they will send text messages to people who had been in that vicinity based on their cellular data. So that this is on the right, this is the text message they will get in. If you have been to the following places on January 31st from 6 a.m. to 5:30 p.m., you could check out this map and then call the number 1922. So the government will check on you. This is a map of the masks. So they created an app for people to track whether they could buy masks. And then even they have an inventory. The green is, if they still have 50% inventory. So the government for each store give them 600 masks per day to sell. So you could track the closest location to you to get the mask. They also monitor temperature for buildings. So if you walk in and you light up, then you can't get in without getting additional checks. Then they communicate with the public daily. The government now has 90% approval rating from the public for the handling of the crisis, and it's got the lowest per capita infection rate and death rate in the world. So they need to continue to monitor. Most recently, they have people from the US and Europe going to Taiwan because it's safer there. There must be a balance between emergency power and maintaining civil liberties, which I'm currently working with Michelle Mello in the law school to do that, to better understand that. Basically, they've worked on logic and sequence and tempo, when to do things fast, and then articulate it to the public. And that's what they have done. Thank you.
Thank you very much, Jason, for that great glimpse of what happened and how it was managed in Taiwan. Our next speaker is Lucy Lee. Lucy Lee is from Chan Zuckerberg BioHub and is going to be speaking on tools for estimating unreported infections of COVID-19. Lucy, please share your slides, which I see you have, and take it away. Thank you.
I work on the data science team at the Chan Zuckerberg BioHub based in San Francisco. I'm particularly interested in combining pathogen genomic analyses with mathematical modeling and machine learning approaches to help understand the transmission of infectious diseases. So I'll spend the next few minutes talking not about the COVID infections that we observe, but rather those that we cannot detect, and discuss why it's important to quantify the number of undetected infections. So not all infections are detected by healthcare systems. This can be because the symptoms are too mild for the infected individuals to seek healthcare, or there's a limit on the number of tests that can be performed, or there could be restrictive criteria for selecting individuals for testing. Regardless of the reason, the consequence of a large number of undetected infections is that infections can spread latently through the population, which is a problem when those infections end up in vulnerable individuals. Furthermore, this also facilitates pathogen spread across large geographical distances when those infected individuals are able to travel when they are infectious. And lastly, when considering eliminating a disease from a region, it takes much longer to be certain that the disease is gone. So how can we estimate the number of undetected COVID infections? The most obvious solution is to do more testing, not just of symptomatic individuals, but of the population at large. I highlight here a few examples in Washington, in South Korea, and on board the Diamond Princess cruise ship. These methods are very useful for quantifying how many cases are asymptomatic or mildly symptomatic. However, this process is obviously very expensive and time-consuming and may not be doable when resources are already constrained. So besides trying to directly detect the usually undetected infections, we can use modeling to infer what those numbers are based on when and where infections occur. I highlight here a couple of examples of this approach to quantify the number of undetected infections, both of which found very low rates of detection based on early pandemic data. However, there's usually a great deal of uncertainty in modeling results at the start of a pandemic. Adding in additional sources of data can improve the accuracy and precision of estimates and reduce potential biases from single sources of data. So besides case count data, another source of data that is informative of the number of undetected infections is the virus itself. I link here a blog post by Trevor Bedford, the founder of NextStrain, who did some back-of-the-envelope calculations to infer how many undetected transmissions had occurred in Washington by March. So what information is contained in the virus that allows us to estimate the number of undetected? Let's assume for a moment that we're able to test every single individual and track every single transmission in the population. If we sequence the viral genome, we can see that it mutates as it transmits through the population. This is a process that happens to all living organisms. Every time DNA is replicated, there's a chance of mutation. The viral genome, after many rounds of transmission, starts to look different from the original virus that infected the population. Now, let's assume we are only able to test 1 in 4 infected individuals. If we know how quickly the virus mutates, we can infer how many missing transmissions could have occurred between the tested cases. So in my work, I modeled both the time series of case counts at the start of the epidemic, as well as the viral genomic diversity to quantify the number of undetected infections. The viral genomic data are represented here by a tree. Each tip on the tree represents a viral genome, and the closer the viral genomes are on the tree, the more related they are. So using just data from Hubei, the province in which Wuhan is located, I found that only about 1 in 7 infections were detected in the reported time series. Once adding in infections outside of China, that number was potentially as low as 1 in 20. This large number of undetected infections is in the same ballpark as what was reported in the other modeling studies I referenced earlier. This means that by the time 100 confirmed cases are in the community, there could be as much as 1,000 other infected individuals who are not symptomatic enough to be hospitalized and could transmit the disease undetected. This is why, in the absence of a vaccine, population-wide social distancing is needed to get the case numbers down. Since I started the analysis of this pandemic data, the epicenter of the pandemic has shifted to other parts of the world. So the next step in my work is to use this approach to quantify the undetected numbers in different countries and regions and elucidate what fraction of the undetected cases is due to mild symptoms versus limited testing capacity. Another implication of this large number of undetected infections is in the recommendation for face mask usage. So this article just came out in the New York Times that highlights the significant role that asymptomatic or mildly symptomatic cases play in continued transmission of COVID-19. And this may lead the CDC to recommend broadened usage of face masks in certain public areas, such as supermarkets. So before I finish, I wanted to highlight some of the other COVID-related work that is happening at the BioHub, which for those of you who are not familiar, is a nonprofit biomedical research organization based in San Francisco. So recently, the BioHub became one of the COVID testing labs, helping to expand the testing capacity in the Bay Area. In addition to diagnostic testing, we're also interested in a number of research questions involving the analysis of both pathogen and host data. So in the interest of time, I won't read out all of these names, but I want to make sure I acknowledge the contribution of these groups of people, as well as the research and medical communities globally who are coming together to improve our knowledge of this pandemic disease. Thank you.
Thank you very much, Lucy. Before I introduce our next speaker, I want to remind the audience online that they may submit questions on the main page for the conference. You'll see a link that says click here to join the conversation. You can submit questions, and then our team will be reading them and feeding them to us during the Q&A, which will be at the end of this panel session. Our next speaker is John Brownstein. John is at Harvard, where he studies methods for real-time mapping of COVID-19 cases worldwide. Thanks, John. I see that you're already sharing, so take it away.
All right, great. Thanks, Russ, and good to be here. I'm going to be telling you a little bit about a variety of our activities that we're engaged in right now as far as COVID surveillance. Obviously, it's all work in progress. So the idea here is just to give you a sense of the kinds of things we're actively doing and some preliminary results. We've been tracking coronavirus since the emergence event in late December. And this is just a graphic showing the data that we're collecting over time as it spread globally. And the reality is being able to create a visual and sort of a situational awareness of this kind of data is really challenging given the lack of sort of official sources. The earliest signs of what took place in China were actually through our data mining tool called HealthMap, where we identified the earliest signs of the outbreak through mining in Chinese language and local news media, WeChat, Weibo, and highlighted the fact that you could use these tools to basically uncover what's happening in population. It's something that we've been doing for many years through many disease outbreaks. The reality is that the only way to create sort of a situational awareness view of what's taking place is through mining of all this information and collating it. What we quickly realized is that as much as it's easy to sort of scrape the web, to create a real detailed line list of cases around the world, you need sort of an army of people. It can't just be done through machine learning and web scraping. And so we created a network of organizations from from Oxford, University of Washington, Northeastern University, many others, that essentially created a global line list of cases. So combing the web through official and unofficial reports, creating a detailed line list of every single case around the globe. And that becomes more and more challenging over time, clearly. But that ultimately now resides in a public site on Health Map. And that data is made freely available. And because that data was heavily curated and made available, it's generated a whole set of publications all aimed at forecasting and understanding sort of the risk in different populations, and especially understanding the efficacy of various interventions. This is a paper we just published in Science last week, which essentially utilized our line list data along with mobility data from Baidu. And because Baidu has highly granular data on population movements, we could connect movements to sort of case information. And as soon as interventions started coming into place, we saw the massive drop in cases that were taking place in China. So that's just one example of a way that once you built a really detailed case count, you can actually start to fuel a lot of both the science as well as policies related to interventions. We're doing this in a whole variety of ways, not just through data scraping, but through collecting data from the general public. This is our tool called Thermia, which is actually identifying fevers in populations through sort of a decision tree. This is something that we launched years ago and connected that to smart thermometers like the Withings Thermo device. But the reality is we actually already had in play a fever calculator in China at the time. And so what we were doing was actually collecting data, not just from official sources, but through people that were disclosing symptoms as well as temperature. And of course, we saw the bubbling up of case or symptomatic cases, which not necessarily confirmed, across China at the time of the emergence of COVID. So again, another good example of how this sort of collected data across the population can be incredibly valuable. We've extended that work with a number of different symptom checkers. This is a company called Buoy that we're working with. It's an AI-driven conversational chatbot that we have helped sort of customize for the purposes of COVID. And already this tool has been widely deployed and shows incredible diagnostic and triage accuracy. And so right now, this tool now has been made available for the state of Massachusetts and more broadly, where essentially the case definition for COVID has been entered. And so now anybody who has sort of, potential symptoms around COVID can go through this sort of conversational interface. On the other end, we're going to be collecting data from this tool to basically improve our surveillance efforts at the local level. A lot of our work is not just about sort of getting sort of the digital exhaust from patients, but it's also crowdsourcing. This is a project we launched actually 9 years ago off the movie Contagion called Flu Near You, where we engage people to answer a few questions and then essentially get a national army of people responding about symptoms across the country. And what's phenomenal about that is you can, for instance, look at the emergence of flu in a population very easily. We've now adapted this for COVID, so COVID Near You, which is now launched about a week ago. And this has been crafted to have specific symptoms that relate to COVID, as well as collecting testing data. Of course, clearly, we have a lack of testing across the country. So being able to have insights into patterns, emerging hotspots, can be driven heavily by individuals just contributing information. And so right now in the system, we have over 260,000 people now reporting symptoms and doing that at a fairly frequent clip. And so from that, we're now, of course, in the process of analyzing all this information, looking at demographic patterns, symptom patterns, connecting that to testing data, looking at contact tracing, and of course, lots of other opportunities as this emerges. We're actually expanding this to other countries at the moment. The last thing I'll just mention is it's not just about mining for case information and events and symptoms. We're working closely with the CDC to build tools to actually have understanding of social distancing impacts. So what are communities doing to prepare for coronavirus? There is no sort of unified data set to look at school closures or closures of various community events. And so we're pulling together all that policy information and events at the community level to then provide sort of a common operating picture for the CDC as they're trying to understand sort of the variation in sort of interventions that are happening across the country. And clearly being able to have that kind of data and matching that to epidemiological information will be super important to understand the efficacy of the various interventions. And we know that there's major variation across the country. Obviously, many places not had stay-at-home orders. Many places we're not seeing as much sort of adherence to sort of the general policies that have been put out. So being able to connect this kind of data with epi data, then we'll be able to do some of the same studies that we did for China. So I'll leave it there. Look forward to discussion. And sorry again about the technical difficulties there.
Thank you very much, John. Really exciting stuff. Our next speaker will be Ryan Tibshirani. Ryan is from Carnegie Mellon University, and he'll be speaking on epidemiological forecasting tools for COVID-19.
Yeah, thanks for the intro. My name is Ryan Tibshirani. I'm a faculty in statistics and in machine learning at Carnegie Mellon University. I work with a group that Roni Rosenfeld and I co-lead at Carnegie Mellon called Delphi. We are one of the CDC's 2 centers of excellence for flu forecasting. And I recently became an Amazon Scholar. So just a quick note before I begin. I am not a public health expert. I'm a statistician who has been thrown headfirst into what has been an exciting and a kind of extremely challenging effort in pandemic forecasting with the CDC. So just take that as my background as I describe kind of where I'm coming from and what we're doing. So first I wanted to just tell you a little bit about the efforts we've been doing for many years, which are very relevant to what we're doing now. We've been working on flu forecasting at Carnegie Mellon in the Delphi group for about 6 or 7 years. Influenza is a major global public health problem. It's associated with between 250 and 500,000 deaths each year, as estimated by the World Health Organization. And in the US, it's typically between 30 and 60,000, but we do have bad seasons, like, for example, the worst season in recent memory was the 2017-18 season, in which the CDC estimates about 80,000 flu-related deaths occurred. So as I mentioned, we've been doing this at Carnegie Mellon since about 2013. And interestingly, what prompted us to begin this was that CDC has at that year begun a forecasting challenge every year for seasonal influenza. There are about 40 systems that participate in recent years. Each one of these systems is put forth by typically an academic unit, but there are also some units in industry who participate. This is kind of completely community oriented. There's no compensation, obviously. We are all doing it for the purpose of advancing science. Why does the CDC care? They care because forecasts of seasonal influenza can help them essentially with preparedness and countermeasures. So things like planning vaccination campaigns, figuring out if we can get the forecasts to be granular enough spatially, figuring out how to better staff hospitals, free up hospital beds, free up ventilators, et cetera. Our group has had the highest accuracy forecasts every year except for the last year, in which case we had the second highest accuracy forecasts, and we became a center of excellence last year. So let me tell you about what flu forecasting looks like, and then I will tell you why it's so relevant to what is happening right now. So the most basic target that the CDC cares about is called ILI, influenza-like illness. And they care about the percentage, essentially, of visits to a hospital or doctor in the US, the percentage of such visits in which a patient reports these symptoms. So this is a clinical diagnosis. It's not confirmed by a laboratory test. And why do they care about this? This is believed to be a leading indicator of flu burden. So for example, if we see ILI go up, then we may believe that in a number of days or weeks, we'll see an increased burden in terms of hospitalizations. And there's lots of literature that supports this. This is the CDC's, at this point, kind of most basic unit of interest. And so what I'm plotting through here is national level ILI across the years 1997 through this year. So I actually generated this plot, maybe a couple minutes before we started. This is the most recent data we have in terms of influenza-like illness. And the CDC started doing this in 1997, so that's as far back as we go. And so you can see, of course, very clear seasonality as we go from year to year. This was the year of the 2009 H1N1 pandemic, and if you look carefully, you can see a very different seasonality. And at the very end, you can see what's happening this year, and if you squint carefully, you can see that we have a very abnormal behavior in terms of ILI, and I'll kind of revisit that in just a couple of minutes. So some notes, the CDC collects ILI at the state level, not just nationally, but for each state. Importantly, every data point that we get from the CDC is 1 week old. It's available weekly, but it's dated by a week because of a delay that kind of, the CDC takes to aggregate and collect and release the data. And the data is subject to revisions, so sometimes significant ones, because doctors turn in, let's say, reports late, and this is actually informative. It's not a missing at random type process. So why does the CDC care about ILI? Here's another way to look at it. If you think about the severity pyramid, and this is a CDC figure, then this is getting at syndromatic illness or symptomatic illnesses, the syndromatic surveillance. And there's obviously a clear relationship between that and hospitalizations and deaths. And so, of course, observation is important at every level of the pyramid. And you might imagine that the pyramid is actually much more complicated than this for flu. And it's significantly much more complicated than this for coronavirus, which is what I'm going to get to in just a minute. So let me tell you about what specifically we forecast. We forecast for the CDC the next 4 weeks of percentage ILI in every state. We forecast long-term targets, which is when is the worst week going to be and what is the peak value of percentage ILI going to be, and how long is the season going to last. And predictions are repeated every week as the data comes in. And we do the same for hospitalizations. So this is currently what the kind of CDC flu forecasting challenges look like each year. So how to forecast seasonal epidemics? Let me just give you some very high-level points. I'm trying to convey somehow why none of this is appropriate for pandemic forecasting. So this is kind of the point of contrast I want to make. So first, you have to choose a model class, and the two basic classes of models are mechanistic and statistical models. The difference is that mechanistic models try to model the underlying kind of latent mechanism of the disease, typically based off of kind of epidemiological differential equation models. Like the simplest one would be the SIR, or susceptible, infected, recovered model. Statistical models model observables, so they don't deal with latent variables, at least not those that are kind of have biological meaning, and they're kind of a direct phenomenological model of observables. So our group works on statistical models, and I'm going to mostly comment on what kind of epidemiological forecasting will look like for those. Some of the key elements are to collect lots of data and proxies like what I would call digital surveillance data, which is similar to things that were mentioned by previous speakers. Flu Near Year, for example, as John Brownstein mentioned, would be like a terrific proxy.
1 minute.
And some other keys are that you have to really kind of carefully handle non-stationarity because each season is a little bit different. So let me tell you why none of this is appropriate for forecasting a pandemic. And I'm sorry, I'm running out of time. The kind of key element here is distribution shift. So what we're observing now is nothing like we've observed with historical flu. And by definition of a pandemic, it's nothing like what we've observed, period. And so what not to do is just to kind of continue to run the same forecasting systems. And so the CDC pulled the plug on the forecasting challenge this year, just started a new challenge in which we predict the same targets, ILI and hospitalizations, because the simplest clinical picture of coronavirus meets the kind of same clinical picture as flu. So let me tell you about the current landscape. I'm running out of time. The current landscape is that the CDC has continued the forecasting exercise this year, has just switched essentially over to focus on coronavirus, but considering the same targets. And the two centers of excellence, ours and another one, are helping kind of serve as advisors to this effort, in which we are building an ensemble of community forecasts from about 20 teams that are participating. One of the hardest things we're facing this year is the kind of requirement of using counterfactual reasoning. So we want to kind of ask models to escape confounders and produce scenario projections, which is going to be extremely important for policymakers. So my very last thing I'll say is that what you can do is that you can take symptom surveys like the one that John Brownstein mentioned and any of the ones you see, because we actually really value that data. And you can join in our crowdcasting effort, which is separate from what I've talked about, but I've put a link there. So thank you, and I'm sorry that I ran close to overtime.
Thank you very much, Ryan. That was really interesting, and it's good to see the repurposing of previous efforts for the current challenges. Our next speaker is Tina White. Tina is at Stanford, I believe a PhD student, and she's going to be talking about a mobile app intervention to slow COVID-19 using crowdsourcing data. You've heard crowdsourcing in the previous talks, so Tina will be telling us more. Thanks, Tina.
So my background is machine learning, and I'm a PhD candidate at Stanford. And to give a little bit of context for the intervention I want to talk about, I just want to mention when it first came to mind for me was just seeing news like this and becoming concerned that the kind of quarantines and the situation in China was something that could easily come here. This was towards the end of January, and just getting personally worried myself about it and sad to see the level of quarantine that was there in a city that was larger than, more people in it than the Bay Area. So that's when I first became concerned. And then a couple of weeks later, seeing this article about China's coronavirus tracking app. I think this is what concerned me the most, were the details of this app and how invasive the app seemed from its description. So there's a lot of data collected about individuals that perhaps in this country would not be accepted or might be considered an infringement on civil liberties. So this is what concerned me, is that, well, perhaps we'll see these unprecedented quarantines here, and perhaps we'll also see apps like this here. So I became worried about that and started thinking about whether there's a way to perhaps perform a similar intervention as the kind of app that China came out with, but without infringing on our civil liberties. So that was kind of the challenge that I started thinking of around the time that I saw this article early February. So the first thing that comes to mind when you think about crowdsourced data is usually GPS, because everybody knows they have GPS on their phones, and those phones, these GPS is enabled. So that's the first thing that I thought of and wrote a post about, well, maybe there's a way to anonymize GPS well, so you're not sharing too much information about a person unnecessarily in order to create an app like this. So, and I also want to talk a little bit about what this kind of app does, or so background a little bit in why this intervention is effective. So the kind of app that China came out with appeared to be doing a form of contact tracing. So if somebody is ill, the app will tell them, tell their close contacts or somebody that they've been in contact with recently, it'll send an alert, and then authorities will be able to get in touch with that person from that alert. It's sort of unclear what sorts of data they were using, but it looked like that was coming from all kinds of sources, like surveillance cameras, GPS, things like that. So this seemed very invasive to me. However, it did seem to be a very effective intervention. So there's this difficult choice to make at that point, because you want to save lives, but you also want to be careful not to infringe on civil liberties if you don't have to. So what we found after a while of getting feedback from people in public health and epidemiology was that GPS data is very identifying. So trying to collect that, it would be hard for us to do. If you connect it with medical data, our laws and regulations in the US are very protective of this kind of information, which is a great thing. We have much higher expectations around privacy here, and I have high expectations around privacy, and I'm glad that these regulations are still out there and exist. And so it was interesting to come up against this and try to think about, well, is there another form of intervention that will still work, but that doesn't collect this kind of identifying information? And around this time is when we ran into another group who was thinking about the same issues, and they had a little bit more experience than we did in the past. So they developed a flu tracking, or had been developing a tracking app for the regular flu, just like the last speaker had originally was doing forecasting for the regular flu, and now we're looking at COVID-19 data. So what they were using was a Bluetooth protocol in order to determine close contacts for the regular flu. And they had interesting arguments for why it would be a better way of measuring close contact between individuals. And that got us excited because Bluetooth communication occurs locally between devices, which means that there's a way to construct the system to be decentralized, and therefore the information that you gain from Bluetooth can be separated from identity before being uploaded to a database. So you don't need to collect any identifying information about a person in order to perform the kind of intervention, the same kind of intervention, but if you use Bluetooth instead of GPS. So this got us very excited. So Bluetooth is also a really good measure of close proximity between individuals, because the way to tell whether somebody is in proximity is a local communication between the phones, rather than being a communication that goes up to a satellite and then back down. And then you have to look at whether two trajectories are close to each other. So you have to put that on a central server somewhere in order to do that computation of who's close together. That's not true with Bluetooth. You can just, the two phones can know whether they're close together.
1 minute.
So we got very excited about this, and Bluetooth also, the communication is reduced if there's a wall. So in places where you're more likely to become infected, like indoors or inside of cars or public transit, it works a little bit better, or we expect it to work better than GPS. So I'm going to skip forward a little bit. This is our privacy model. This is the way that we can upload these numbers without actually uploading them with identifying information. We use a number called the CEN, the contact event number, in order to do this. And we also have a video of, we actually created this intervention in an app. So we have Bluetooth communication working between Apple and Android devices. We don't have time to talk because I only have 1 minute left. And we worked with several other teams to try to implement this system, and several other groups are working with us now trying to develop Bluetooth as a technology. And finally, we have a few design images of what an app like this might look like. What we really wanted to share is this picture in the middle of our GitHub, where we've made everything open source, so any other country or that wanted to use this kind of protocol could easily pick it up and share it. They don't have to use our app, they don't have to use our logo, but just trying to make it easy for this intervention to be used anywhere.
Thank you very much, Tina, for an exciting project in the works. We're next going to go to Xavier Amatriane. Xavier is at cureai.com, co-founder and CTO, and he'll be talking about AI for COVID-19, an online virtual care approach.
Thanks so much, Russ, for the introduction. I'm really grateful for the invitation to the conference, and also humbled to some extent represent many, many startups that have poured their hearts and soul into addressing this crisis situation and working on coronavirus-related things. Now, also, sorry, I wanted to mention two people, because if this was a regular conference, I would have them on the stage, but the logistics are complicated. Both Jeff So and Anitha Kannan have helped tremendously in a lot of the research that I'm going to be presenting. Jeff So is our head of clinical informatics. He's also an assistant professor at Stanford in the Department of Primary Care and Population Health, and Anitha Kannan, who is our head of machine learning research. Now, before I dive into some of the COVID-related efforts, let me add some context about what we're doing at CureAI and what I'm talking about here. I'm sure most of you will agree that there were big inefficiencies and deficiencies in the healthcare system that were well known before this pandemic, right? And those include things like lack of accessibility to healthcare services, physician shortage and burnout, medical errors. Now, COVID-19 has not only exposed, but also augmented all these shortcomings, putting a huge stress in the whole medical system. Now, that has motivated many to propose telemedicine or telehealth as a solution. But the reality is telehealth by itself only solves some of the problems. In fact, telehealth is mostly a different medium for the same processes and practices. Very importantly, it does not scale or improve quality by itself. In fact, scaling telemedicine through AI was exactly what we were working at CureAI when this crisis broke out. So we decided to put our efforts into coronavirus-related features. Now, what is the solution that we're proposing? We are proposing an end-to-end medical platform that is always on, accessible, and affordable, and where we combine latest technology, AI, and automation, of course, and providers in the loop to accomplish both scale and quality of care. And we design our system to be always learning from the data and to operate in the wild. How does this look in practice? Well, as you can see here on the screenshot, and on the left, you see the patient client, the one that you can download and install in your phone or use from our web. And on the right, you see the provider client. And it is primarily a chat-based application that allows for synchronous and asynchronous communication. And there's an end-to-end integration of AI, both in the patient-facing and the provider-facing application. The provider tools might sound familiar to some doctors in the room. They include sort of like a new generation EHR built on top of the well-known FHIR standard, but includes full-on automation and decision support. And the platform, as I mentioned before, is designed to capture data and improve and learn over time. Now, going into what we've done for COVID-19, it includes a lot of different AI power features that I will just try to summarize in the following slides. Let's start with our automated diagnostic assessment. This diagnostic assessment is based on the latest known recommendations and research as of today. It's constantly being updated. On the surface, it may look like some other COVID symptom checkers out there, and I know some of them have been referenced in the conference already, but there's much more to it. One of the things we have is this is a dynamic questionnaire that adapts to responses in the flow. For example, in the third screenshot, you see that if you've answered that you are a healthcare worker, then you will be asked whether you've interacted with patients with COVID-19. And the assessment is also based on personalized features, including, for example, when we're asking on the fourth screenshot, the zip code, this is including the latest known incidence of COVID-19 in the area. But most importantly, this automated assessment offers the opportunity for the patient to then continue the conversation with medical providers, both health coaches and licensed MDs, to address any need. And this goes all the way to actually final diagnosis and a care plan, as you can see here on the third screenshot. We also include automated and personalized daily follow-ups, so we keep checking on the patients over each consecutive day. What we're still working on, there's more features. One of them, very important, we have already added at-home testing capabilities to our platform. We are unfortunately still waiting for the FDA to approve. And we're also in discussions with existing healthcare systems who are thinking about using our platform sort of like a front end to their own healthcare systems. Okay, so I've talked about some features that are already in the product, but since we started at Cureye, we have strongly focused on research. And we've done research in medical diagnosis, NLP, image processing. Here's a highlight of some of our peer-reviewed publications in the last couple of years, some of which have been in collaboration with Stanford and also MIT. And now we are applying some of that research to COVID-19 scenario. As a first example, in one of our previous publications, we used a double fine-tuned BERT language model to identify similar questions. The pre-trained language model was fine-tuned on a medical Q&A task and then on medical question similarity. We're now applying that with some slight modification to the COVID case. Now, why is that important? Well, we're implementing an automated question answering feature with the goal of providing a much better user experience to people looking for COVID-19 information. So instead of navigating through a long list of questions, the user can then input their personal question and be directed to the most relevant ones. Also, importantly, to avoid misinformation, all our answers are curated. And because a simple answer might not solve the concern or the problem, we again have the opportunity to connect directly with a provider. Okay, and finally, I'm also very happy to share that we have now trained what, as far as I know, might be the first machine learning COVID-aware diagnosis model. We have used the same approach described in our Learning from the Experts papers that you can see here. The basic idea is to use an expert system as a prior and simulator to generate clinical cases. Then the simulated cases can be combined with any other data, such as, for example, data from EHR. What we have done now is we have added data coming from our COVID assessments in the product. This is a great example of the ever learning feedback loop that I mentioned earlier. And now we have a fully COVID-aware diagnosis model. Of course, at this point, it is hard to evaluate the accuracy of the model just because there is no ground truth data at this point that we can test with. But we're very confident that this is going to be valuable and improving over time. And again, showcases how machine learning can be used from very early on to build these diagnosis models. So to conclude and highlight the main point of what I mentioned, healthcare needs to scale quickly now. The only way to scale while preserving or even improving the quality of healthcare is using technology and AI and automation. But AI cannot simply be dropped in the middle of all ways of doing things. We need to integrate it in an end-to-end system benefiting both patients and providers on both sides. Thank you.
Thank you very much, Xavier, for that exciting vision for where we need to go. Our next speaker is Mark Musin from Stanford University. Mark is going to speak about knowledge technology to accelerate open science in addressing the COVID-19 pandemic.
Thank you all. And again, thanks for the opportunity to be here. There's been a lot of discussion in the lay press about how the COVID-19 pandemic is going to change a lot of features of society. One element of society that actually hasn't been discussed a lot is that COVID-19 is going to change science and the way we do science in some profound ways. And what I want to talk about today is how some of the work we're doing at Stanford may be helping to push that change forward, particularly in the context of the current epidemic. And now I can't advance my slides. There we go. I'm sorry. The main thing I want to have you take away is that science in the past 10, 20 years has changed radically as people are recognizing the importance of making available online the very data that scientists are using to form their hypotheses and to publish their papers. That there's been a shift as we recognize that the output of science is important, not just in terms of publications, but in terms of basic data, so that other scientists can go and look at those data, can verify that the results of the experiments are correct, and also can take those data and reuse them and potentially make new discoveries. And nowhere has this been more important than the case of the COVID-19 epidemic, where suddenly all these data that are filling up resources all over the world with information about COVID-19 suddenly are available, and people want to be able to have access to them quickly, want to be able to use other people's data to make new observations. And there's just enormous excitement about the whole idea of open science and the opportunity to take advantage of data that already exist to be able to make new observations and hopefully to address the epidemic. That's all the good news. The bad news is that although we have lots of data out there, it's kind of like having a library where you don't have a good catalog, where you don't know what all the resources are, where you can't actually easily find what you need to find. And so the scientists who are most interested in being able to find other investigators' data and learn from them are kind of stymied. And they're stymied for a reason that's going to sound rather arcane. They're stymied because they don't have good metadata, the data that describe what the data sets are all about. Let me just show you why I say that. First, let me just emphasize that the buzzword that has become so frequently used now to describe the problem is the idea of trying to make data that are fair, that are findable, so you can actually search for them, that they're accessible, that even once you find the data, you can actually download them and look at them, that they're interoperable, that you can take your data and mix them with my data, and we can actually get something better than the sum of the parts, and that the data are reusable so that they're explorable by others. So this buzzword of having data that are fair pervades biology right now. And the challenge, as I said, is that most data are not fair. So here are the metadata, or a tiny piece of the metadata that describes samples that are in a repository at the NIH called GEO. And these results show you in several records how scientists have described the age of the patient, from age to age to age to pop age to age after birth to age in years to God knows what. If you're a scientist and your goal is to find a specimen that's described in a repository, where you want to look at the data that were accrued from some experiment, you have to know what to search for. And if you have to know, and if you're interested in patients of a certain age, you have to know how the investigator might have chosen to represent age in one of a million different ways, including a million different typos. We looked at a repository called Biosample, another NCI repository, and wanted to really quantify how bad are the metadata, which means how bad and how difficult is it to search for someone else's results. Well, 73% of the Boolean metadata values are not true or false. They're values like non-smoker or former smoker. 26% of the integers don't parse as numbers. And 68% of the metadata entries that are supposed to represent terms from standard vocabularies, well, are not terms from standard vocabularies. And what that means is if you're an investigator and you're trying to find a particular set of data, you're often really stuck because the metadata are terrible. And why is that important for COVID-19? Well, if we want to find relevant studies, if we want to be able to integrate new results with those that are already available, if we want to re-explore existing data sets, if we want to verify published claims, we may have a lot of difficulty finding the right answers. And one of the things that I find remarkable is that just in the past couple of weeks, there's been this absolute flurry of activity in the COVID-19 community demanding that we get data that are available and that are more fair, data that are more accessible, data that are more reusable. And the question becomes, how can we actually come up with better data like that when, frankly, the data that exists online are very difficult to search and very difficult to use? Well, like many other people in this session, we have technology that we're trying to repurpose specifically for COVID-19. We have technology we've created at Stanford called CEDAR, where CEDAR is a Center for Expanded Data Annotation and Retrieval. And CEDAR basically offers a three-step process where initially we author metadata templates. We decide for different classes of experiments, for different kinds of experiments in virology, in biochemistry, and whatever, what are the kinds of experiments that people do? And can we come up with a way of standardizing what the metadata for such an experiment should look like? We then have a mechanism within CEDAR that allows us to annotate those templates. We basically fill in those templates with terms from controlled terminologies that are consistent with well-defined data types. And ultimately, that gives us the ability to take the metadata that we enter into CEDAR and use those metadata to annotate the data sets that are stored in the repositories that investigators ultimately want to explore.
1 minute.
One of the things we also do is to look at those data so that we can easily use those data to make it easier for people to fill in the blanks of the form. So for example, here's a form for filling in information about a specimen for a repository called Biosample, and the drop-down menu gives you all the controlled terms that might be appropriate for the tissue. However, if we want to look at what the disease might be, if we already said the tissue is lung, then because we know a lot, we can use AI and say, well, look, we don't need to provide all the possible values. We just look at lung cancer or chronic obstructive pulmonary disease or other kinds of conditions that might be associated with lung tissue. If we say the tissue is brain tissue, then our menus can be much more simple, and we can specify, for example, what are the kinds of diseases that might be associated with a tissue coming from brain. What that means is when we create metadata, we don't deal with the mess that we currently have, but rather we have metadata that are really tailored for the situation and that use the kinds of terms that people want to search for. In the past couple of weeks, the GoFair organization, the people in Europe who are promoting the FAIR principles in the strongest way, have created something called the Virus Outbreak Data Network, or VODAN. And one of the things that VODAN is doing is using technology such as CEDAR in order to be able to make it easier for investigators to create data related to the epidemic, data related to virology, data related to all the kinds of experiments that people need to do in this area, and make this data more readily available. We know that data are never going to be fair unless we have common templates, when we have controlled terms, and we have technology that makes this all easier. And so what gets us very excited here at Stanford is the ability to take our existing technology known as CEDAR and to repurpose it for the purpose of making it easier and faster and more reliable for workers in the COVID area to be able to get the kinds of data sets they need in order to do the kinds of analyses that they view it to be most important.
Thank you very much, Mark. And I'm just struck in this session by how many people have pivoted their organization and their efforts to be relevant and useful for COVID. It's quite inspiring. The final speaker of our session is Johannes Eichstadt. He is from Stanford, and he will be talking about what can we learn from Twitter analysis about COVID-19.
Hello, everyone. My name is Johannes Eichstädt. I just joined Stanford faculty. I am a psychologist, and I specialize in using social media to understand the psychological states of large populations. And today, what I thought I'd do first is to zoom out a little bit after so much disease focus to try to capture a little bit of the psychological impact that might be coming our way. So if we think about the COVID-19 outbreak and everything that happened around the outbreak, the social distancing, there's probably three main things that are going on. Right now, we are all going through a phase of uncertainty and anxiety. This came up in previous talks. There's an acute adjustment phase where we're engaging in information searches that serve both informational and psychological needs in our sense-making processes. This is an acute adaptation process. Then there's going to be a real low hierarchy of needs impact on a large part of the population. That's unemployment. There's a huge unemployment shock. And then there might be the biggest transition in social norms, rituals, and behaviors since World War II coming our way as we're transitioning from face-to-face interaction to the digital space. Humans are a fundamentally social species. A large part of our neural infrastructure is dedicated towards tracking other people, body language, human contact. We regulate our emotions better through other people than basically any other way. And we're now seeing a natural disaster unfolding in slow motion with an absolutely unpredictable impact long-term on our psychological adaptation. I think that's fair to say. So I think that there is a good chance that all three of what we call pathways will lead to reduced subjective well-being and mental illness. So just a quick check-in on the unemployment. I mean, many of you, I presume, have seen this. This is data from the US. The gray area there is the Great Recession, 2008, 2010, spikes in unemployment up to 300,000 per week. This is just what happened last week, 3.3 million new unemployment claims. This is a shock to the labor market that we have not seen since World War II. So what do we know about the psychological literature of unemployment? So here's a famous study about 24,000 Germans that have gone through unemployment. And you see that they go from the baseline. You see 2 years before unemployment, and then unemployment happens at the zero line here, and their life satisfaction, which is the sort of one of the key variables of subjective well-being, drops by 0.7. Okay, what is 0.7 on a 10-point scale? Doesn't seem like that much. Here's context. So here are national rankings of life satisfaction, which is heavily dependent on income and education and all the things we value in society. And going 0.7 down in these statistics would mean going from the United States to Slovakia or Uzbekistan. That is just the impact of unemployment. So if we go back to this model and we just think about this pathway here, it is huge. What about loneliness, this piece down here? Well, this is a study of 700,000 people. There, the impact of loneliness is 0.5, so almost as much as unemployment. And it's comparable to the impact of suffering from headaches or being chronically ill. That's also big. So if you look at this whole model, right, this pathway is big, this pathway is big. How lonely are we going to get as a function of this outbreak? I think that's up to us. That's up to us, to our ability to transition into the digital social spaces beyond FaceTime, find new ways of belonging and connecting in the digital space. And finally, the uncertainty anxiety piece, that's hard to predict. So if nothing else, we as social scientists, we as people who care about the public health of the population need to measure the well-being of the population at scale, now more than ever. How might we be able to do this? Well, my colleagues and I, for now 10 years, have worked on methods of using Twitter to read the language of communities across the US and across other countries in the world and create well-being estimates. And we're doing that now, and we're going to try to make that data available as quickly as we can to the entire research community so we can start figuring out how our psychological experience is changing now that our biological experience has suffered this impact. So we're collecting fresh data. But what can we learn from Twitter in the meanwhile? And this data is fresh. It's still warm. What we did here over the last month is scrape Twitter for hashtags, clean it, throw out replies and retweets. Then we extracted something called topics, which are these clusters of coherent words. I'll show you what those are in a second. And then we combine it with other things that we knew about counties, including the cases and the confirmed deaths and everything we know about the census and who lives in these counties. And then we just looked in this data space of what kind of connections can we see and how people talk about the disease and what these communities are structured like. So the first thing here that I'm showing you is what's going on right now in urban counties across the US, right? So this is probably wherever you're watching from, this is probably where you're watching from. So you see a lot of this adaptation. So all these clusters are little pieces of language that COVID-related language that hang together. So these things are all significantly correlated with living in urban areas. And you can see this adjustment to COVID lifestyle, from not touching your face to there's panic buying and toilet paper here in the middle, to things being canceled and working from home. In a sense, this is the adjustment, right? Just a functional adjustment. If we look at this slightly differently and we look at this data by education, we see that educated areas are very information seeking and information processing. So there's a lot of talking about articles and news. There's, of course, things that will be canceled in the future, like conferences or move to the digital. There's talking about testing, about healthcare, and about government reaction. So this is high-level meaning making and information integration. How does this look like by age? Well, in older counties across the US, there's talk about Trump and about the economic impact. Whereas in younger counties, this is much more problem-focused coping. This is the one language cluster that stands out there is that in counties that are younger, people talk about washing their hands. And finally, if we actually look at who voted for Trump in the among the counties, the one piece of language that stands out there is this, it's just like the flu. It's the sort of downplaying conspiracy talk. And we're starting new research now where we see how this sort of misinformation decays. Presumably everybody is being slowly ramped up onto the same reality. And finally, what do people feel most negatively about right now on Twitter? They feel scared, they feel negative about the economy. And then there's a huge cluster of feeling negatively about Trump. So here are my very quick takeaways. We really need to measure the well-being impact of COVID, both the entire distribution of risk, well-adjusted people, people who are in danger of mental illness, and we very quickly need to think about scalable mental health care. And now is the time to mobilize resources to make that happen. We see sign of COVID adjustment in urban educated communities. We don't yet see it in rural areas. I think that's coming. The biggest predictor right now of COVID cases is still population density, so that makes sense. So I guess we're just a little bit ahead of the curve there. And finally, there's a huge promise in using the unobtrusive data, the digital exhaust of our digital spaces, to monitor progress week by week. And other speakers have spoken to that as well with things like location tracking. Twitter allows us to also do this in the psychological domain. Thank you very much.
Thank you very much, Johannes. That ends our session talks, but now the fun begins with respect to our panel. So I'd like to ask all the panelists to turn their video on. This will be our biggest panel of the day, so hopefully we will not stress out the internet. I'll give you, and I'm also welcoming Rob, my co-moderator, back. So thank you all, and we have a lot of questions from the crowd, but I want to give Rob the chance to kick off this session, and then we'll take it from there.
Great, thanks a lot. I've been listening with enormous curiosity here to look at the various ways that people have repurposed their research and various attempts to confront the crisis head on. I have a question about the variety of different things that were described, especially by the first 4 or 5 presenters, Jason, Lucy, John, Tina, Ryan, maybe Xavier as well. Which try to predict the scope of the epidemic, as well as to provide diagnostic tools, even in the hand of your cell phone in your hand. Here's the question, though. My layperson's understanding about COVID-19 is that some of the most worrisome super spreaders are completely asymptomatic. So people who wouldn't, if given a cell phone diagnostic tool, answer yes on any of the questions with the symptoms, and yet they're some of the most dangerous people still to be out and about socializing. So I'm wondering if anyone can address how it is that interventions of any kind, other than physical distancing, sheltering in place, can tackle the problem of asymptomatic patients.
And let me just say, I see Xavier raising his hand, and let's use the good old-fashioned hand raise if you'd like to be on the list of responses. Xavier, you can go first.
Yeah, I mean, I think the real key here is how to keep people away from hospitals and actually keep people away from each other, right? So I think that's why I was saying in my presentation that telehealth and any form of telehealth that scales is a really key thing here. Whether you have symptoms or you don't, if you have a question and you need to talk to somebody and you need to talk to a provider or a doctor, and you want to do it from your home, and you don't want people to leave their house, even if they want to get tested, right? So that's why at-home testing becomes so important. We only want people to leave their house and go to the hospital in really critical situations. And I think the symptom checkers and all these automated assessment tools are important if there's an ability to then follow up with the next steps. And I think that's the key message, right? How do we treat people from their houses without incurring in risk for themselves and for others?
Go ahead, Tina.
So I think to some extent, the intervention that we're proposing captures some of these events where you have asymptomatic transmission. Because if someone were to voluntarily put into their phone that they were a confirmed case, and then the people that they contacted are anonymously alerted, those people who were contacted would be instructed to stay home for a more targeted intervention, like you specifically ought to stay home for the next 2 weeks. And those people may or may not be symptomatic. So we would capture some of that with this intervention as well.
Yeah. Just to add, I mean, obviously, being able to identify even asymptomatic people is pretty critical. There's some interesting sort of studies out from companies like Oura, the Smart Ring, Whoop, the sort of Smart Band. Both some early evidence shows that you can actually detect physiological changes, even if the person isn't experiencing symptoms. So some interesting opportunities around wearables and continuous tracking that ultimately can identify cases even for those that don't actually experience symptoms.
What kind of physiological changes do you have in mind there, John? Of those?
So like heart rate, temperature. I mean, they're identifying cases days ahead of someone actually experiencing the symptoms. So that to me represents a great I mean, they're deploying these in certain populations right now and with some really exciting results.
Ryan, and then Johannes, and then Jason.
I just wanted to speak to something that was very related to what you said, but it's at the next rung of the severity pyramid. If you think about the severity pyramid I mentioned, so asymptomatic contribution would be the bottom rung. The second bottom rung would be symptomatic contribution. We actually have a very poor national snapshot of symptomatic contributions at this point. So yes, I'm worried about asymptomatic carriers. I'm also worried about the fact that we do not have a surveillance system in place that at a low temporal latency and a fine geographic resolution identifies people who have symptoms. Now, there are many efforts out there, like some things that Jonathan mentioned. I'm aware of probably at this point 10 plus surveys that are web-based for people to report their symptoms. The truth is the sample sizes are just way too low. So I would say that I mean, an easier problem to solve is a symptomatic one. So a national or even international surveillance system at this point, which is capturing that, would be extremely useful.
Johannes, and then Jason.
Yeah, just a very quick point, purely from a data science point of view. As we're trying to capture these asymptomatic cases, I think it'll be critical to merge feature spaces from different data domains. So if we have Bluetooth interactions, Bluetooth proximity in conjunction with the annotation of people self-report that they have symptoms or that they've been tested, it's really a question of merging the density of these data spaces across domains so that you can cover up the holes that you have in one kind of data with the density that you have in another set of data. And that builds on the previous point. The goal here is to create a density of the datascape so that you can make these inferences.
Jason?
I just want to make a point that symptoms are subjective and signs are objective measures. So fever is a sign and not a symptom. So if you look at the reporting, there's the fever occurs at 80 to 90% of the individuals, and then there are other symptoms like dry cough and shortness of breath and all that. So if you take a lot of people here are working on collecting these symptoms and signs, can you build a prediction tool for us where if you get 3 or more, or 5 or more, or 6 or more, if you get everything on the list, and it's more predictive, because most people are going to have fevers with COVID-19 at one of those 14-day, incubation periods, and so it's 80 to 90% of them.
Ryan, and then Lucy.
Yeah, I can speak to that. So first of all, I just want to emphasize that yes, symptomatic surveillance is not the same as positive laboratory testing, but the CDC currently adopts influenza-like illness as one of its gold standards for measuring, let's say, prevalence. So that is very clearly defined as fever of 100 degrees or higher, along with sore throat or cough. Now, you might think adding, for example, difficulty breathing, if you're trying to look at, kind of a very, very basic symptomatic presentation of coronavirus. But I just want to be clear that there are models then that take things like ILI prevalence and then predict hospitalizations, predict critical hospitalizations, predict deaths. And these models are very well established for influenza. The question is whether we can train them fast enough, in a sense of, by fast, I mean, do we have enough training data to kind of make useful forecasts for coronavirus? But I agree with the basic point that symptoms are not kind of a positive confirmation of disease, but they are still extremely useful in terms of these projections. And they are very clearly defined in terms of how we consider kind of positive cases, at least for influenza.
Lucy?
So there are some modeling studies that show that people without symptoms are slightly less transmissible compared to those with symptoms. So they're not, sneezing or coughing. But if they're able to go outside and make more contacts with other people, then ultimately they might end up infecting similar numbers of people. So ensuring that even if you feel well, that you're not going outside except for like essential purposes will be key to keeping the case numbers low.
Thank you. Now I want to go to our the crowd has been our listeners have been very active, and our intermediate people have been summarizing. But there are a ton of questions from the listeners about whether the tech companies have data sets that could or should be shared that are not being shared. People mentioned mobility data, and many of these came up, but mobility data, phone data, sound and sound surveillance. There's a lot of Alexa devices that are listening to us and listening to me even as we speak. And then social networks, we've heard about them all a little, but I'd like to know, are there big things missing, or are there big opportunities that we should be capitalizing upon? And again, show me your hands. John?
Yeah, listen, the tech companies have been incredibly collaborative. Like the COVID Near You project I presented is actually a collaboration across Google and Facebook and Airbnb. So a bunch of engineers are all contributing in time. So there's a lot of activity at the sort of the bottom up approach. At the top, yeah, mobility data sets. What I presented was Baidu, but also Google's releasing some data in this space. They're trying to go as fast as they can while still being under the same pressure that they've undertook over the last several years around data. So it's hard, would be hard to press to do some of the same types of sort of app-based approaches that we saw in Korea and Israel and other places without sort of really major sort of federal support. And I think that's where there's potentially a little bit of a disconnect between sort of what's happening at the federal government level and what they're trying to push in terms of an app-based contact tracing approach. But as far as like one-off data sets, and collaboration, it's been as great as I've ever seen at any point in time.
Great. Xavier, Ryan, and then Lucy, I wanted to ask you specifically if you're using these kinds of data in your modeling. So Xavier, Ryan, Lucy.
Yeah, I guess as a representative from industry here, I've been hearing this since the first session. I know Nigam Shah and Dr. Berry also talked about how hard it is to share data given some of the legal landscape, and that's a reality. If you think about many of the countries that Michelle Berry talked about where they had a successful approach to coronavirus, they had really compromised privacy and individual freedom and have gone all the way to sort of having drones measure temperature of people in crowds, right? That is tricky, and it's a really critical sort of like social discussion that needs to happen. And I think it's the same when it comes down to how much granularity of data can all these tech companies share, and to what extent that is legal and available. And I think Professor Shah was also mentioning that he had some difficulties accessing some of these data sets because of the legal landscape. And I think it's a great discussion to have, but it's also a very slippery slope. So like, how do we in a situation of crisis, how do we react quickly and also safeguards of like privacy and all these other freedoms that we have, right?
Ryan, and then Lucy. Ryan?
Yeah, this was touched upon, but I just wanted to make it explicit that, you know, so data privacy is, of course, one of the foremost issues people discuss today, and this is an unfortunate time for this to have been such a big issue, because there are real issues of privacy surrounding sharing of medical data. That being said, what we've seen in our group, and I think this is true across probably anybody who's working on COVID modeling and forecasting, is that there's been more movement and there's been more accomplished in the last 2 weeks than I've seen in years in terms of data sharing. So agreements that we've been working on for literally 3 or 4 years have now, in a matter of like days, been signed and finalized. So one thing that I've been doing with Google for the last 8 days, Google ran a trial period of a survey that was very, very simple, asking people whether they had ILI, influenza-like illness, which is fever of 100 degrees or higher, along with sore throat or cough. And this was sent to about 1 million people. Actually, in fact, more. I got about 1 million responses over the course of a week. So this kind of thing usually would take, very, very long time to plan and to deliver. But I think companies are really willing to help, and I think it requires a giant like Google or another kind of really big tech company, and I think there are many others of these in the works, to kingmate or adopt kind of one survey or one mode of surveillance and just make it available to everybody. I think that would be really beneficial to the entire community. And so we're working on making that happen. But.
Lucy, and then Tina.
I think
Lucy, in particular, the crowd was wondering if you were able to incorporate these new data streams into your modeling.
So right now, we're not incorporating any of the social media data yet, but we would very much be interested in having access to more granular data than what is provided at the county and the state level. And I think one conversation we've had with people is that publicly only data down to the county level is available. So there's no information about how many people are actually infected in individual cities. So obviously in places where the city sizes are small, that could present a potential privacy issue. But in places like the Bay Area, when each city is a very sizable population, I think that needs to be a conversation that needs to be had to balance privacy, but also like informing the public about how many COVID cases are happening in their area. So in addition to getting access to these new streams of data, we're also interested in exploring how to safely share data with the public so that they can be informed without compromising confidentiality.
Yes. And Tina.
Oh, I just wanted to mention that our approach was kind of designed so that you don't have to collect identifying information about individuals in order to use it. So our data set in some ways is kind of special because there's no actual identifying information in it. It's just these anonymous contact event numbers, which are then deleted after a couple weeks and are only interpretable by the individual phones. So there's a little bit disappointing to researchers in some way because we don't have a data set that we could really perform research on. It's only information that is used to form this alert system. So it's only an intervention and not something that generates a data set, which is kind of what we were aiming for, something that's so private that we can't even like interpret it ourselves. It's only interpretable by the phones that were locally involved in the contact events.
Mark, did I see you twitch? No. Let's go to the questions. Let's go to the questions from the, some of these are geared towards individual speakers, and I think there's a lot of interest. So let me just go to a couple of them. One question for John is, how are these technologies like Buoy and the COVID Near You advertised to doctors' offices or the public to get buy-in on a massive scale?
Yeah, really great question. I mean, obviously, we're building off of the existing tool base. So we already have a cohort of 100,000 people in Flu Near You. So that gives us a jump start. And of course, leveraging social media, news media, and then our partners at CDC and public health departments, they're all sort of pushing it because, local public health department pushing a COVID Near You, then all of a sudden gets granular data for their particular community. So creates a bit of a new channel for marketing. But, we're still trying to get, 1 million people in the system. We're a quarter of the way there. So, still a lot of work to do to figure out how to get people engaged. Absolutely.
And just as a follow-up from me, and not necessarily from the crowd, is what is the best granularity you're going to be able to get? Realistically thinking, are we talking county, city, blocks? What's your thinking on that?
So our data is at the zip code level. Right now, the amount of data we have in the 260,000 reports, it doesn't give it the granularity other than say city level and state level. We start to go 10x that volume. I think we start to begin to have zip code level, data that becomes valuable for us.
Great. Another question. Sorry, Rob.
Yeah, I'm just going to hop in with one that also from the audience, but I would love to have some of the experts on the panel react to as well, which is that for those of us who aren't data scientists, aren't biomedical researchers, we're getting our information from the usual newspaper sources, Twitter or whatever. Various different places have become central repositories of projections. One of the questions that arises is why so few of the kinds of models that we ordinary people are reading have any uncertainty intervals attached to them. We always get projections of lines that go out with no uncertainty intervals, no information about the confidence about the projections. So I'm wondering, for those of you who are making some of these models, how would you respond to audience questions about why so much apparent certainty in the public communication when anyone who's a social scientist, a scientist knows there are some uncertainties built into the projections?
Ryan?
Go ahead.
Yeah, I think that's really unfortunate, first of all. I suppose I've seen it both ways, to be honest, in terms of news coverage, but it is unfortunate that there are projections made that don't have uncertainty kind of quantification attached to it. I just want to make clear that within, I think, the CDC's view of forecasting, which I think is a model that's adopted by lots of local public health officials as well, we look at forecasting distributions, not targets. So for example, if you want to know what is going to be the worst week of the year between now and December, that's a distribution we're putting forth. So each week I'm going to assign some probability I think it's going to be the worst. So those are fully kind of, let's say, probabilistic. And uncertainty can be gleaned directly from those. So in terms of the forecasts that I think most of the community is making, at least, there are probabilistic. Uncertainty estimates are kind of baked into them. If those aren't being reported at the level of kind of presentation and various news outlets, I think that's really unfortunate. One thing I will say is that some models actually do not lend themselves as easily to these types of uncertainty estimates. And it may well be that, particular types of models, which are based on maybe more mechanistic kind of transmission type approaches, are being presented in the news, and therefore it's kind of harder to read uncertainty estimates from them.
Good. I saw Xavier also want to get in on that.
I have a different hypothesis. I think that it's really hard for the non-experts to deal with uncertainty in model predictions, right? And that's why you see those uncertainties that exist not being reported, generally speaking, to the main audience or the main public. Now, if you think about it, even very early on, there were some models that were predicting anywhere between 100,000 and 4 million deaths in the US, right? And that felt to most people that don't know anything about modeling like pretty much noise, no information. Like what's 100,000 to 4 million? That's a huge. But the reality is, if you have an exponential and you have some uncertainty on the slope, that's where you are, right? So dealing with that level of uncertainty for the general public, I think it's really hard. And therefore, journalists and general, many of us tend to just avoid it and just go for the middle of the projection and say, okay, it's roughly going to be around that. But that's probably a statistical lie, right?
Mm-hmm. I want to go to another question that's coming up in the crowdsourced questions a lot, which is a lot of the technologies we've been discussing today are more prevalent in younger demographics. And yet we know that the older demographic is not only at greater risk, but has less access to some of these technologies. So there's a general question about what, if anything, are we doing to make sure that these solutions we're addressing are relevant and serve the interests of the less technologically capable and folks in society? Tough question. Johannes?
Yeah, so this comes up a lot in sort of different pieces of this research puzzle. The truth is that it's all a question about sample size, right? So as long as we have a substantive number of younger people in the population that can represent a particular population, a county or a city, we are then able to make inferences around those people who are at risk to whom it might be spread. I would also like to say that people tend to grossly misestimate the age distribution of digital technology. So the age difference between the median age of Twitter and the US population is 5 years. It's not 15 years. So it trends a little younger, but not by much. So all of this comes down to just having big enough samples and being good in your statistics. But for a phenomenon that is fundamentally about community contagion, having any member in a community is incredibly worth it.
Jason?
Yeah, I wanted to say that, some of the technologies send out passive data, and others you have to do active data. So for the elderly, it may be more appropriate, a bracelet or something that sends out passive data to whatever you're trying to track.
Jason, I wanted to follow up with another question that came in for you, which is how significant is the different way that healthcare is set up in Taiwan for their somewhat stunning success in managing? I believe they have universal health insurance, and it sounds like there were bracelets and all kinds of things, either pre-distributed or quickly distributed. What can you tell us about the differences in the healthcare system that might be pertinent and that we might want to think about implementing in other countries, including the US?
Yeah, so, national health insurance is nice, but it's not why they're successful. Because in Palo Alto, we could easily get patient data and triage patients. We could easily make an app and say, tell me these symptoms so I could triage you, not through the ED, but through a fever clinic. If you have travel history, I'll triage you differently. So we have all the technology here in this country, and we have more. So I would say that it's nice to have, but not must have a national health insurance system. The other thing is that they were prepared because they had all these laws that allowed them to do certain things, and then these powers expire. For example, they expire in a year from March. So because you have all these laws, you were thinking ahead, then you could say, okay, who's the honest broker here for these data? And then how do we quickly get all the data in the same place so we could use it? And let me give you an example. In the immigration and customs data set, they send batch file to the National Health Insurance Program. Not all the travel history, just the travel history in the last 14 days. And then after that, they just get rid of it. So there's a way to clean the data out so that you're not there forever in terms of your travel history. So that's just one example.
And then for Ryan, there was a question about, you made it very clear in your talk that I think the word weird actually might have even appeared on your slides. So given that it's so weird right now with COVID-19, what's the source of your confidence that all the great work that you've done with flu will translate well and usefully to COVID?
That's a good question. I guess it depends on what targets you're talking about. So I have very little confidence at this point in long-term forecasts. And in fact, I am not a proponent for making forecasts past 4 weeks. So our group in particular has been pushing to kind of get rid of long-term forecasting for coronavirus. But I think it'll continue, but I just hope that we don't end up conveying a lot of that, because I really don't trust, aside from the uncertainty kind of levels being massive, I don't trust long-term forecasts at this point for a variety of reasons that don't have anything to do with statistics. I mean, what happens past 4 weeks is going to be dictated in such large part by policy and by adherence to policy that it really does not make sense to me to be pushing forecasts past that. That said, a lot of people care about long-term forecasts for a variety of reasons. So my answer is kind of convoluted, but if we can get access to the data that we're hoping to get access to, which would be a game changer for us, which would be national level surveillance data of symptomatic illnesses, and we can get access to hospitalization data that we're seeking, then I have some confidence that we can make useful short-term forecasts. Now, I'm not positive we're going to be able to do so at the county level. You mentioned geographic granularity earlier. At this point, we're aiming for the county level, but we may not be able to do so given the sample sizes we're seeing. We are seeing, I think, the largest sample sizes possible in some sense with these data sets. And we may have to kind of fall back to health market area, which is, it's a combination of counties that are dominated by one health market. So that might be something on the level of a metro area. But that's the hope, at least. Short-term forecasts, metro area within 1 to 4 weeks.
Thanks. Well, you know what? Our panel is coming to a close. I want to thank you all for your work. I'm struck by the pivoting, as I said before, of many organizations towards COVID-19. But at the same time, the downside is the requirement that we all pivot is probably costing us something. And there was breathtaking examples in earlier sessions and in this session hearing about Taiwan of how much preparation helped in other places. So pivot is great. Preparation is great. I want to thank you for all of your work. We will resume in a short time with the final session on treatments, vaccines, and the patient experience. But for now, thanks very much to the panel, and we'll see you back in a short time. Welcome back. I'm Russ Altman with Rob Reich. We're in the 4th session of the AI and COVID-19 conference. We hope you've been enjoying it. This is going to be session 4, treatments and vaccines. A couple of bookkeeping notes first, however. First, I want to remind you that there's a Q&A facility on the conference page where you can join the conversation and put questions, and our crack team will be gathering them and sending them to Rob and me. Secondly, there's been a lot of questions about the availability of the older videos in the entire conference, and the answer is yes. These will be available soon for rewatching or catching things that you missed. It'll just be a matter of our technical team bundling the video and making it available. But yes, the entire proceedings of this conference will be available long-term for asynchronous watching at your leisure. So with that, I want to welcome you to this session 4, and we'll go to our first speaker, who is Kristen Beck. Kristen is the lead bioinformatician at AI and cognitive software at IBM. And she'll be talking about rapid analysis of SARS-CoV-2 genomic content using a functional genomics platform.
I want to begin, of course, by thanking the organizers of this amazing conference. I think it's so excellent to be able to bring people together and share information for researchers and scientists. And I know to the general population and all those families in their living room that are watching this as well. So a huge thank you for that and the introduction as well. My name is Kristen Beck. I'm the lead bioinformatician for AI and cognitive software. I hail from the IBM Almaden Research Lab. So IBM Research is a place where we get to do kind of some really neat and crazy and inspiring things. And our goal really is also to help make the world a better place. And so what I'm going to share with you today is some of the research that we've done over the last several weeks in response to COVID-19 in an effort to help provide our expertise in genomics and capabilities for the research community. So one of the things that we've observed over the last several weeks is that as the virus itself has been spreading rapidly, the amount of available sequence data is also growing at a very fast rate. This data was pulled as of yesterday, looking at the total amount of sequence deposited over time, and we're seeing thousands of available sequence data. This magnitude of data, as well as the rapid rate with which it is created, indicates that applications to process that data must keep pace. And in order to do that, they must scale in an automated way, in a way that brings important points of that data together. On the right-hand side is a plot generated through the NextStrain platform with great acknowledgement to their work at this time, indicating from them and other researchers that we see that this virus is mutating typically about twice per month. And that in itself will reveal previously unseen variants. So the amount of data is growing, the virus itself is changing, and that really forces a unique computational time. The viral genomic sequence itself, this contains the molecular targets that are going to be used to develop antivirals, vaccines, and rapid diagnostic tests. So those sub-regions of this genome and the diversity that they have are what will actually be able to help us slow and kill this virus. For the last several years, through IBM Research, we've been working on a platform that was formerly called Omicsware. It's now called the Functional Genomics Platform, and its roots originated in bacterial genome analysis, really to support the microbiome. The repository itself has been a collection of over 200,000 bacterial genomes, and then beyond their genomes, we've annotated the phenotype, so annotating all of their genes, the proteins and functional domains. And together that data collection delivers the biological activity that the system could have. We've put this together in a way that's a bit of a paradigm shift from how traditional bioinformatics is being done. So instead of having flat files on disk, we put this into a structured relational database. And what that allows is that these data types are connected automatically through the ingestion and processing that we do, such that you can observe a functional domain that does a specific enzymatic activity, map that back to its genome of origin, and go beyond that. The data itself is surfaced through a web browser, but also a developer toolkit that includes a Python SDK, Docker container, and REST APIs. And really over the last several weeks, when the global pandemic became just, I don't even know, paramount size, really. I think it caught a lot of our attention in a much bigger way than it had, unfortunately, at this point. We shifted in what we were doing, and we said, how can we come together and how can we help in this nature? And to that extent, we wanted to look at the COVID-19 genomic information that was available. And so we brought a task force together, I think it was on a Tuesday, and the next day we had a corpus of genomes, about 100 at the time, and I passed that over to the lead architect of our system, Ed Siebels. And by the time we were drinking coffee the next morning, we had analyzed all of the genes, proteins, and functional domains. And not only did we have the data, but it was easy to get to, queryable, and structured. That in itself, this data is what's going to comprise all these molecular targets for health interventions to be able to slow and kill the virus. Since that point, we realized how tremendous this capability is and expanded this even further. So since that point, we've processed over 25,000 viral genomes from GenBank and GISAD, which are tremendous aggregates of data of this type, including SARS-CoV-2 for COVID-19 genomes, as well as SARS and MERS genomes, which provides a comparative capability to look at other outbreaks. As part of this capability in this platform, IBM is actually offering this cloud-based capability to researchers who are also working on COVID-19. They can request access at ibm.biz/functional genomics. And we hope that by providing this data, we'll be able to accelerate researchers and also provide an excellent set of data to build AI and machine and deep learning applications on top of this. To give you just a peek of what data we already have in the system, on the left-hand side here is the total counts of data for different biological entities. For example, the genomes, genes, proteins, and domains of the viral data, all of our virus corpus. On the right-hand side is the specific counts for SARS-CoV-2. You can see we have over 3,100 genomes to date. This was pulled live this morning, 3,000 genes and 2,600 proteins and 4,300 domains. And at the same time, what we're able to do by looking at data of this magnitude in a structured manner as it is, we can start to look at the emerging variants. So on the left-hand side, you have a contrast of gene distinct counts, the unique count of sequences, as well as the redundant counts. So that gives you the distribution of variants that we're already seeing emerge in the population of these genomes. On the right-hand side, I've contrasted for specific proteins, the total count of distinct proteins, and then also the redundant count. So you can see, for example, that replicase polyprotein 1A has an increased amount of variance compared to replicase polyprotein 1AB. For spike glycoprotein, which is involved in host cell invasion, at the same time you see hundreds of variants. The collection of these variants itself is crucial as we think about building antivirals, vaccines, etc., because the affinity and the specificity for these molecular interactions will be key to their effectiveness. On the bottom is a enriched motif that we're starting to observe in the spike glycoprotein, and show just a little bit of a snippet as to what we can actually provide. I'll go ahead and wrap with that, just to invite you to come and access the data and to collaborate with us and to be able to provide this collection of data for the research community. Thank you.
Thank you very much, Kristen, for that overview of the genomic analysis. Our next speaker is Anthony Goldbloom. Anthony is founder and CEO of Kaggle, and he will be speaking about the COVID-19 machine learning challenges.
Hi, everyone. I'm Anthony Goldbloom, CEO of Kaggle. For those of you who don't know us, we are the world's largest machine learning community. We have a little bit over 4 million members, and we're best known for running machine learning challenges, but we also offer a place for data scientists and machine learners to share data sets and also to share reproducible notebooks or reproducible code. Like a lot of teams or a lot of people at the moment, we were interested in ways that we could contribute to COVID-19, and 2.5 weeks ago, the White House Office of Science and Technology Policy approached us with the challenge that they wanted to put out in front of our community, and that's how we first got involved. Right now, we have 3 challenges running. Oops. 3 challenges. One is an NLP challenge, which is an automated literature review. The second is a forecasting challenge, forecasting cases and fatalities. And the third is a data sets challenge, so curating useful data sets. I'm going to go through each of these challenges, give you a sense for what's involved, what they require, as well as what the kinds of things that we're seeing out of them. So the first one is this NLP challenge, which was the one that the White House Office of Science and Technology Policy asked us to launch. What they had done is they encouraged the journals to open access the history of articles they have published on coronaviruses, and then more modern articles on COVID-19 specifically, and also to release them in a machine readable form. One of the challenges is that the literature on COVID-19 is moving very, very quickly, and it's very difficult for somebody to get their arms across all of the literature. And so the goal here is, the way I like to position it is, it's like trying to create an automated literature review that each week, as new papers come in, the data set is getting updated, and we're creating the machine learners in our community sort of answering key questions about COVID-19 by scanning those papers, and in doing that, creating sort of like an automated literature review. If we look at the kinds of approaches that people are taking, this is an example of a system. It's not animating, but the way it works is somebody types in a question and it pulls out all the best answers to that question. Other people are taking more traditional approaches. So looking if we're trying to find all the papers that reference a reproduction rate or the reproduction number, doing string matches, looking for the papers that have that term, and then trying to extract the data out of those papers. And what we are doing is we are putting the best of what the Kaggle community is coming up with on a website. It's listed here at the bottom, www.kaggle.com, COVID-19-contributions. And the aim here is for this to be a resource that people can come to have a sense for what the scientific literature is saying at any point in time. Our second challenge is a more traditional Kaggle challenge. It's a forecasting challenge. And here we're asking our community to forecast cases and fatalities by city. Now, the goal here actually isn't to build another epidemiological model. We heard from Ryan at CMU earlier today. There are lots of good epidemiological models out there. Actually, the reason we have launched this challenge is to encourage our community to play with the data and try and pick apart the factors that are driving differences in transmission rates across cities. So this challenge is much newer. The NLP challenge launched a little over 2 weeks ago. This one's around a week old, and so the models aren't quite as mature. But some of the early things, this is a very common output from a lot of the models that are being built here. It's what's called a feature importance plot. And it's interesting because this is giving us a sense for what the machine learning models are finding are the most predictive of fatalities and cases. At the moment, the models are fairly. This is one of the better performing models. You can see it's a very simple model. The most important variable is a time series variable, days from the first case. But it's also picking up that country, state, latitude, and longitude make a difference. Obviously, there's nothing about the fact that it's not the country that is the reason that transmission rates are different in different countries, but rather it's the policies in that country, or it's the cultural norms around hugging and kissing, or it's the temperature. And so we expect that as people iterate on their models, they'll bring in more granular data sets, and we'll start to see much more interesting, these variable importance plots becoming much more interesting and starting to sort of pick apart the most important factors that are driving differences in transmission rates across different cities. So this is one to watch. The last challenge that we're hosting is a dataset curation challenge. So our community, as well as being very good at building natural language models and forecasting models, and they're also very good at playing with datasets and curating datasets. Very often it's not so simple to join two datasets together. You've got geolocation challenges, or you've got, you don't have good join keys between different datasets. You have to do fuzzy matching. And so we've challenged our community to put together data sets that are useful for making decisions about the pandemic. To make this a little bit more concrete, I'll give you a sort of real world example of where this could be useful. So the congressman this morning mentioned that his understanding was that temperature had an impact on transmission rate. And this is one of the studies that is very often referred to when people say that temperature and humidity seem to reduce transmission. But this paper was written on 100 Chinese cities. That is a very, very small analysis. Whereas somebody in our community has taken every single city in the Johns Hopkins University dataset, joined that city to the nearest weather station. And so in doing that, he has created a data set where you could very easily or relatively easily analyze the link between temperature, fatalities and cases across every, the 4,000 cities or whatever number of cities it is in the Johns Hopkins data set. And so this is a data set currently sitting on our website that would allow somebody to build a much more robust model around the connection between temperature and transmission rate. So to conclude, for those of you who are machine learners who are looking for a way to get involved, you can check out our challenges at kaggle.com/COVID-19. For those of you who are interested in following either the automated literature review, the things that come out of the forecast, insights that come out of the forecasting challenge, or the data sets being created on Kaggle, visit kaggle.com/COVID-19-contributions. We're also interested in getting input from domain experts. We found that having domain experts help to steer the work of our community has been very helpful for producing more impactful results. So I encourage you to email me at a@kaggle.com. Thank you very much.
Thank you very much, Anthony. That's a great and inspiring activity where many hands are working together. Our next speaker is Ron Lee. Ron is from Stanford University, and he will be talking about machine learning enabled systems for delivering care to critically ill patients.
Thanks, Russ. Thank you to the organizers for this conference, and thanks to all the audience members who are joining us today in this time of unprecedented crisis. My name is Ron. I'm an inpatient physician at Stanford Hospital, and I take care of hospitalized patients with COVID-19. I also work closely with the hospital and the School of Medicine to enable the use of AI to help address the most pressing clinical and operational problems that our healthcare system faces. Today, I'd like to share some work we are doing to use AI to help deliver care to our sickest patients with COVID-19. Before I get into the AI work, I'd like to start by just framing the problem. The reality is that there are clusters of COVID throughout the country, and the numbers today reported over 200,000 cases and over 4,000 deaths. The consequence of these rapidly growing numbers is the severe strain that's being placed on our country's healthcare systems. Resources are being drained, staff are under immense amounts of pressure and stress, and we are unfortunately already seeing healthcare workers getting ill, with some who have already died. We need to fundamentally rethink the systems of care to meet the unique challenges we face with this pandemic. We are in a war, and we need a wartime strategy. The key point I'd like to make here is that while we think about the individual goals of preventing outbreaks, delivering high quality care, and keeping healthcare workers safe, we have to recognize that these goals are actually all interdependent. So the solutions we develop to control the COVID-19 pandemic will have to consider this interdependency and the complexity that comes with it. I'd like to get a bit more specific when we say that healthcare is complex, because what we really mean is that healthcare is delivered via complex systems, and we can build better systems to deliver better care. I think this framing is important because it allows us to define the space in which we develop AI solutions. Traditionally, we mostly think of AI as synonymous with machine learning. But I think that for AI to truly drive solutions for the most pressing problems like the COVID-19 pandemic, we have to think about how to develop entire systems, including the structures, the processes, and patterns of care delivery that can be enabled by machine learning models. Here's an example of a process that we are using at Stanford Medicine to do this. We start by actually pretending that AI doesn't even exist, because we focus solely on understanding the problem that we are trying to solve. We also ensure that the process is highly multidisciplinary and iterative. The work doesn't end once the solution is implemented. In fact, it is only the beginning. Here's one problem that we face when managing patients who are hospitalized with COVID-19. Most patients admitted to the hospital are not actually critically ill in the beginning, and they can be managed in standard hospital isolation wards. If they become sicker, they will have to be moved into the intensive care unit or ICU. We worry about this population because, one, we're learning that many of these patients actually become sick very quickly. We also have a constraint around the availability of ICU resources. And we also are learning that when we perform critical procedures like intubation, mechanical ventilation, these procedures aerosolize particles in uncontrolled settings, and that actually places healthcare workers at very high risk of becoming infected. So we came up with the problem statement of how can we identify sick patients early before they emergently need critical care. We started by using principles from process improvement to more deeply understand the current state. And I'd like to give special thanks to Margaret Smith for leading this work. We held focus groups and interviews with tons of sticky notes, whiteboard sessions with frontline clinicians to better understand their current processes and pain points. We then prioritized each pain point based on how frequently it occurs and also its level of impact on workflow and outcomes. We then derive from these pain points the key drivers that can enable a better system for delivering care. And this is where AI comes in. Among these key drivers, we identified the need for accurate, objective, and timely clinical assessments that need to be continuously performed over time in order to screen for at-risk patients. This is something that is currently performed manually by a limited number of trained physicians. And this is doable if we have, let's say, 20, 30 patients with COVID in our hospital, but becomes fairly difficult if we have several hundred. We recognized that this is actually a perfect task for a machine learning model to perform at scale. The model would have to predict sufficiently in advance if a patient is at risk of requiring ICU level care. And there are actually many models out there that could do this well. And we ended up choosing one developed by our electronic health record or EHR vendor because it's already conveniently integrated into our EHR and can drive the workflows that we need. Based on validation studies done by the vendor, It performs reasonably well in predicting the outcomes of interest. And the initial analyses that the vendor has done, as well as us and our team at Stanford, suggest similar performance on COVID-19 patients. And we are actively validating as we have more patients at Stanford with COVID-19. In addition to validating the model in terms of prediction accuracy, I'd like to stress the importance of validating also the usefulness of the model output in enabling the workflows that we are designing. This is being done in design sessions that we are holding with frontline clinicians at Stanford. Here's an example of a digital interface in the EHR. I'd like to thank the Stanford Healthcare Technology and Digital Solutions team for rapidly designing and building this out. So let me point a couple of features here that I think are interesting. One, you see a score, so it's 61 right here, that it ranges from 0 to 100. So this score is calculated by the prediction model, and it indicates the patient's level of risk of becoming very ill and needing ICU level care. And this score is actually updated every 15 minutes based on the most recent clinical data. What you don't see that's blurred out here is actually also a section that shows the factors or the model features that most strongly contributes to this score at this time. The other thing is this score trend line. And I'd like to point out that, so this is actually from a COVID patient in our hospital. And we noticed during these design sessions that there is a potential importance of not just the absolute value of the score, but also the rate of change. And you can see that in the beginning, the score is fairly low, and then it jumps from about 30 to 50. And you can imagine that is more important than just knowing what the score is at any given time if it's stable, because that can trigger certain workflows that are important for early detection and intervention. And we can also leverage the other IT capabilities we have available at our hospital to deliver this to clinicians. So armed with this prediction model, with information that is objective, reliably updated, and made available to not just the physician, but the entire clinical team, we can now ask, what new structures, processes, and patterns of care can we enable? What new roles, team dynamics, and cultural changes around care can emerge from a system that is enabled by AI? We are excited to find out, as we are actively working on designing and implementing such a system to fight the COVID-19 pandemic at Stanford Medicine. Thank you for your time.
Thank you very much, Ron, and thanks for your work. Our next speaker is Fei-Fei Li. She's at Stanford University, and she'll be talking about AI-assisted elderly care for acute infection and chronic disease.
Everyone, it's really a true honor to be here to share some of our research thinking on how we can help our aging population to cope and combat the COVID-19 pandemic. Our research is still very preliminary. We've spent the last several years looking at how a set of AI technology could help aging seniors to live more independently and cope with chronic disease management. But recently we realized the same technology for longer-term care might also be helpful for seniors in this acute pandemic. And this is what I want to share with you today. First and foremost, I want to acknowledge the researchers and partner institutes. Our team is consisted of clinicians and computer scientists working closely together. The one person I want to highlight here today is Alan Luo, a second-year PhD student at the computer science department at Stanford. Everything I'm presenting here is part of his current research. One thing that is most heart-wrenching when we hear the worldwide news about COVID-19 is the human losses and suffering. Here, a son recounted a chilling story of his elderly parents suffering high fevers at home in Italy for 8 days before passing away with coronavirus without proper medical help. Indeed, while we still don't know much about the nature of coronavirus, one thing we're seeing from studies like this is that this virus hits elderly population harder than the younger ones, both in terms of infection rate as well as fatality. The red bars here show drastically increasing fatality rate as the age increases. Exactly why this is so is still subject to further scientific studies, but doctors and researchers are conjecturing several factors that might contribute to this pattern. For example, most seniors have base health conditions that make them more vulnerable. Community living of many seniors enable a faster spread of this highly infectious virus. Seniors also interact with caregivers who tend to be of a younger group and might carry the virus without symptoms. Other reasons may also include challenges of medical triaging or lack of care for the base chronic disease due to the overwhelmed healthcare systems. So one of the key questions all of us want to ask and find solutions for is how we can take care of seniors while keeping them safe. Well, nowhere is safer than home if one doesn't need to be in the hospitals. So how can we help seniors to stay at home, yet help to continuously monitor early symptoms for infection or progressions of mild symptoms, and or even continue to manage their base chronic health issues? A potential opportunity is to use AI-powered smart sensor technology. The idea here is that sensors installed at home can help families and clinicians keep track of the health conditions of the elderly in versatile and scalable fashion. Here's how the system works in a 4-step overview. First is collecting data by putting sensors at home. This table shows various kinds of smart sensors. They complement each other in modality and the kind of data they capture, but also in sensitivity with respect to privacy. Camera sensors carry a lot of detailed information of a person's activity, but is least compatible with most people's privacy needs. Other sensors include depth sensors on the second column, thermal sensors on the third column, as well as wearable sensors in the last column. Since we're interested in understanding more nuanced and complex human behaviors relevant to clinical outcomes, our research focuses on the first 3 types of sensors. Now, in the second step, sensor data are transferred to some kind of secure central servers for machine learning and training. We need to address security issues in the transfer itself, but I won't elaborate here due to time limit. Then AI models are trained to recognize clinically relevant patterns, including respiratory, sleep, dietary, and other behaviors. These AI models can be then installed on the edge devices themselves, so that in deployment time, data no longer has to leave the house. Last step is to set up a way to communicate the smart sensors detection results to caretakers and families. This is a quick summary of how this technology works. Now, let's look at a few examples of the kind of useful information we could glean from these sensors. We show 4 examples: infection detection, mobility analysis, sleep pattern analysis, and dietary pattern analysis. Here's some sample images revealing fever detection or respiratory pattern recognition using thermal sensors. Such information is useful for early detection of infection. Here is an example of human movement understanding, an important clinical indicator for many relevant illnesses, and something doctors would like to keep a close eye on. Using depth sensors that protect privacy, our preliminary work show high accuracy to discern different types of movements. Another example is sleep pattern analysis. Last but not the least, smart sensor technology could also reveal important information on dietary patterns, from eating to fluid intake to pill consumption. One of the biggest pain points in our medical system in times like COVID-19 is the lack of caretakers due to a huge increase of healthcare system overload. These are just 4 concrete examples of how these sensors can help lending a hand to our clinicians in helping and protecting our elder population. They're not meant to do diagnostic decision-making or to replace clinicians, but they can be there continuously to keep an eye on our aging population living at home and help to raise timely alerts to clinicians and families. Of course, for every step of this research
1 minute.
and the deployment of this technology, we have to be very thoughtful of the ethical, privacy, and security challenges. We won't elaborate these points here, but we want to put them front and center as part of the ongoing research. So in summary, AI-powered smart sensor technology can provide an opportunity to help keeping our elderly population at home, while helping our families and clinicians to continue to monitoring their health conditions. This is not only critical to help maintaining social distance of this more vulnerable population, but also helps to mitigate hospital overload. Beyond COVID-19, the same technology can help seniors to live at home with continuous assistance, can participate to help manage chronic conditions, and can also be useful for physical rehabilitations. Thank you very much.
Thank you so much, Fei-Fei. And of course, it's great to see this system, which would be needed even without the COVID epidemic and pandemic. So very inspiring work. Our next speaker is Binbin Chen. Binbin is a MD PhD student at Stanford, and he'll be discussing identifying COVID-19 vaccine candidates with machine learning.
Thank you. My name is Binbin. I'm a recent PhD graduate from Ross Altman's lab. My previous research work focused on using machine learning to understand human immune system respond to cancer as well as vaccines. Thanks for giving me this opportunity to give this talk about our computation pipeline to identify vaccine candidates for COVID-19. Most of vaccines are dead pathogens or components of pathogens we can use to train immune system to get ready for real infection. We consider vaccine is one of the most powerful weapons against a pandemic like this. Not long ago, in 1950s, millions of Americans suffered from measles. Introduction of measles vaccines drastically reduced the incidence of measles in the US. Unfortunately, no vaccines are available for any form of coronavirus today. The key question we want to answer is that, what do we put into a COVID-19 vaccine? The short answer is components of viruses trigger immune responses. However, the field still has limited immunology data on COVID-19. For today's talk, I will show you by combining immunology principles and the machine learning tools, trained on a wide range of known pathogens, we can predict immunogenic components of a virus. How do our immune system fight off a viral infection? First, B cell can produce antibodies binding directly to specific parts of a viral protein. It can potentially stop entry of viruses into human cells. We call parts of viral protein to be targeted by a human antibody B cell epitopes. However, what if viruses have already entered a human cell? Fortunately, human cells have machineries called MHC to present fragments of viral protein on their surface. T cells can recognize those viral protein fragments on a cell surface and destroy infected cells to stop viral infection. We call a viral protein fragment presented and recognized by T cell epitopes. Ideal COVID-19 vaccines should contain both B cell and T cell epitopes. Researchers, including our lab, have developed computational tools to identify these regions. This COPE-TOPE is a linear regression model to predict where antibody binds based on structure of a target protein. Maria, NetMSP PAN are two neural networks trained on a wide range of pathogen data and as well as human data to identify the region can be presented by human cells based on their sequence features. So we can run these computational tools on the whole genome of novel coronavirus. The viral genome is a single RNA producing all pathogenic protein, including spike protein. You'll hear me talk a lot about spike protein today because it enables the entry of virus into human lung cells. Human ACE2 cells are protein present in human lung cells and tightly bind to viral spike protein. This interaction is essential for the virus to enter human cells. An antibody targeting this interaction will have desirable outcome for a COVID-19 vaccine. And I show the human ACE2 protein in yellow here. We first ran this COPE-TOPE on the whole spike protein. The red region indicates the likely binding sites of human antibodies. We predicted the two top epitopes near residue 440 and 494. We ran the exact same computational pipeline using a structure solved by an independent lab and to predict the same epitopes. Further, this antibody binding site predicted sits between human ACE2 and the spike protein interface. So binding to this site is likely to block viral entries. Last week, researchers in Shanghai validated our prediction using antibody isolated from COVID-19 patients. We did similar analysis for T-cell epitopes of viral protein with our pre-trained neural network, Maria and the NetCPAN. Blue colors indicates how likely this protein fragment can be presented by human cells. What we want to use for vaccines are regions with consistent dark blue colors. For example, here I show you this 9 amino acid long fragment can be presented by 65% of common MHC on the cell surface. You can find more details in our manuscript online, and we show our computational methods works well for historical SARS data. The last table in our manuscript summarizes our top candidates for potential COVID-19 vaccines. 5 out of 13 candidates are from spike protein. Some of our candidates not only look like SARS fragments, but also trigger antibody production in the previous SARS studies. In conclusion, spike protein contain both T-cell and B-cell epitopes. Anti-spike antibodies from patients likely block the viral entry. There are at least 4 spike protein-centered vaccine pipelines are under development. We will monitor closely for the clinical outcome of these trials. For researchers who want to go to beyond spike protein, we provide a comprehensive list of candidates for either vaccine development or understanding T-cell response in COVID-19 patients. With that, I would like to thank all of your audience again, my team, my collaborators, and my funding source.
Thank you very much, Binbin. We are all very much looking forward to the arrival of the vaccines, and we are grateful for the efforts of you and everybody else working on that. Our final speaker is Stefano Renzi. Stefano is a research engineer at Stanford, and the title of his talk will be Repurposing Existing Drugs to Fight COVID-19.
Hi, Russ. Thank you for the introduction. Okay, so COVID-19 is a global pandemic that's already killed over 40,000 people, and it threatens to overwhelm healthcare systems around the world. Now, we desperately need treatments for it, but we don't have the 5 or 10 years that it normally takes to develop a new drug and get it into clinical trials. Now, the fastest way to develop drugs is to repurpose existing drugs that are already on the market or in clinical trials. The big advantage of this approach is that you can leverage a lot of work that's already been done. These compounds have already undergone extensive testing, and we know a lot about their safety. So if we have good reason to believe that they're effective, we can advance them into clinical trials almost immediately. Now, today, I'm going to talk about some work we've done using natural language processing, protein structure prediction, and biophysics to identify drugs that can be repurposed to fight COVID-19. So the first thing that we did was mine the literature for therapeutic targets. The goal here was to develop a working hypothesis. What protein are we going to target? Why do we think it would be effective? And what evidence do we have that this therapeutic strategy would actually work? We did this using a tool that we developed in our lab called Docs2Graph, which uses natural language processing to generate a map of relationships between chemicals, diseases, and genes discussed in a corpus of documents. Here, the document corpus that we used are the abstracts from the top 15 articles returned by a PubMed search for SARS and all the articles that they've cited. The genes are green, chemicals are yellow, diseases are red, and the size of each dot represents its importance in the corpus. Now, the thing about the maps generated by our tool is that they also work as a content indexing system that lets you drill down on documents and even individual sentences of interest. So when we click on this gene TMPRSS2, we get sentences that tell us that it is a host protease expressed on the surface of cells that line the airway. It activates a mild human coronavirus, 229E, by cleaving the spike protein, has been shown to facilitate the spread of SARS and Middle East respiratory syndrome coronaviruses in the airways of mice. So now we have a promising target and a mechanism of action, right? This gene or protein, TMPRSS2, cleaves and activates the coronavirus spike protein, which allows it to bind its receptor ACE2 and enter the cell. We want to disrupt this process by inhibiting the activation step. To do this, we need to find existing drugs that can bind and block the active site of our target, TMPRSS2. We decided that the best way to do this, given the available resources, was to use a biophysical model to model the binding interactions between our target protein and potential inhibitors. So here, what I'm showing you is an ensemble of homology models that we generated for our target. You see, the actual structure of the protein is currently unknown, so we had to use computational models to make predictions about it. And to do so, we used the known structures of closely related proteins as templates. So you can see here that all of the models align pretty well with a little bit of variability in the loop regions around the active site. Now here, I've highlighted the active site of the protein. This is the part that catalyzes the activation of the coronavirus spike protein. Now we want to block this with a small molecule inhibitor. And here you can see a close-up of a small molecule inhibitor that is happily bound in the active site of TMPRSS2. And finally here, if you look at the dotted lines, these show some of the physical interactions between the active site and the inhibitor that keep it bound in place. So these are the interactions that we're going to be modeling in our biophysics simulations. Now, the type of simulations we're going to use are called molecular docking. And basically the way this works is that you take a potential inhibitor and you jam it into the active site, and then you look at how well it fits, as well as the number and strength of physical interactions. Doing this, you can use some principles of physics to calculate the binding energy, which indicates how strongly that potential inhibitor is going to bind the active site. So we did this for 18 molecules in total. 3 of them were designer chemicals that are known to be very potent inhibitors of TMPRSS2, and we used these as positive controls. The other 15 were our most promising repurposing candidates. So this slide here shows the results of our docking simulations. The horizontal x-axis shows the binding energy. Negative scores, so things on the left side of this graph, are good. They indicate tight binding. Each entry on the vertical y-axis is a compound, and the box and whisker plot associated with each compound shows the distribution of binding energy scores from docking simulations. So here we've highlighted the 3 positive controls in red, and they all rank very highly, which is good because this is what we would hope to see if our simulations are working properly. We also see that some of our repurposing candidates, which I've highlighted here in green, have binding energy scores approaching the positive controls, which suggests that they can also be potent inhibitors of TMPRSS2. Now, out of these top 6 candidates, 3 of them are currently marketed, meaning that they've been approved for use in humans and they're being prescribed to patients for other things. The other 3 are not approved, but they've made it pretty far into clinical trials. So while they're not available for prescribing, they've already been cleared for testing in humans. Now, as it turns out, this candidate here that I've highlighted in red that we predicted to be a potent inhibitor was reported to inhibit entry of the Middle East respiratory syndrome coronavirus into human lung cells, and it's currently being tested in clinical trials in Japan. So that's pretty exciting for us. One thing I would like to make very clear is that these are preliminary results. When you look at the hierarchy of evidence, computational predictions are pretty close to the bottom. You can use them to figure out what experiments you should do in cells and mice, but it would be very irresponsible to test these compounds in humans without further experimental validation. That being said, we're very excited about these results, and we're currently testing our candidates in cell models. I would like to acknowledge the organizations that fund my work, as well as my co-authors, current and former lab mates, and a long list of researchers at other institutions who I've had the pleasure of working with. Thank you very much. And if there's any time left, I would be happy to take a question or 2 from the moderator.
Rob, we have a tradition now. I'd like to know if you'd like to ask the first question.
Please. Well, I'm going to take up the mantle of the kind of layperson amongst this otherwise pretty technical panel, appropriately technical, unapologetically technical. But since I my disciplinary training, as I've mentioned already, is as a philosopher. I have a little bit of social science chops. I want to ask a layperson's question for the AI ML community that's assembled, especially on this panel. And it has to do with the following observation. I don't think it's especially controversial, which is that the amazing power of AI and machine learning is to find these patterns, patterns that humans would not be able to pick up on their own in enormous pools of data. And one other way to put this is that whatever the outputs or predictions are of some type of machine learning tool is based upon the past, based upon history, based upon the data that's in the training set. And of course, COVID-19 is something novel. What gives a machine learning expert, someone doing the computational work here, the confidence that these particular tools, which are generating predictions on the basis of the past, will continue to be as powerful and as reliably predictable when it comes to confronting the novel coronavirus?
Anthony?
I think there's limits to, I think that machine learning can be useful in places and is not going to be terribly useful in places. So it's going to be useful if we want to study, for instance, like one of the projects we're doing is trying to figure out, based on where we are today and differences in transmission rates up until this point, machine learning has the potential, I think, to be very good at picking that apart. However, if there is a policy lever that hasn't yet been applied and it gets applied next week, machine learning is going to be pretty much useless in figuring out the impact of that policy lever. And so I think your observation is spot on. And really what it points to is the places where machine learning can be helpful and can't be helpful in the battle to get on top of COVID-19.
Ron?
That's a great question. And I can offer a clinical perspective as we're trying to use machine learning for clinical care. And it's true that we don't have too much experience with COVID-19 patients, although we're finding that we're rapidly gaining experience, unfortunately. But I also think that as a clinician, I also don't have experience treating COVID-19 patients outside of the few weeks that we've treated them. And we also are finding that they are, yes, different, but not that different from other patients who are very ill. So I think what we're starting to see is, yes, we have these models that may not be perfect in predicting specific outcomes among COVID-19 patients, but they're good enough. And the benefit of having a machine learning model is that it also learns very quickly. It can learn over thousands, hundreds of thousands of patients, when as a clinician, I can only learn from the limited patient population I see, and also that it can do things at scale, something that humans can't do. So I think we'll start to see these models getting better, but also I think we can't let the enemy of good, or enemy of good can be perfect, and perfect be the enemy of good, excuse me. And I think at this point, our challenges are real. They're here right now. So I think we just have to use what we have.
Fei-Fei?
Yeah, so first of all, I want to thank Rob for asking this question. It's really important that we don't overhype any technical tools, and it is important to recognize the limits of machine learning and AI in today's capabilities. So our work doesn't directly deal with the disease itself, but rather human behaviors that is in assistance to clinicians' care for our patients or aging population. But one thing I want to add here, which is a bit of a call to action to machine learning community, is that there are many interesting and important problems and cases where it is indeed the long tail events, the few shot learning scenarios, the rare event scenarios that are really critical. And having been worked in clinical setting for the past 8 years, whether it's a fall detection for aging seniors, or a spike in fever in the long evening, or a oddity in dietary pattern, all these tend to be small data events. But yet, with the right development of machine learning, where we're looking at few shots learning, we're looking at long tail rare event recognition, these are opportunities that technical solutions can participate in addressing these issues.
When you say few shot learning, just to clarify, you mean examples where we've only seen a few pieces of data versus tons of data and yet still need to learn?
Yes, thank you, Russ.
So we do have some great questions from the audience. So actually for Fei, there's a lot of excitement about your models, and people want to know, are they being deployed right now? And is there a way for them to validate how well they work specifically for COVID, kind of building on the last question in some ways?
Yeah, thank you. So what I presented is a set of basic science research that has been going on at Stanford in collaboration with our medical school. And from a research point of view, we are focusing on writing academic papers and getting the academic projects going. But I'm aware that there is actually Stanford spun-off entrepreneurial opportunities that is actually using the published work we have done and deploying similar technique in COVID in COVID pandemic situations globally now, internationally, and helping hospitals to combat say PPE gearing issues and patient monitoring issues. So I'm aware of this work, and we can take some of the specifics offline. But this is a very good example of basic science research ramping into real world application in a time of crisis.
Let me just say, Fei made reference to offline. We will continue to update our resources page for this conference so that papers and websites that might not be on there now that come to our attention during the meeting will be added in the coming days. So it'll be hopefully a living resource. Another question for Kristen is you showed some really interesting data about the genome and its mutation over time. Is there any prospect for linking those mutation data with clinical data so that you can tell if some variations are more severe than others, and that kind of clinical genomic correlation?
Yeah, that's an excellent question. Most certainly. So as it relates to the functional genomics platform, we really focus on the genomic information. And as far as the clinical metadata, that's something that, of course, has tremendous patient privacy on, right? But there are initiatives, for example, the GIS-AID, who do aggregate that information, and we provide the unique identifiers to link out to those type of references. And that way, individuals in their research portfolio can say, okay, I'm looking at specific trends in regionality, in age, and some of these different patient metadata attributes, and link into that as well. As it relates to what we are able to provide to the community, because of the sensitivities around patient information, we don't redistribute that information, but it does exist in the public space where people could then link out.
And the other question, just as an add-on that came in, was a question about whether any of your code or data at the genomic level is available for sharing and collaboration.
Yes, it very much so is. Yeah, so if you look at ibm.biz/functional-genomics, and I can add that to the body of resources that you're putting together.
Yes.
We have a public landing page. It has some description on there of the data itself. We have some example code notebooks on public GitHub and those type of things. And we want to open this to COVID researchers. And having data that sits inside a bunch of walls doesn't help people. And so we want to get this out to the community and really help accelerate research at an unprecedented time of a huge global health challenge.
Great, thank you. Ron, a question came in for you. Could you address the ethical issues of machine learning-based triage for treatment access and resource allocation? It was mentioned in some of our earlier sessions, but it sounds like this might be something that you're dealing with head on.
That's a great question and a tough one to answer. I think that, people are reading about stories, right, in Italy and now, unfortunately, in New York about even things like rationing ventilators. Fortunately, we don't have that situation here. And I think what we have to be attentive and careful about is the systems we're designing are very much human-driven, but augmented by artificial intelligence. So as physicians, as other healthcare professionals, we kind of take on the responsibility of navigating through these challenges because they're so complex. Unfortunately, I don't think at this point I would trust a machine learning model to make these high-stakes decisions without human input. So it has to depend on the situation, but that's exactly why we're designing whole systems of people, of teams, and machine learning models rather than having any kind of automated triggering of critical decisions with just a model itself.
Great. That makes perfect sense at this point. Bin, this is a little bit related also to the question we asked Kristen. For vaccine development, how do we monitor viral mutations to make sure that our vaccine remains valid even in the setting of mutations over time of the virus?
I think it's very relevant for any vaccine development because viruses are different. If we talk about influenza, it will be irresponsible for me to not talk about mutation in my talk. Let me see if I can share my slides. Can the audience see my slides right now, Russ?
Yes, I believe we can.
So fortunately,
very impressive.
Thank you. Fortunately, coronavirus, its own RNA polymerase is reasonably stable as they have poor reading abilities. So mutation rate are relatively low in the sample we saw. So most of the patients only carry 0 to 3 mutations compared to reference. So our lab designed analysis first in February. In the important spike region, we see almost no mutation. Then almost 2 months later, we only see probably 13, 14 mutations in the spike region intact with human ACE2. So we have certain confidence if we have a vaccine, it will cover most of people, specifically for spike protein. And another idea we are floating around is maybe we should be collecting samples from the community so we can track the mutation profiles in real time.
Thank you. Thank you. Stefano, a question came in on your slide with all of the whisker plots. It looked like the error bars in your plots were pretty wide. And so the question is, why are they so wide, especially for the repurposing candidates where it might dip into the range where you're not so excited about it?
Yeah. So I would say that there's actually really one protein, one homology model that caused a lot of the outliers. And this one in particular was a little bit funny because the template structure we used was bound to a very abnormal ligand. And this ligand actually changes the binding pocket when it binds in there. So it looked very different from anything else. And it was somewhat of an outlier. And that's where a lot of those came from.
Great. This is a question that was originally focused to Ron, but I think you may all have ideas about this. We've heard in this session and also in the previous sessions, Ron, about a lot of people volunteering to help, a surge, if you will, of technical skill and enthusiasm. The question is, has that been useful to you? Do we still need people to volunteer? And if we do need people, and this is for all of you, what areas do we really need people to step up who have specific expertise that might be useful either in your work or in the work that you know about? We'll start out with Ron, but I'd love to hear from all of you.
Thanks, Russ. Well, I certainly can't speak for the entire medical community, but I will say we certainly have witnessed a tremendous number of volunteers. And I think this is a testament of crisis actually invoking good, right? I think things that we haven't really done before, and invoking a sense of solidarity that really means a lot to us as frontline healthcare providers.
But are the volunteers, is it easy to manage them and figure out how they can help? Because there's a certain overhead just in dealing with a volunteer, and you have to make sure that the time it takes to get them up to speed is worthwhile compared to the other things you could be doing.
I think it has to be problem driven. So, I think the healthcare organizations of Stanford Hospital, they've done a good job setting the key priorities. So for example, the PPE shortage, right? So we've had actually an inflow of volunteers from including medical students, members of the community to source PPE. I know Nigam Shah has created a data science group and many students have volunteered for that effort. So I would say that volunteers are great. I think we certainly welcome help, but I think it is also our responsibility as health organizations and others on the front lines to set the priorities, define the problem, and I think then the volunteers will come and we'll be successful together.
Fei-Fei?
Yeah, thank you for asking that question, whoever in the audience, and Russ. I would really like to call on the worldwide AI computer science technical talent to be interested and participate in healthcare research. We've been doing this for the past 8 years. What I find is that, in my own group, we have both basic science AI and AI in healthcare, and it's much more easily to get students interested in so-called normal AI, computer science AI, compared to students interested in healthcare and AI. But there we get to solve so many of these really global, important, sometimes acute, like COVID-19, but sometimes just long-term human problems. And we really need that global talent of machine learning students, AI students, to participate in us.
Stefano, you made a bunch of computational predictions, which are great, but as you pointed out in your talk, they require the cellular and the animal models. Any movement? Has there been any uptake of your predictions in terms of moving them forward and evaluating them?
Yes, so we are collaborating with several different labs on validating these predictions. We have somebody who's doing direct binding assays for TMPRSS2 with a bunch of these compounds. So this isn't necessarily a cellular assay where you're measuring the effect on the cell, but we're directly measuring the binding of these agents to the protein. And then we are also collaborating with some labs that are doing cell entry assays where they're testing to see if these compounds are able to inhibit the entry of the virus into cell models.
Great. There's a question from the audience about whether are we making sure that we, for these interventions for predicting, detecting, and understanding the distribution of interventions, is anybody making sure that the things that we do are not actually harming? There have been cases in history of medical interventions that we thought were good, but turned out to be bad. I don't know if I've heard about any yet, but I'm wondering if any of you have seen signal in that regard. Silence would be good in this case. Oh, Ron?
Well, I won't say that I've seen signal of things harming, but I will say that the types of studies, especially in my area where we're implementing machine learning models, I think you'll see types of studies that go beyond just looking at model performance, but really looking at the implementation effects of the systems. I mean, there is the whole area of implementation science that I think will be really important here. And we'll have to look at not just clinical outcomes, but how these interventions affect teams, culture, workflows. It's very complex, but I think altogether this will help us understand what actually happens in vivo, if you will, when you have an AI system taking care of patients.
Great. Let's see. I don't know if anybody wants to comment on this, but one question comes in. Some news sources are reporting that countries that use the BCG vaccine, this is a vaccine that is used to prevent and provide protection against tuberculosis. That it is not routinely used in the United States, but there are some reports that the BCG vaccine may be helping lower COVID-19 infections. I don't know if anyone has anything to add about that. Bin?
So one sentence summary is no one really knows. There are actually clinical trials running among healthcare workers to see if BCG vaccine can protect them, but there's like way conclusive data on this topic right now. But one thing I want to cautious is this study suggesting different brand of BCG vaccine, depends on where it's manufactured, affects the outcome. So we will like, if there's new paper come out, you should like take a grain of salt about where the vaccine is manufactured.
One question I wanted to ask Anthony is, and related to the Fei-Fei's comments a moment ago, it is quite inspiring to see the computer science AI community throwing themselves at the Kaggle challenges. But if I remember correctly, at the very end of your talk, you made a call for some domain expertise. As I recall, you wanted some healthcare people, and I can't remember the categories. Tell me about the challenges in getting people who have skills in one area to make sure they're asking the right questions in a new area. And tell me why you're asking for those experts and what you're going to do with them.
Yeah, for sure. So we've had a small number. When the first challenge was launched, we had a bunch of people with public health and epidemiology backgrounds jumping into our forums. And that has had a really large impact on focusing people on some of the right, on solving more useful problems. So I'll give you a concrete example. Our this automated literature review is turning up lots and lots and lots of papers, and very often with conflicting results. You know, the mean incubation period ranges from 3 days in one study through to 7 days in another. You hear of incubation periods up to 33 days long. Like, how do you know which study to trust? There's a particular epidemiologist, her name's Savannah Reed, who's been very active in the forums, who's been educating our community on the levels of evidence that are typically used in medical studies. And so now people are mining the papers, not just for the conclusions, but also for what level of evidence the paper was based on. Another big focus is mining the papers for how large the sample sizes are, for instance. So if the evidence is a randomized control trial, how large is the sample size? And so this automated literature review is going from just dumping out the results in a way that is sort of hard to figure out which studies do you pay more attention to and which do you pay less attention to presenting results in a way that they are going to be more useful to those making decisions. And I give that as one example, but there are so many ways where people with domain expertise like Savannah have been useful. And my pitch is that a small number of people with domain expertise, we have probably over 10,000 people playing with our challenges at the moment. A very small number of domain experts can have a very large impact on what this community of 10,000 people end up focusing on and how useful their work is.
Fantastic. Very, very useful, very helpful. Stefano, as our drug repurposing person, there's been a lot of questions on the chat line about hydroxychloroquine and other remdesivir and a bunch of other repurposing candidates, which you didn't mention because you were focusing on the one protein that you've been working on. We also heard earlier in the day at least one case of a couple that seems to have self-dosed hydroxychloroquine with very bad outcomes. I don't know if you have any thoughts about this repurposing enterprise and the trade-offs between not wanting people to poison themselves and yet getting information out to the physicians about drugs that may be helpful.
Yes. I mean, that's a very difficult question, right? Because a lot of times you might have something that you're very excited about and you want to communicate that to the scientific community so they can do testing. However, people will pick up on it and then they might start taking the drugs themselves. And these are untested drugs. So they might be giving them to sick people or they might be taking them when they're ill. And, they just might not work or they might have dangerous side effects. So a bunch of the drugs that I highlighted in my talk, in fact, had some pretty nasty side effects like hemorrhages and uncontrollable bleeding. So you wouldn't necessarily want to give that to somebody unless you were pretty sure it was going to work. One of the pains that we took in our slide was to actually obscure some of the names of the drugs because we didn't necessarily want to get them out there unless they've been tested and put that out there. And, I think it's just a really tough issue. We also ran into this when we were publishing the preprint. We sent it into bioRxiv and they did not want to publish a preprint that was based for repurposing that was based on just computational evidence because they were worried about exactly this. And we ultimately had to go somewhere else. And, it's just a very difficult issue. You don't want people doing harmful things and you don't want to be inadvertently spreading misinformation if your predictions are wrong. On the other hand, you also want to be able to communicate your findings to other scientists so that they can test them and vet them and find out if they're right or wrong.
Can I ask a question in that general spirit, which is we sometimes hear about the FDA or other bodies which control research and trials, IRB processes internal to universities, loosening restrictions in the face of the emergency. I'm wondering for any of you who are hoping to go through an IRB for the coronavirus or FDA actually deploy animal or human subject trials, what's your view on whether or not the current types of regulatory arrangements are right for the moment or not?
So I'll take a stab at this one. I mean, I think that we are in very extraordinary times. So, we need something fast and, this is an emergency. So there has to be some kind of allowances made to get these drugs to the front line very quickly. I think for purposing candidates, they already have some machinery in place that lets you skip some of the preclinical work and some of the early studies that you need to do because these have already been done. So there's kind of some stuff that's been proven in this domain. I see that Ron is raising his hand.
And then we're going to bring our session to a close.
Okay.
Ron, please go ahead.
Sure. I just wanted to say that the existing structures, processes for testing drugs in clinical trials, they're happening right now. Stanford is a site for remdesivir. In fact, our group is conducting one of these trials. It's happening all over the country. So I think things are happening. I will say, though, that some of the lower hanging fruits that we can solve probably aren't even regulatory, but just process. I mean, running a clinical trial is really tough just because even things like how do you consent a patient? Can you consent a patient remotely, right? What IT systems can you use to do that? I mean, these are all very boring things, but you could actually make a huge difference in the speed at which you conduct a trial. So I think these are things we're working on now at Stanford and I'm sure at other places. And I think we'll see some, potentially some results in the future.
Okay, well, I think this ends our panel. I am very grateful for all of your comments and talks. If I could ask you to please leave the Zoom in the most respectful way possible, Rob and I will go right into our wrap-up session. So thank you very much, panelists, and please feel free to leave the Zoom.
Thank you, everyone.
That wasn't my smoothest moment, perhaps. Okay.
That was great. Yes. So, we've had a long day and we've learned a lot. I kicked the day off by saying something about how universities are notoriously oriented towards long time horizons. We work in a way which is rarely oriented to doing something quickly tomorrow in the face of an emergency. And when these occasions arise, it's inspiring to see people from all across the university in different places with different types of disciplinary expertise, bringing that expertise to bear on an urgent problem. And I'll add that I didn't think that anything we learned today would yield actionable advice for anyone listening for what to do tomorrow. Although we did hear that wearing a mask is indeed possibly a recommended activity, even if you're asymptomatic, even simply going out in public. So there was one very practical thing which people could do tomorrow. But don't use one of the N95 masks. Use one of the ones that you make for yourself at home.
And we probably should wait for the CDC to press submit on that.
Correct. We want to look at CDC. In any case, practical stuff is very often what we will hear about from other trusted sources. And we've heard a whole array of different things today. We begin with a health crisis. We also know it's an economic crisis. It turns out it's an information crisis. It's a social crisis. It's a political crisis. There are all kinds of opportunities, of course, in crises. And by working together across disciplinary lines, bringing minds together from within the university and outside the university to tackle big challenges, well, that's the sort of thing which keeps me hopeful. And that's one of the main things I'm taking away from today.
I totally agree. I think we saw that the image of universities as an ivory tower, while sometimes it's true, there are people who have jumped off the tower and who are in the fray. Let me just, if I can, say a few things to close. We plan to make this entire broadcast available as a recording. So if you missed any of it, don't worry, it'll be available soon. If you're on our HAI mailing list, or if you registered for this event, you'll receive that link by an email when it's available. In the meantime, we'll post updated sections and resources about the information that we learned today, so that resources page should be a living document for the next few days or even weeks. If you registered for our event, you'll be receiving a survey. As many of you know, registration stopped for technical reasons last night. So for the subset of you that did get to register, please tell us your opinions on how we did and what was useful will be very valuable to us. Thank you again for making time to listen to our research today. All of us at HAI are worried about the pandemic and wanted to do something to help. We hope this was useful. We want to thank Stanford Video for its support. And really, from the Stanford Institute for Human-Centered AI, we want to thank you for your participation, and we wish you all the best in terms of your health and your safety. Thanks.
Thank you.